Good morning, everyone. I am Dr. Saurabh Damani, consultant gastrosurgeon at Shelby Hospital, Ahmedabad, and I will be your host for the day. I welcome you all on behalf of Dr. Ashish Solanki and the entire GastroPlus team to Laparoscopic Education Awareness Program Leap 2025. We will be starting the program with welcome address from Dr. Ashish, whose hard work has made this entire event possible.
Thank you, Saurabh. Good morning, everyone. Welcome to this GastroPlus Leap Minimal Invasive Colorectal Surgery virtual live workshop. Now, we surgeons devote a lot of time to learning technique and acquiring new skills. And it stands to reason because we are judged by our operative skills. Hence, workshops like these are very popular, where a master presents his technique and skills, and we can pick up the tricks of the trade from him. And this aspect is missing in those YouTube videos. And we know the problems with all live operative workshops. So I thought that this could be a good compromise between live operating workshops and lecture-based discussion and teaching. I've said this earlier as well, that there is now level 1 evidence that minimally invasive colorectal surgery has proven benefits over open surgery, and therefore the onus lies upon us to pass on these benefits to our patients. So I hope that our endeavor today will facilitate this process. With this, I welcome all the delegates who have not only traveled from major cities and towns of Gujarat, but also from far-off places like Mandya, Karnataka, Srinagar, and Mumbai. I hope they will be joining us soon. I also welcome all the faculties and PG teachers from various medical colleges of Gujarat. Wish you a fantastic day ahead of meaningful and fulfilling learning. Thank you.
Our first session is Back to Basics, and our first speaker is Dr. Harsh Shah, who will be talking on minimally invasive colorectal surgery, relevant anatomy and approach to surgery. Dr. Harsh is a consultant GI oncosurgeon at Apollo Hospital, Ahmedabad. I would like to invite Dr. Harsh on stage. I would also like to invite the chairpersons for this session, Dr. Nishant Sanghvi, Dr. Bhavin Vadodrea, Dr. Chirag Thakkar, Dr. Hitesh Patel, Dr. Vashish Jalal, Dr. Awadh Patel.
Thank you, Dr. Rasesh, for this kind of opportunity, and thank you, Dr. and GastroPlus team also. I am the opening batsman, as Dr. Rasesh would put it, and let's start today's session. What I'm going to discuss is minimally invasive colorectal surgery anatomy. Majority of the talk will be on anatomy, and there will be last few slides will be on approaches. So we'll be discussing more on clinically significant anatomy and how a surgeon can avoid injuries during the surgery while taking care of these anatomical structures. When we talk about anatomy, these are the basic foreground over which we discuss, like fascias, vessels, lymphatics, and nerves. And I'll be segmenting my talk in all these basic structures. So let's start with fascias. So there are few fascias which are important in colorectal surgery. When we talk about colon, it is more of tall threaded fascia and Girota's fascia. For rectum, as we know, mesorectal fascia, presacral fascia, and there are few important fascias which I'll be discussing. Let us begin with tall fascia. Basically, this fascia is formed. This is different from line of told. Taut fascia is basically a fascia which is a fusion fascia between the mesocolic fascia as well as the Girota's fascia, which is called retroperitoneal fascia. So the blue structure that we see here, so I'm not getting the point. So this blue structure is the fusion fascia of told, and this is the fascia where we enter into our, whether we are doing a right colectomy or left colectomy, we have to enter into this fascia and to achieve an avascular plane. And the line lateral to it is the line of told. As we can see in this picture, this white line is it's the line of told. And once we divide this line, you can enter into this told fascia if you are doing a lateral to medial approach. Basically, it's a continuous fascia. It runs behind the right colon, left colon, going down to the sigmoid colon up to the rectum. So it's a very long, continuous fascia, and it's utmost important for surgical dissection. If you are doing a left hemicolectomy or a sigmoid colectomy, when we are mobilizing the left colon, so this is how the picture looks like. Posteriorly, it is the Gerota's fascia, and superiorly, it is the mesocolon, and which is lined by the told fascia. Let's jump to the threaded fascia. So as we put it, most of the anatomical textbook would put it as submesocolic or pre-duodenal-pancreatic fascia. If we look closely in the picture, so this is the pancreas and this is the duodenum. The fascia overlying this is the pre-duodenal-pancreatic fascia, and this is the visceral peritoneum of the mesocolon. And the threaded fascia that we are talking about is formed by the fusion of this fascia, these two fascia. And if you can see, the blue structure is the, this blue structure here, it is the told fascia. It has got tremendous importance when we are performing right hemicolectomy, because it is the fascia which overlies the head of the pancreas, and when we are mobilizing duodenum pancreas from the mesocolon, we have to divide this fascia and enter into the space of threaded. And once we are into the threaded space, where we will be able to easily isolate the lymph nodes, as well as we can identify the gastrocolic trunk anatomy, which is of utmost importance for right hemicolectomy or extended right hemicolectomy. So if we look into the surgical pictures, the upper one here, we can see this red structure, red arrow is marked at the threaded fascia. This is the duodenum. So we are dissecting between the duodenum and the mesocolon overlying it. And this structure, we have to divide this structure to enter into this space. And this blue arrow is pointing at superior right colic vein. And the similar things are shown in the lower picture. So let's jump on to the rectum, where we are talking about Waldeyer's fascia. It is also called rectosacral fascia, and it's been there in anatomical textbooks for years together. So basically, it lies at the S4 level. It connects mesorectum with the presacral fascia, and it divides the retrorectal space into two compartments. One is presacral and one is precoccygeal. And this is of very much importance, because if the surgeon is performing this going behind the rectum into the TME plane, he has to divide this fascia with scissors, like sharp dissection. So if we don't divide this, then there's a risk of going into the mesorectum anteriorly either, or posteriorly into the sacral venous plexuses. If you look into the surgical pictures, you can see that we have already divided the rectosacral fascia, that is Waldeyer's fascia, and now we are looking into the precoccygeal space. So how is it described is the snowy appearance of the areolar tissue of this precoccygeal space. Once you see this, then you will realize that you have divided the Waldeyer's fascia. Now, let us talk about Denon-Villiers fascia. Denon-Villiers fascia, as we all know, it lies anterior to the rectum, more easily visible in male patients. It separates rectum from the seminal vesicles and the prostate. So in the above picture, you can see seminal vesicles denuded of Denon-Villiers fascia, because our plane of dissection has gone anterior to Denon-Villiers fascia. And if we want to preserve the Denon-Villiers fascia, which is seen in the lower picture, where seminal vesicles will not be visible. So the lower part, where we preserve Denon-Villiers fascia, is more favorable if you want to preserve the neurovascular bundles. In the females also, this is described, the Denon-Villiers fascia, and one can identify this tough structure while dissecting anteriorly in female patients. So as I was discussing about the neurovascular bundle, later on we'll come in the talk about neurovascular. These are the neurovascular bundles which are lying at 2 o'clock and 10 o'clock position anterior to the rectum. And the red line, if we are dissecting in the red line, the green structure is the denonvillous fascia, then we are likely to preserve this neurovascular bundle. And if we are going into that green line, then we may end up damaging the neurovascular bundle, which will result in sexual dysfunction. So this was all about fascias. Now we'll talk about some vessels which are important in colorectal surgery. So these are all vessels that we are going to talk about. First is gastrocolic trunk. As we all know, this gastrocolic trunk is formed anterior to the head of pancreas. It drains into superior mesenteric vein, usually formed by 3 vessels, that is right gastroepiploic, right colic vein, and anterior superior pancreatic duodenal vein. So there was a very good study which is called HELAC trial, which looked into a lot of patients, like more than 500 patients, and all those undergoing right hemicolectomy with D3 lymph node dissections, and where they described the anatomy tributaries of gastrocolic trunk. So this was the result of the trial, that in 14% of the patients, which is called type 0 gastrocolic trunk, there will not be any colic vein, which in 53% of the patient, you will have at least one colic vein draining into the gastrocolic trunk. In type 2, which is 27% of the cases, you will have 2 colic veins. That is either the right colic vein, superior right colic vein, or the middle colic vein draining into the gastrocolic trunk. So basically, these are the 2 anatomies which are very common for, and this is of very much importance while performing right colectomy or extended right hemicolectomy, because more the colic veins you encounter, you will have to divide those many veins, and you are likely to have bleeding from these vessels, and this is one of the most commonest reason of conversion to open. If we look into the surgical photographs, so type 0, which is the first picture, where you can see that this is a superior mesenteric vein, and the Henle's trunk, which is the gastrocolic trunk, is draining, getting the tributaries from right gastroepiploic as well as anterior superior pancreatic duodenal vein. This is the type 0. In the next picture, which is the B photograph, you can see beautifully seen gastrocolic trunk, and which is drained by there is one there is a right colic vein which is draining into it. So if you are doing a right colectomy, you just have to divide that right colic vein and leave rest of the everything below, so that you will get your plane. Otherwise, if you go into the plane of gastrocolic trunk and if you encounter the bleeding, then you might have to convert to open. So similarly, in type C, you can see there are 2 veins draining, 2 colic veins draining, and in the D photograph, you can see 3 colic veins draining into gastrocolic trunk, which is the least common but most dangerous. If we can recreate this picture preoperatively, then it might be useful during the surgical encounter. Now we are going to talk about the more common arteries like ileocolic artery, right colic, middle colic. This is the CT angiography picture of SMA and SMV prior to performing a right hemicolectomy. So what I would like you to focus here is the position of the ileocolic artery and the right colic artery. Mind you, right colic artery is not present in all patients. It is present in only 40% of the circumstances. So it will not be there in all patients, but in all these 3 pictures, you can see the right colic artery. The ileocolic artery goes usually behind the SMV. So that is 55 to 60% of the time, ileocolic artery goes behind the SMV, and 40 to 45% of the time it goes anterior to the SMV. And why I am mentioning this, because in CME with CVL, which is a standard technique in right hemicolectomy, your plane of dissection is over the SMV, that is superior mesenteric vein. And you should know what structures you are likely to encounter while dissecting over the SMV. If the ileocolic artery is going posterior to SMV, then you are likely to encounter vein first. So you are likely to have bleeding from that part. Similarly, in middle colic artery, there are some variations. Type 1 is the most common, which is you have a common trunk of middle colic artery, which divides into right and left. And the second most common, which is type 2A, where you have separate origins of right and left middle colic artery. So, and they are also arising at a different level, which has got some clinical significance. Like we discussed about CME, CVL, the plane of dissection is over the SMV. So you should know if you are going to encounter the trunk of middle colic artery, or is it going to be the right colic artery that you are going to encounter. Like in type B, you will encounter right colic artery. So it will be good if you are performing right hemicolectomy, but for extended right, you will have to go to the left and find out the main trunk and remove the lymph nodes as well as ligate the trunk there. So this is a slightly busy photograph, but I'll take you through this. Just look at the red structures in the first photograph, which are the arteries. In the first upper photograph, you will see there is a common trunk of middle colic artery, which is dividing into right and left. And it's surgical photograph. You can see a middle colic artery, which is ligated over the SMA. In the below picture, the CT angiography picture is showing separate origins of right and left middle colic artery, which are also at different levels over the SMA. So if you are performing an extended right hemicolectomy, you will have to ligate these vessels at different levels on SMA and identify it and ligate it. Similarly, when we talk about left colic artery, so this all, why we are talking about left colic artery? Because those people who believe in preservation of left colic artery in low ligation of inferior mesenteric artery, you have various classifications. One of the famous classification is Yada's classification, where type 1 is where left colic artery is arising as a separate origin from the sigmoid artery. There is a separate trunk of left colic artery, which is the most common. The type 2 is where left colic artery and sigmoid arteries arise as a common trunk. Type 3 is where there is trifurcation, and type 4 where it is absent. So if you look at the surgical photograph, you can see that in the type A you can see the left colic artery. In type 2, you can see there is a bifurcation, and there is trifurcation, there is quadrifurcation. So it will be easy to preserve the left colic artery in the first and second varieties, while in the third and fourth varieties, you will have difficulty in preserving left colic artery. It is also important to know the relationship of left colic artery with IMV, because if you wish to preserve left colic artery, and while you are ligating IMV, you should not accidentally damage the left colic artery. So let me make it more clear like this. So in the first two photographs, first two upper photographs, you can see there is a good amount of distance between the IMV and the left colic artery. So you may get away with ligation of IMV and without damaging the left colic artery. But in type C, you can see the distance between the left colic and IMV is very less, and you may end up damaging left colic artery while ligating IMV here. So there is a lot of talk about arc of Riemann, whether it is present or not, but it is seen that it is present in only 40% of the cases. And the importance of arc of Riemann is only when you have deficient marginal artery of Drummond.
I would request
Okay. I'll make it fast. So, like lymph nodal distribution, you can see there is, as we all know, we have pericolic, intermediate, and central lymph nodes, which are color coded. Red are pericolic, blue are intermediate, and yellow are central lymph nodes. So, which are important to be removed in CME with CVL dissections. Same surgical photographs. So let's skip this. I'll come to autonomic nerves. So this is the left pelvic. We are looking on the left pelvis, where we can see the sympathetic chain is coming from the aorta, dividing into two hypogastric nerves, which are sympathetic in nature. Then it goes to the pelvic plexus, which is where they meet the sacral splanchnic nerves. And so it's a mixed pelvic plexus, which gives rise to neurovascular bundles. And we'll see some surgical photographs where they are likely to get damaged, and we have to preserve the structures there. So you can see this is IM, inferior mesenteric artery origin, and this is the neurovascular bundle. This fourth number structure is the left trunk of the superior hypogastric plexus. So while ligating inferior mesenteric artery, one has to be aware of this structure and try to preserve this. So these are similar surgical photographs where you can see the nerves being dissected, and let me make it forward.
Dr. Harsh,
So,
please conclude.
Yeah.
Please
Yeah. So surgical approaches, I think this is quite straightforward. And
this will be discussed in detail.
yeah, we can discuss. Thank you.
Thank you very much.
Thank you, Dr. Hirsch, for this wonderful talk. We will take questions at the end of first 3 back to basic sessions. Our next session is back to basics in MRI for rectal cancer, and our speaker for this topic is Dr. Tushar Desai, who is a consultant radiologist and MRI specialist at Infosys Diagnostics, Ahmedabad. I would like to in focus. I would like to invite the chairpersons for this session, Dr. Bhavna Parikh, Dr. Monil Patel, Dr. Rutul Patel, Dr. Nirav Vakani, Dr. Janet Gandhi, and Dr. Ishan Shah. No.
Good morning, friends.
We welcome Dr. Kalai Rasan, Professor, additional Professor Jipmer, and he'll be there with us. Welcome, Dr. Kalai.
Hello, hello. Hello, hello. Hello, 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 hello. Good morning, friends. Hello, hello. Look. The question is what a surgeon wants to know. One simple line, can I operate on this case or not? So two major factors which will decide the therapeutic modalities. And MR definitely helps to confidently discuss 2 points which are very important to decide the different modalities of treatment. First of all, tumor location. Location within the rectum, whether it is upper or lower rectum which is involved. Once the location is clear, then they would not to know the extension of the primary tumor and the nodal status and the distant metastasis. So these 2 points which we can very well comment upon by doing MRI, so that would help us to decide which surgical procedure is to be performed. Before that, I would like to throw some light on imaging anatomy, so everybody will be on the same page when we are talking about the definition of anal canal or we talk about the definition of the rectum. Because the definition of anal canal, surgical and imaging, is slightly different than the anatomical anal canal. Like in this, on imaging, a line drawn from the inferior aspect of pubic rami up to the top of puborectalis sling, that forms the superior aspect of the superior border of the anal canal. And the white thing which is seen here, which is an intersphincteric groove, which is the lower border of the anal canal. So in between, this is the anal canal. The surgical and imaging anatomy of the anal canal is same, and it is different than the anatomical anal canal. Like in anatomical anal canal, it is the superior border is formed by the dentate line, and lower border is the anal verge, where surgical anal canal includes the lowermost rectum, dentate line, and anatomical anal canal. So, and imaging also says the same with the anal canal definition. Now, definition of rectum. The lowest part, lowest border of the rectum is formed by the anorectal junction, which is a line drawn from inferior aspect of the pubic ramus to the lower part of the sacrum. The proximal segment, proximal border of the rectum is formed by the sigmoid takeoff. Sigmoid takeoff is the anterior curvature of colon at the level of sacral promontory or the S1. So in between, this is not, we define this as a rectum. Now rectum is further divided into upper and lower rectum with the help of anterior peritoneal reflection. Like in this image, we can see this is a site of anterior peritoneal reflection, and that divides upper rectum and lower rectum. Now further we divide rectum into low, mid and high by measuring distance from anorectal junction. Now if it is 0 to 5, it is a low rectum. It is 5 to 10, it is a middle rectum. And if it is 10 to 15 centimeter, then it is a high rectum. But many times this doesn't correspond with the anatomical landmark because of the variable size of the rectum in a different individual. Another important imaging anatomy is mesorectal fascia. So fascia is snugly and encircles 360° in the lower rectum. At mid, where anterior peritoneal reflection is takeoff, it is only appear on the lateral and the posterior aspect, and in the upper rectum, it is mainly anterior and anterolateral aspect is covered by the peritoneal cavity. Only small posterior portion shows mesorectal fascia. Now I have seen this, I've drawn this green line. This is a complete encircle fascia, which is mesorectal fascia in the lower rectum. And this is at the level of mid-rectum, where it is absent anteriorly, and here it starts from the lateral aspect, goes posterior again. So this is a mesorectal fascia on MRI. Anterior peritoneal reflections, which divides rectum into upper and lower. On the axial T2-waiter images, you can see a bird-like structure, a linear structure, which gives an appearance of like seagull appearance. This is anterior peritoneal reflection. On sagittal images, you can see on the superior aspect of seminal vesicles, there is a reflection here. I have shown with the arrow, this defines the middle rectum. Now this is about the location. So when we write upper, middle or lower, we consider this is the imaging anatomy, and we want to give the same idea to the surgeon when we talk about the level of tumor location. Now it is the extension. So we do staging with the help of MRI, that is T&M staging. Now the T1 tumor is very small tumor, and which involves mucosa and submucosal layer. Now, most of the times, we do not see submucosal layer on the routine MRI. We do see only two layers. Outer black line is a muscularis layer, and the inner line is a mucosal layer or a submucosal combined. Only cases where we have a submucosal edema, we can see three-layer anatomy very well, which is not possible in each and every cases. The inner black line is mucosa. Beneath that, the white area is a submucosal plane, and the outer is a muscularis propria. But most of the times we do not see submucosal plane, so it is very, very difficult for us to say T1 or T2 staging of the lesion only on MRI. The upper rectal polypoidal lesion in this case, which is showing intact muscularis propria, which is a T2 hypointense or a black line. I would say black line. Axial, oblique axial of the same lesion which shows intact T2 hypointense muscularis propria. So it is only involving the rectal wall. And this is also a coronal well. You can see the preservation of muscularis propria. So this is a T2 lesion. You do see some speculations here on this margin. This can be a desmoplastic reaction at the base and may upgrade this T2 to T3 stage. So it may overstage many times. Another lesion where a circumferential mass, thickening of rectal wall with breach of this black line at many places. Even on this side, posterior aspect, we do not see the muscularis propria. And so this is an extramural extension. Anteriorly also there is extramural extension. When it is less than 1 millimeter extension, then it is a T3A. When it is between 1 to 5, it is T3B. If it is between 5 to 15, then it is a T3C. Like in this case, there is a sagittal T2 weighted images where you can see a ulcerated lesion with a large extramural component which has gone posteriorly beyond the rectal wall, very well seen on these axial images, and the extramural component depth is almost 15 millimeter. So this is T3C lesion. I have put an arrow to delineate mesorectal fascia, which is quite away from the extramural lesion. So there is no involvement of MRF in this case. There is another case, there is a large extramural beyond 15 millimeter and involvement of mesorectal fascia anteriorly. This is T3D with MRF positive. Another case of middle rectal malignancy, where is a concentric wall thickening with extramural component at the site of anterior peritoneal reflection, which I have shown an arrow here, and this line suggests anterior peritoneal reflection, which is involved, well appreciated on the axial images, that it involves the anterior peritoneal reflection, and this is stage T4A. Another case where there is a lot of extramural component, direct invasion of posterior wall of uterus, as well as left ovary. I have shown with arrow that left ovary is also infiltrated by the lesion. This is T4B. So tumor extension, depth, involvement is very well appreciated on MRI. Now coming to the two cases which I have shown here. This is a lower rectal malignancy which is showing extension into the anal canal. This coronal image is showing that there is an intact intersphincteric groove and external sphincter without involvement. So this piece of information may be very helpful to the surgeon while deciding on the surgical procedure. Another case of lower rectum which is involving the left-sided levator ani muscle. This will also help surgeon. Now coming to nodal. Nodal is the sensitivity of nodal involvement by metastasis or direct extension is very less on MRI. So we always write it is suspicious. We are not confirmatory on MRI that this is involved or not. Size is a criteria where around 10 millimeter size, rounded appearance, most of the time suspicious involvement of the lymph nodes. Like in this case, there are two nodes, which is mesorectal nodes, and away from the mesorectal fascia. Another case which is abutting the mesorectal fascia with spiculated margin. So this is mesorectal nodes with fascia involvement. Regional nodes, another group, lateral pelvic lymph nodes, which are very important. We are likely to miss these lymph nodes easily on MRI just because of lack of knowledge. This consists of obturator group of lymph nodes and internal iliac group of lymph nodes. Whenever it is present, I think we need to be very careful about, because it is a high risk for local recurrence as well as for the reduced overall survival period for the patient. Distant metastases like involvement of external iliac and inguinal lymph node in rectum, they are like categorized into metastasis rather than regional lymphadenopathy. Another very important finding which we have to mention in every case is involvement of extramural venous involvement by the tumor, because it considered to be the high factor for recurrent disease and metastasis and impair overall cervical survival. M classification is always better with the CT scan. Now restaging after neoadjuvant therapy, because many a times we do scan again for the preoperative assessment in a case of a neoadjuvant therapy, we do mention responses in the three category: complete, good or poor. Complete where the bulk of the tumor has gone and most of the involved area is fibrotic, which is a T2 dark area, and there is no diffusion abnormality on this. 5 minutes more, please. Two cases, another case where this is a neoadjuvant image shows extramural component invading the prostate and peripheral zone of the prostate. After neoadjuvant therapy, restaging has been done where tumor bulk is almost reduced, T2 fibrosis, and the prostate appears to be separate. This is well appreciated. There is a large retroprostatic extramural component which has gone completely after the neoadjuvant therapy. Another case where there is a ulcerative lesion, semicircular ulcerative lesion, and the diffusion is showing a significant restriction and a diffusion abnormality, where after neoadjuvant therapy, the complete bulk has gone, and this appears to be T2 hypointense, so fibrotic wall. There is no remnants of the active lesion, and there is no diffusion abnormality. This gives an confidence that these are the burnt out lesion. So on concluding, MR is more reliable for assessing the depth of tumor penetration into the rectal wall and highly accurate in predicting MRF involvement, which is crucial for the treatment. As I mentioned, T1 and T2 differentiation only on the basis of MRI is very difficult because all three layers are not easily visualized on a routine MRI. Overstaging or understaging because of the desmoplastic reaction, as already I have discussed, and very low accuracy of detecting lymph node metastasis compared to T staging. Thank you very much.
Thank you, Dr. Tushar, for this crisp and precise information for us surgeons and also for sticking to your time for the given topic. We will take the questions after one more session. Our next session is on ports placement and ergonomics in minimally invasive colorectal resections, and our speaker is Dr. Kalairasan sir. Sir is additional professor in the Department of Surgical Gastroenterology at GIPMER, Pondicherry. I would like to invite the chairpersons for this session, Dr. Anand Patel, Dr. Latif Bhagwan, Dr. Ashok Desai, Dr. Manthan Marja, Dr. Avinash Tang, and Dr. Dushyant Bhatt.
Dr. Dhaval Rajdev, would you please chair the session?
Yes, there. Check the connections. I thank Rashesh and his team for the kind invitation. It's always nice to be part of this wonderful academic event. So next 10 to 12 minutes, we'll discuss the port placements, ergonomics, and minimal invasive colorectal resections. So I'll cover both laparoscopy and robotic, and also the commonly performed procedures such as right colon resection and the left colon resections. So if you talk about the right colon resection, that is the laparoscopic procedure, so the patient is placed supine, and generally we operate either from the, mostly from the left side of the patient. So the leg split is not strictly required. However, if you want the assistant surgeon to stand in between the legs, so you can have leg split. So the trocar position, we need to remember, so what each trocar will be used for, and that will help in deciding what is the optimum port position for this procedure. So the surgeon stands on the left side of the patient, and the assistant on the right side. If you have the leg split, the camera surgeon can be in between the legs. So the camera comes through the infraumbilical trocar, and here we place two trocars on the left side, which is primarily used by the operating surgeon. And this is placed at the pararectal region below the costal margin. And this is just at the level or above the level of umbilicus, and this will be in the mid-clavicular line. The reason is because the camera is here, you don't have the triangulation, but these two trocars in this angle, it gives you that feature-like triangulation. And most of the clipping will be done from here, and this also helps in the hepatic flexure mobilization. So that's the advantage of placing this bit medial in the pararectal rather than the lateral. And if you see the other side, you have two 5 mm trocars, and this is actually the mirror image, except that these two trocars will be slightly on the lower side. So this will be used to retract the transverse mesocolon, and this is used to, in the initial stages, you elevate the ileocolic pedicle, and subsequently this will further help in the transverse mesocolon retraction. So this is used by the assistant. So this is what we generally use for right hemicolectomy in the laparoscopy. So this is, if you see, the same trocar position, but you can, now this is actually done, you can use it for hemicolectomy. At the same time, this trocar position can also be used for complete proctocolectomy, which means you can have this, this trocar, you can see here, slightly at lower level, and this trocar is also slightly lower level. You can use this for hemicolectomy, and in case if you want to do a proctocolectomy also, this can be used. So that's about the laparoscopic for right colon resections. Now if you see the robotic, so the robotic trocar placement is for the XI robot. Generally we don't use the robot for the right hemicolectomy because the benefit with robot is only minimal compared to the left colon resections. But however, if you want to use the robotic platform, especially the XI, now this is draw a line from the costal margin on the left side to the pubic symphysis. Now in this line, you place 4 trocars, at least 6 centimeters should be the distance between the trocars, and then the camera will be from if you calculate, I mean if you label this trocars as R1 from here, so the camera is from the R3, and then this is for the assistant trocar. So this is what we, I mean whatever right hemicolectomy done with robotic are done with this trocar orientation. There is also another option of placing all these trocars in the suprapubic region and then doing this procedure. I haven't personally done this, but this is described in the literature. The advantage what they suggest is you can later on you can use these 2 trocars, you connect them and give phalansteal incision and retrieve the specimen. Cosmetically much better than having 4 trocars in this line. So here the assistant trocar will be on the left side. So this is for the right colon resection. Now if you talk about the left colon resections, so this is one on the, this is for the robotic and this is for the laparoscopic. Let me start with the laparoscopic one. So generally the camera trocar is from the supraumbilical region, and then here there is a variation. So what we do is we place a 12 mm trocar. This is roughly in the mid-clavicular line, and then a 5 mm trocar just above the ASIS. Now the reason for placing this 12 mm trocar here is, so normally the camera comes from the supraumbilical region. However, if you want to have, if your vision is not good, especially taking the IMA at the origin, sometimes you may not have a better vision when the camera is in the supraumbilical region. In that setting, you shift the camera here, so you'll have a much better view of the IMA origin, and then you'll also have this triangulation. Like, so that is an advantage of having a 12 mm trocar here. Now this 2 trocars are used by the assistant, and again it's a mirror image, but if you see here, these 2 trocars will be slightly at a higher level compared to the working trocars on the right side. Now towards the end of the procedure, when you want to do stapling, so that is the time you need to decide whether you want to apply the stapler from here, because if you want to apply the stapler from here, which is feasible if you are going to do just an anterior resection or maybe a low anterior resection in a female pelvis or a slightly wider male pelvis, then that time you might have to change this to 12 mm trocar. But some of the cases, especially in a narrow male pelvis, and if you want to do a ultra low anterior resection, then placing stapler from this trocar might be challenging. In that setting, what we do is we place an additional 12 mm trocar in the suprapubic. The advantage is the staple orientation is vertical, so even in the narrow space you will have you can apply the stapler, and plus when the stapler enters the pelvis, the stapler itself retracts the prostate, so you will have a slightly better vision and also the success with the stapling when you place the suprapubic trocar. Anyway, we will have the video part subsequently, and I'll explain the usefulness of the suprapubic trocar and how it helps. Now this is for the laparoscopic left colon resection, and if you talk about the robotic, this is what is recommended by the intuitive. You draw a line from the left costal margin to the ASIS, and this line should be 2 finger breadth above the umbilicus. So you draw a straight line, and then in that line you place 4 trocars at 6 to 8 centimeter should be the length between the distance between the trocars. And if you see the actual intuitive, so they would have recommendation, they would have recommended to place a camera trocar here, but we have found a better vision when the camera trocar is placed in R3 if you're counting from here. So this is what we use for low anterior resections when we use robot, and then a single assistant trocar between the R1 and R2. Now this is just comparing between, this is what is recommended by intuitive, where the scope is generally placed here, but we have found when the scope is placed in the R3, the vision is better, especially when the IMA origin. Now occasionally this will not be very helpful if you have to do a ISR or in a difficult pelvis. So in that scenario, because one of the limitations with this trocar placement is you have only one assistant trocar. Sometimes you need two assistant trocar. So in that setting, another option to place the trocars are, so you place the three trocars in this line, but only thing is this should not cross the midline. So you start from above the ASAS and up to the midline. In that space, you place three trocars, and then you have one more on the left mid-clavicular line, and another one between the mid-clavicular line and the midline below the costal margin. And then you have one assistant trocar. Now, how this differs from what I've shown previously is, when we are doing the colon part, that is because in ISR you need to do a splenic flexure mobilization also. The limitation with this is that conventional trocar is, this will be sometimes very close to the splenic flexure and you may not be able to use it effectively. Now here, because this is away from the splenic flexure, so what you can do is, so you have this orientation. So this trocars, these four trocars are used during the colonic mobilization. The splenic flexure, descending colon, the initial part up to the rectosigmoid, and the targeting is done here. Now once that is done, when you are going to the deep pelvis, then we use this four trocars. So during the colonic dissection, you have one assistant trocar. However, when you are doing the pelvic part, you have these four trocars, which are the kind of R1, R2, R3, robotic active trocars, and this can be used by the assistant. Generally, this is used, what we do in ISR is we kind of tie umbilical tape around the colon for retraction, and this trocar is used for the retraction, and this is used for the suction. So you have two assistant trocars for doing the deep pelvic dissection, and these four are the robotic trocars. So here 4 plus 1, here 4 plus 2. So this is something which you can keep in mind and can be useful in ISR, that is intersphincter dissection, or in a difficult pelvis. So that's roughly the, broadly what the trocar placement, what you use for right, left coronary resections, both laparoscopy and robotic. Thank you.
Thank you, Dr. Kalairasan sir, for this insightful talk. The forum is now open to any questions from our audience. I would like to invite all three speakers on stage, Dr. Harsh, Dr. Tushar, and Dr. Kalairasan sir.
Dr. Kala, excellent talk. Enjoyed it, very lucid. My query is regarding the right hand working trocar in the right iliac fossa or the during laparoscopic left colectomy. Sometimes we find that it goes medial and then you struggle dissecting in the pelvis. So what is your tip on accurately placing the trocar, the right hand working trocar?
So we need to remember the inguinal ligament. Okay, so that means the lower end, that is a right working trocar, should be more lateral, parallel in that orientation of the inguinal ligament. So that allows you to enter into the pelvis, because our laparoscopic instruments are rigid. So you need to remember that inguinal ligament and place it more laterally. The left hand working trocar should be more medial. So that's how we plan it, and that is more useful when you are going in the pelvis. So you'll be going both in line when you are reaching in the pelvis.
Thank you.
So a bit more lateral, that is the most important thing compared to the left trocar, which is more medial.
Would you place it pararectal kind of a thing, or would you place it lower?
So the left trocar is more pararectal, and this right working trocar is more mid-clavicular and slightly right of the mid-clavicular.
Sir. Sir, excellent talk. Do you plan the trocar on the right side, right working trocar, if you're going for the ultra low anterior section, and if you're planning for the ileostomy? So do you plan accordingly so that the ileostomy, or you plan it in different way?
No, actually we don't plan that way because when you think that, because ileostomy you mark it pre-operatively, and so we generally don't really, I mean, if feasible, we place the trocar at the ileostomy site, but really don't think too much on that, because trocar placement should be for your procedure,
Yes.
because this is a minor factor, having 5 mm trocar additional away from the ileostomy. So I think better not to try to place your trocar on the ileostomy site.
Yeah,
May not be economically.
not feasible.
Yeah.
If there are no more questions, we would like to proceed to the next session. Our next session will also be taken by Dr. Kalai sir, and he will enlighten us on technique of standard right and extended right hemicolectomy for right-sided colon cancer. And the chairpersons for this session are Dr. Bhavik Vasoya, Dr. Pallav Desai, Dr. Narendra Sangvi, Dr. G.H. Rathod, Dr. Umang Tripathi, Dr. K.S. Purohit, Dr. Samir Kacheriwala, Dr. Neerav Wakhani.
I think we had an excellent talk from Harsh on the vascular anatomy in relation with the right colon cancer, and what we will do is we'll also see practically how that influences decision making, or the approach of the vascular control. So before we start, just the basics. So we generally use the term right hemicolectomy, extended right hemicolectomy. So generally, so what you need to remember is all these procedures are designed based on the lymphatic flow. We all know the lymphatic vessels accompany blood vessels. So if you want to have a good lymphatic clearance, then you need to ligate some of the blood vessels. And from the anatomical studies, it has been shown when the tumor is in the cecum ascending colon, so the lymphatics generally travel along these 3 vessels, and that's why we ligate these 3 blood vessels when there is tumor in this location. And because you are ligating these blood vessels, we remove some portion of the bowel. And so that's the principle of all these procedures which are described in colon. So if you see for the margin, or with respect to the pericolic lymph nodes, it's the 10 centimeter is what is the recommended margin on either side. So one important point to remember is when the tumor is there in the hepatic flexure or in the proximal transverse colon, we sometimes have to do this additional lymph node dissection along the gastroepiploic artery or the gastroepiploic arcade. Studies have shown up to 10% lymph node metastasis in that region. One of the practical way of deciding that is when you, while trying to take the right colic vein at its junction with the gastrocolic trunk, when you have lymph nodes there, those are the patients where you need to do this additional lymph node clearance. So I think we will be having a lecture on this complete mesocolic excision with CVL. I'm not really going into detail on that aspect, but when you do this procedures, I think that is applicable to most colonic procedures. We should avoid breaching the mesocolic fascia and thereby the potential tumor spread. and ligate the feeding arteries at the origin to have better lymph node yield. Which means you should not open the retroperitoneal fascia, or you should not breach the mesocolic fascia. It's very the important concept on, because some, at least at the resident level, they think, because the term fascia is used for tolls. But however, you need to understand that it is not a fascia, it is actually a fusion fascia, which means you have a mesocolic fascia, which is a true fascia which covers the colic vessels. You have a retroperitoneal fascia, which is a true fascia which covers the gonadal vessels, ureter. The tolls is actually the fusion between these two fascia, which means you have a areolar tissue between those two fascia. That's called the tolls fascia. And you can nicely appreciate here, this is the retroperitoneal fascia, and what you can see above is the colic fascia. So you can see here this flimsy layer. Now this is the tolls fascia, which means it's actually a fusion fascia. You are the two fascias which are fused, you are opening up. So that is what you need to remember while doing these procedures. The other anatomical point is this tolls fascia, which we have just now seen, when it comes towards the duodenum and the anterior and the pancreas, it splits into two leaves, the anterior and posterior. The anterior is called the threaded fascia. This is what we encounter during right hemicolectomy, and the posterior is called the treats fascia, which is posterior to the duodenum and the pancreas, which becomes important during pancreatic procedures like RAMs, all those things. So that is something, again, you need to remember. The tolls, when it comes to the duodenum and the pancreas, splits into two fascia, that is threaded and treats. So the key steps is the first is have a good traction on the ileocolic vascular pedicle, so that you enter in the right fascial plane, that is between the mesocolic and the retroperitoneal fascia, and then taking off these vascular pedicles and keeping in mind the variations which you can encounter in respect to the ileocolic artery and the ileocolic vein. So here you can see the artery anterior, but sometimes you can have artery running posterior, and that has implications in your lymph node clearance, and also the technical difficulty or easiness which you can have. And when you come to the transverse mesocolon, and you can see here, this is the right branch of middle colic. This is what we generally do if you have tumor is in the cecum. However, when the tumor comes up to the hepatic flexure, then you need to take the middle colic at the origin. I'll take you through one video probably that runs for almost 20 minutes, and then we can discuss each and every step. I think as the video plays, any questions are also welcome, because this is relatively a unedited type of video with played at 1.5x. So you can see here the assistant, this is coming from the lower trocar. So the lower trocar will be lifting the ileocolic pedicle, and the upper trocar will be used to retract the mesocolon, and then you use your two working trocars. So the upper one, so initially we use the harmonic, but most of the times it's your preference which you are comfortable. Many times the use of the hook cautery really helps in entering the plane, but harmonic also works well. Okay, like we don't prefer to use those vessel sealers for these procedures, because they tend to fuse that fascial planes, because we want the planes to open up. So that's why prefer either of these energy device. The key here is good traction by your the assistant. So that's the key. You can see here because that will lift the ileocolic pedicle. So we have just lifted the assistant was lifting the ileocolic pedicle, and then we are asking the assistant to lift the mesocolon also. And then with your left, because the mesocolon is giving traction, you are giving the counter traction, and then you have to identify the superior mesenteric vein plane, because that's our key first landmark, because your dissection has to be along the superior mesenteric vein. And you need to remember that superior mesenteric vein is actually formed by the ileocolic vein and one of the jejunal veins. So these two veins join together and form the superior mesenteric vein. So this formation happens somewhere here, and then you expose the superior mesenteric vein right from the place where it is getting formed, and then till the level of the inferior border of the pancreas. So it happens in a gradual way. So once we have exposed part of the superior mesenteric vein, now we are going along the ileocolic pedicle. So the pedicle is identified based on, because the assistant is lifting off the pedicle. Now this approach is obviously in minimal invasive. We use the medial to lateral, which means we are starting from the vessels medially, and then we are going towards the opening up the Toll's fascia, and then do the colonic mobilization at the end. So that's the typical medial to lateral, in contrast to lateral to medial, what you normally do in open surgeries. So you can see here, now this is the dissection is being done, and this is where the superior mesenteric vein is formed. So this is the ileocolic vein, and this is the superior mesenteric artery. The pulsatile is a superior mesenteric artery, and this side you will have the jejunal veins. So you can see there is actually nothing here, which means this is where the superior mesenteric vein is forming. And now after exposing that, we further define the superior mesenteric vein. We are going along the superior mesenteric vein. Now this is where how the relation between the artery and the vein matters. Now if the artery is anterior, coming anterior, and then you have the superior mesenteric artery here, and the ileocolic artery is traveling anterior to the superior mesenteric vein, then going to the origin of ileocolic artery is easier. However, if the ileocolic artery is posterior to the vein, then it will be passing posterior to the superior mesenteric vein. In that scenario, doing the ligation of the ileocolic artery at the origin becomes technically challenging. Now, whatever the lymphatic tissue are there, you need to sweep it off from the place. You can see here, the direction is you take everything towards a specimen. So that is what you need to aim for, rather than doing in the opposite direction. So you take off all this lymphatic tissue from the origin of the ileocolic vessels. So you can see here in this case, the artery is, this is the artery and this is the vein. So the ileocolic artery is coming, here it is anterior, but actually if you see here, so when you are at the level of pancreas, you have superior mesenteric vein and the superior mesenteric artery. The artery is to the left of the vein. But at this level, you can see here, the artery comes almost posterior to the vein. So that is a relation which you need to remember. So you have the superior mesenteric vein, and below that the pulsation is the superior mesenteric artery. So this is what you need to remember, the relation as you come. So this is actually the duodenum, because we are at the root of the mesentery, and we are having the duodenum below this. So in this Actually, we are taken together. Most often we divide them, but in this case, because we have cleared all the lymphatics and these vessels were running close, so we have clipped it together, but most often we take them individually. And then, so once the ileocolic pedicle is taken, then we go along the vein further. So this has to be done in a sequential way, because the dissection becomes easier once you take off the ileocolic, then the exposure of the superior mesenteric vein becomes much more easier. But remember to stay anterior to the vein, because once you get the vessel plane, follow that rather than going in a different plane, because that's where one of the mistake is. Once you start at a different level and then you will injure these vessels. Once you identify the vein, then keep following that till the level of the inferior border of the pancreas. So this approach is called caudal to cranial. That is, we are starting from ileocolic and then we are moving up. There is another approach called cranial to caudal, in which you start from the middle colic and the control of gastrocolic trunk and then come below. What we use is the combination of both, because the control of ileocolic is easier from below, but control of the colic vein is easier from supracolic. And I'll explain, because this is one of the important points to remember, because we have just saw this, this is actually the, so this is the gastrocolic trunk. Now that we have seen. Now we have seen from the lecture taken by Dr. Harsh that anatomy is very complex, because you don't have any standard anatomy here. So before I go to that gastrocolic trunk, so the point which we were telling is the Toll's fascia, as it comes over the duodenum, it splits into two. That's at the anterior is a threaded and posterior the treats. So what we are taking off is the threaded fascia, because that is what is the anterior, and once you take out the threaded, then you will expose the duodenum and the anterior surface of the pancreas. So coming back to the point which I was telling here, you can see the gastrocolic trunk, but because the variations are too much, it is sometimes difficult to appreciate the complete anatomy of the gastrocolic trunk from the infracolic compartment. And that is one of the reasons we identify the gastrocolic trunk. We do dissect and identify the colic veins, but before ligating the colic vein, we actually go to the supracolic compartment, reconfirm the anatomy, and then ligate these vessels. And that is something you need to keep in mind. So we ligate ileocolic vessels, then expose the SME. In this case, you also see there is a vein which is coming here. So this is again a variation which you need to keep in mind. So this is the superior mesenteric vein. You can see this is actually a jejunal vein. So normally this dissection is done to expose a superior mesenteric artery. Normally when you dissect here, you actually have the artery, but in this patient, the jejunal vein, the first jejunal trunk, is actually going over the superior mesenteric artery. That's why we are not able to see the superior mesenteric artery. Normally this vein goes posterior to the superior mesenteric artery. It goes posterior superior mesenteric artery, comes and joins here. But in this case, it was traversing anterior to the superior mesenteric artery. That's why we are not immediately seeing the superior mesenteric artery here. The reason why we do that is to ligate the middle colic vessel at the origin. As I told you, in this patient, the tumor was close to the hepatic flexure. So we want to ligate the middle colic at the origin. For that purpose, we need to expose the superior mesenteric artery. However, in this case, because the jejunal vessel vein was coming, so we have gone much more superior and then try to define the middle colic. So middle colic artery again can be nicely controlled from the infracolic. So after the ileocolic, it's the middle colic which is better controlled from the this location. So we are identifying the middle colic artery and then going along the middle colic artery. So you can see the branching of this is the right branch of the middle colic, and this is the, here you will have the left branch. So normally you will, for the purpose of standard right hemicolectomy, you take the right branch. Actually, you need to define the right branch from the origin. It's not that you take at periphery, because you need to clear the lymph nodes. So this is the middle colic, and then the right and the left here. So the middle colic is defined, and then we take it at the origin. Okay, so this is actually the middle colic, which is taken at the origin. You can see here. So here is the superior mesenteric vein, superior mesenteric artery, and then the middle colic at the origin. This is the left, and this is the right branch of the middle colic. So this now two are controlled in the infracolic compartment itself. Then we are going along the gastrocolic trunk. So trying to define the right colic vein, which is draining into the gastrocolic trunk. But we won't, as I mentioned, we won't ligate the right colic vein from the infracolic, but we will reconfirm it by going into the supracolic compartment. Appreciate the anatomy, because the gastrocolic trunk is formed by the confluence of right colic vein, right gastroepiploic vein, the anterior superior pancreadural vein. So this is the classical anatomy which you can see here. This is a gastrocolic trunk, right gastroepiploic vein, the anterior superior pancreadural vein, the right colic veins. We need to take only this vein. Sometimes this ASPDV also can be confused as right colic vein when you try to take it from the infracolic compartment, and that is one of the common reasons for bleeding while controlling these veins. That's why we always prefer to do it from the supracolic compartment. So it's a combination of both caudal and the cranial approach, which is used for vascular control in right hemicolectomy. So we also expose, and then at this point what we do is we place a gauze. Okay, so you can see here, so this is the superior mesenteric vein, this is the jejunal vein which was coming anterior, and then the ligated middle colic artery. So this is the completion from the infracolic. We keep a gauze there, and then we move to the supracolic compartment. So here what we do is we open the gastrocolic omentum and then enter the lesser sac. Now when you enter the lesser sac, the point to remember is you need to expose the pancreas completely. The reason I say that is because often you will have the mesocolon going over the pancreas and sometimes getting attached to the inferior border of the stomach. That is the gastropancreatic fascia. So that is where you can see here, this is actually the part of the mesocolon which is going right up to the stomach. That is, it gets fused along with the gastropancreatic fascia. So we need to make sure that part of the mesocolon is completely taken off from the stomach. The way to identify it is you need to see the pancreas completely. The anterior surface of the pancreas should be visualized. Otherwise, you are not taking the mesocolic fascia completely. And that can result in taking the veins at much lower level, and it may not result in complete lymph node clearance. You can see here, so this is where actually the mesocolon is getting attached. So we are taking it from the stomach and then making sure that we are seeing the pancreas completely. And when you do that, then you can define the gastrocolic trunk also properly. So we are now entering in the plane. This is called the gastrocolic fusion fascia, where the colic and the gastric part of the fascia comes very close together. So when you open this gastrocolic fusion fascia, then you can enter the space between the right gastroepiploic vein and the right colic vein. So this is actually the right gastroepiploic vein, and this is the right colic vein. So we need to enter in the space between those two veins, and that will help us to clearly define. Even if there are some variations in the colic veins, if there are more than one colic veins, then we will be able to identify it clearly. So when we are in the right plane, we generally don't have much bleeding. So that is the important point to remember, because all these are fusion fascias. So if you are in the right plane, you hardly encounter any abnormal vessels. So the aim is to join the plane which we created from below. So now we are able to clearly identify the anatomy of the gastrocolic trunk. You can see here, this is the colic vein. Now this is the pancreaticoduodenal vein, and this is the right gastroepiploic vein. So sometimes this anatomy, so you won't get this type of exposure when we try to control this vein from the infracolic compartment. So that is the point which I want to highlight. So why you should combine the approach. Use both caudal and the cranial approach so that you can safely control these vessels. So what we have seen is control of the right colic vein and the middle colic vein is better done from the supracolic compartment. The ileocolic vessels and the middle colic artery is better controlled from the infracolic compartment. Now you can see here, this is actually the right colic vein, and then you are actually having the pancreaticoduodenal veins here. If you are trying to do from below, you might think this as a right colic vein, and once you take this off vein, you will not get the plane. You will go into the pancreas and have some bleeding. So that's why it is always safer to control this vein from the supracolic part. Now we are taking off the right colic vein, draining into the gastrocolic trunk. So this is the gastrocolic trunk, this is the gastroepiploic, and this is the right colic veins. Sometimes you can have two veins also. That time it's called, one is called superior right colic vein, other is the right colic vein. That anatomy you can actually see on the pre-op imaging. So you can see here, so this is actually the pancreaticoduodenal vein, ASPDV, which now we are clearly differentiating it from the colic vein. So once this is done, then the only vein which is remaining is the middle colic. So before that we do some more dissection in the plane. That's you actually the Tolles fascia which you opened up previously, you continue in the same plane. Just slightly move ahead. Now, when you are in the right plane, you don't have to worry about injury to any of these structures like ureter, gonadal vessels, because you know that all of them will be underneath the retroperitoneal fascia. You can see here, this is the gauze which we kept from below. Now we are joining with that plane. So when you join with that plane, the only vessel which is remaining is the middle colic vein draining into the superior mesenteric vein. So you can see here, so this is the superior mesenteric vein, and this is the middle colic vein which is draining into the superior mesenteric vein, which is controlled. And you also take off those attachment of the mesocolon with the inferior border of the pancreas. Yeah. No. No, no. So that is the important thing, because especially with this anatomy, because sometimes you will have the right gastroepiploic and the right colic will be draining separately into the SMV. So that time there is no true gastrocolic trunk. That is the only scenario you come close to the SMV. Otherwise, we need to take the right colic vein at its junction with the gastrocolic trunk. And that's why it is easier to control from this angle than doing it from below. Yeah. Yes. Because that time, because you have a very narrow space, here you have such a wide space, and then you can clearly define all the blood vessels. And then we take off the middle colic vein. Yeah, yeah. Right.
SMVA.
Yes.
So as we know you are an excellent surgeon, but for young surgeon, how many of times you have a near miss event? Because injury to superior mesenteric vein and even sometimes artery, it becomes lethal. So what is your message to this number? One is technical, this question, and another from literature.
Yeah.
That by clearing all these things, how much of survival advantage long term or lymph node harvesting? Definitely it is yes, but for this.
Yeah, I completely agree, Dr. David. It's actually, you need to balance the safety and the radicality. So, now, there are two aspects what the evidence tells. So, even the evidence, you don't have actually a strong evidence favoring that. You know that the lymph node yield is better, and the R0 or whatever the clearance is much better with this procedure. But the survival advantage, yes, some studies have shown, some did not show. So you need to obviously balance the doing this procedure with the what advantage which you are going to give the patients. But again, yes, initial stages, yes, there is definitely a possibility of injuring these vessels. But I think once you gain a reasonable experience, I think you would all agree that this is the best plane. In fact, when you expose the vessel, the chance of injury is much lesser than trying to not see the vessel and then going blindly and injuring. And injury in that scenario is more dangerous because you don't have any control. Here, the vessels are exposed. Even if some injury happens, you'll be able to control it precisely rather than taking blind switches. I mean, that's my personal opinion on this, because many times trying to avoid seeing the vessels causing injury is more dangerous. So vessel plane is always the best plane. Obviously, you need to refine your skills, but whenever we do any of these procedures, oncological procedures, the best plane is over the vessel. And you will be, even if some injury happens, and also you will be able to safely control them. Yes.
Dr. Rupesh Mehta,
Yes.
Ahmedabad. You have done it both ways, in open method and this. Now, large number of surgeons, they don't have facility of advanced equipment. So what will be your advice? Should they do it or should they refer?
So actually, the whole procedure can be done even with cautery also, monopolar cautery. But again, we find because the the only challenge is, because initially I've done this procedure with monopolar cautery, but with the hook cautery. But when I tell my residents to do that same, so the control which they have with the monopolar, the hook cautery, it requires much more precise control. So they tend to go in a wrong plane or tend to injure the vessels. So the advantage of harmonic is you have one active blade, one neutral. So you keep the neutral blade always over the vessel, active blade away from the vessel. And I feel that's one of the best way of doing this procedure. So it really does not require any high-end equipments, because I don't know whether harmonic is considered as high-end, because now it's more or less universally available. And then you also have a cheaper alternatives to the harmonic also. So I think this is a very much feasible procedure. Yeah, obviously whether the way of this type of exposure, so you need to have reasonable laparoscopy experience before attempting this type of oncological procedures. That is true. The point raised by Dr. Daivath is well taken. But definitely a much doable procedure once we understand the anatomy. Anatomy and where things can go wrong. So that's the two important things to remember. Then this right hemicolectomy is definitely a procedure which can be standardized and done in a similar way by most surgeons.
Amazing presentation, Dr. Kalarasan. I have a comment to make. The thing that you said, you go to supracolic compartment. What I do most of the time, particularly for the extended colectomies, and when I feel that this is going to be a difficult right colectomy, obese patient, bulky lesion, I go to supracolic first, get the colon down, open the space, keep a gauze there, get into Trendelenburg then, and then connect to the gauze space from below.
Yeah.
So I usually do this supracolic first.
No, it's actually described. That's what. So there are two broadly approaches. Start cranium, comes caudal, or start caudal, go towards cranium. The sequence really doesn't matter, but understanding which are the vessels easy to control from the cranial aspect, which are the vessels easy to control from the caudal aspect, I think that is what we need to understand. Sequence hardly matters. I mean, you can do any way starting from below or above.
We can just
yeah, you can ask the question.
We can just take one or two more questions, please.
So just wanted your tips on this is a planned surgery, a malignancy. I'm not sure whether there are separate sessions for benign ones, but if you get growths, perforated growths with peritonitis and in an emergency situation where you probably need to do some extended hemicolectomy or a colectomy in an open scenario, then because where the anatomy is not clear, it's all studded with this partly duskiness all around, you're not able to identify vessels. In that situations, how do you deal with such cases?
No, I agree. I mean, because see, we all know that not all patients are same. Similarly, not all scenarios are going to be the same. So you will not be able to achieve the same amount of the radicality in all patients. There obviously, because those patients usually will be septic, and you need to focus more on the damage control. So there obviously we don't try to go along the vessel. So you need to, because there it's a rupture, so the tumor is already kind of disseminated. So you are not sure of going to offer a R0 resection in those patients. So there it's more of a damage control. You remove the tumor, come out, and obviously we don't. If feasible, you can do it, but many times the planes will not be that good, and also you don't want to do a prolonged procedure also. So. No, I think so, because we commonly do two scenarios is Crohn's and tuberculosis. So Crohn's is one scenario where you can have sometimes very dense fibrosis, especially the mesentery becomes thickened and you may not have the planes. So those are the cases because there it's focused mainly on the luminal pathology. So you don't have to really do this type of procedures. In fact, there was initially in between for some time, the Crohn's, it was thought that disease starts in the mesentery, so you need to take good amount of mesentery even for Crohn's. But now that has been disproven, so you don't have to take wide mesentery in Crohn's.
Do you stage the procedure in septic abdomen?
Depending, I agree. So if you feel the patient is hemodynamic not stable, then do a stoma. Obviously, you do the resection. You may not do the reconstruction. So you bring the ends as a stoma.
But minimum you do a resection with stoma.
Yes.
Routine approach is from medial to lateral. Anytime you need to modify from lateral to medial approach?
I think in laparoscopy it's easy to do from, because if we don't want the bowel to be too mobile in the initial stage. So I don't remember any time we are done from lateral. This is always medial to lateral.
So we are running late. Sorry, we'll have to conclude the session. And our guest faculty for the keynote lecture, Dr. Ahmed Shukri Hafiz, has already joined us from Cairo, Egypt. And good morning, sir. Are we audible to you? Sir, can you unmute your mic, please?
Okay. Good morning from Cairo.
Good morning, sir. It's an honor and privilege to have you here. Dr. Ahmed Shukri Hafiz, sir, I'll give you an introduction. He's the chairman of Department of Surgery and the chief of Minimal Invasive Unit, Al Salam Oncology Center, Cairo, Egypt. He's a master in minimal invasive GI oncosurgery and mentor to many surgeons around the globe, including me. And it is apt to say that he's the key person who has taught us operative techniques in minimal invasive GI surgery, especially colorectal subspecialty. His demonstrative videos are very popular on virtual platforms like YouTube, and one can take a look to believe his skills and repertoire. It is fascinating to let you know that we have never met physically, and that is the impact of virtual teaching platforms in disseminating knowledge and skills. I therefore gave him an analogy of Guru Dronacharya, the royal preceptor of Kauravas and Pandavas in the great epic Mahabharata, and his disciple Eklavya, who learned the art of archery only by constructing the effigy and imagining his physical presence. On this note, we welcome Dr. Ahmed Shukri Hafiz to deliver his talk on technique of complete mesocolic excision with central vascular ligation. May I invite the chairpersons for the talk? Thank you, previous chairpersons. Dr. Sunil Popat, Dr. Somesh Chandra, Dr. Kiran Kothari, Dr. Shakuntala Shah, and Dr. Rupesh Mehta. Over to you, Dr. Ahmed Shukri, please.
Good morning from Cairo. Thank you very much for the invitation. Thank you, Dr. Lanki, very much to give me the honor and privilege to be with you in this scientific meeting. It's a great honor, really, to be talking to you from this distance, but actually we are closer than what we all think. We are in a very small village now with all the technology. My topic today will be on the CME and CVL as a new technique that has been relatively maybe a decade or 15 years on, and it was not completely adopted, and we will go through it and we'll see, is it going to be the current standard of care or not yet. In colorectal surgery, surgeons like to usually cut something and put it on the back table. So, and they feel very good about doing that. But this is not all the time necessarily means that you have done the proper thing. It is not what you have removed that counts, but really what you have left behind in the patient. You are dealing with cancer and you do not want to leave anything behind, and this will be a cause of recurrences, and maybe you will jeopardize the results of your patients. And we have been taught in surgery that in order to change your technique, you must change your concepts. And this has been very, very, very well demonstrated in rectal cancer. In rectal cancer, up until the middle of the 1980s, the results were really, really bad, 30 to 40% local recurrences, less than 40% 5-year survival, all up until these two gentlemen, Bill Hill and Philip Kirky, came out with a new concept. When we changed the concept, this will have an impact on our technique. They have proven that it is not the distal margin that counts, it is the circumferential margin that is really the definitive factor. If you have a positive circumferential margin, your survival decreases by 50%. So this has changed and revolutionized rectal cancer surgery because we changed the way we think about it. And TME was born. Even the pathological specimen handling has changed over time with the concept of TME. And with the TME, two very important concepts has dug into the colorectal cancer surgery. First, the surgery has to be conducted along embryological planes. There are certain embryological facial protective planes that needs to be completely respected, and the surgery of the rectum has moved towards the concept of a compartmental excision like that of soft tissue sarcomas. You need to remove the whole compartment and you need to remove it as a package intact. These two very important aspects, they have changed and revolutionized rectal cancer surgery. To the point where in the middle of the last decade of last century, this is a review of the Scotland database. They compared survival between rectal cancer and colonic cancer. And to their surprise, starting from the 1995, the results, the survival results of rectal cancer has surpassed that of colonic cancer. This was very strange because the natural biological behavior of rectal cancer is much worse than the colonic cancer. So why this shift happened? Simply because we have changed the surgery of rectal cancer, and now we are performing the ideal surgery for that particular disease. So it has impacted the survival, it has impacted the results in a very positive manner. And we did not do the same for colonic cancer, unfortunately. Up until the early turn of this century came Werner Hohenberger, who is the equivalent of Bill Hill in rectum. He came up with the concept of complete mesocolic excision. What he did actually, he implemented the same two concepts of Bill Hill in the rectum. He implemented them on the colon. The colon also has a compartmental fascial enclosure. One end, the colonic side, the other end is the main feeder vessel, and in between you have this sandwiched vascular, lymphatic, fibrofatty mesentery, which is covered by two layers of fascia up and down, and you need to remove this as a package as the same as the rectum. And by doing so, you should, in theory at least, improve your results. So this is the fascial layers that we need to talk about, the mesenteric fascia and the TOTS fascia, which is protecting the retroperitoneum. And you need to conduct your surgery between these two lines of fusion. Embryologically, these two layers of fascia, they have fused together during development, and then you need to go into that space, which is a potential space, and you will develop it by lysing the adhesions that happen during embryology and having two distinct fascial layers separated apart. And colonic surgery has evolved into what we now call the complete mesocolic excision and central vascular ligation, which is surgery along the embryological planes and ligating the vessels at that origin and keeping the package of the colon and the mesentery absolutely intact. So it has shifted actually the surgery from the colonic target to the mesenteric vascular target. This has changed the way we do the surgery to a great extent. And evolving the concept even further, we have developed now what is known as the book and papers of the book concept. You have many layers, which are the papers in the book. You have the bottom layer is the retroperitoneal page, and then you have the piece of colon, ileum, and the mesentery in between, the ileocolic page, and you have the mesentery of the transverse colon, the mesocolic, transverse mesocolic page, and then you have the stomach with its omentum, the mesogastric page. And along these pages, dissection along embryological lines can be carried out to end up with a specimen with such a quality, the wealth of the mesentery, the intactness of the mesentery, the ligation very central at the origin of the vessel. You have a very good length between the tumor to the vascular tie, and you have the whole package intact. This is what we aim at in what we are talking about, the CME and CVL. Regarding the OR setup and patient positioning, there are two schools in doing the CME and CVL. Either you stand between the legs and you will have your patients in the supine position with the leg apart, and you will put the screen overlying the head of the patient. And during the surgery, you will shift between Trendelenburg and anti-Trendelenburg and left tilt and 0 degree table in different parts of the surgery. The other possibility is that you can stand on the left side. In this instance, you will have your monitor on the right side of the patient. But I usually perform the procedure standing between the legs as my standard. It is much easier for me because I do a lot of pancreatic surgery and gastric surgery as well. So this is easier for the team to fix the approach in certain way so that they know, everybody knows what to do in the OR. The arrangement of the OR and the tables is like in the picture. You have your cameraman or a woman on the left side of the patient. You will have the surgeon between the legs and the assistant on the right side of the patient. I have my scrub nurse on my right-hand side with the hand reach table where the instruments can be put. The port distribution, with the approach that we use this distribution. We start by putting the umbilical port first, around 2 centimeters above the umbilicus, and after exploring the abdomen we put the patient in Trendelenburg and put the suprapubic port, which will be the camera port for the most of the infracolic dissection. The two working ports are like in the picture. There are somewhere in the right and left iliac fossa, depending on the body habitus of the patient, the weight, the belly of the patient, the configuration of the contour. You will try to put them somewhere to give you access work both infracolic and for the supracolic part and the anastomosis. And the right subcostal port is for the assistant. The umbilical port, we use it for the stapling of the terminal ileum. The suprapubic port is used for stapling of the transverse colon and for creation of the anastomosis. And now we move to the video. This is a hepatic flexure lesion. So now the camera is in the suprapubic port. And as you see, it gives us a very good mesenteric view. We always start the procedure retro-mesenteric. We always start retro-mesenteric. We flip the patient in Trendelenburg and left tilt, and then we elevate the terminal ilial mesentery, and then we access the medial to lateral plane right here, exactly the same way as in the conventional medial to lateral approach, but we start from below at the level of the terminal ilial mesentery. And by doing so, going into the proper plane, we dissect. This is the embryological plane that you need to access. This is what we were talking about, how to lyse the embryological plane that was fused during development and go in between the two facial layers. You see here the ureter. This is TOS fascia. TOS fascia is engulfing all the retroperitoneal structures. And you see here, this is the essence. These are the nodes. This is the essence of this procedure, because the wealth of the mesentery carries with it the lymphovascular tissue. So you're not leaving anything behind. Even smaller lymph nodes are here. And by working yourself in between these two facial layers, which is essentially a bloodless field, you will protect your retroperitoneal structure. This is the retroperitoneal page that we were talking about. And this is the ileocolic page. And carrying the dissection a little bit. Medially, you will encounter the duodenum. There is a very important triple relationship here that needs to be understood between the duodenum, the head of the pancreas, and the mesentery of the colon. You need to mobilize the duodenal head of pancreas complex together away from the mesentery of the colon, and not to get between the duodenum and the head of the pancreas. You need to mobilize them very well until you see the origins of the superior mesenteric vein and the junction of the superior mesenteric ileocolic vessels. And then carrying the dissection further up, you will open up the peritoneal reflection between the colon and the liver. So now, if you imagine that we have already completely released the ileocolic page from the retroperitoneal page, we put a gauze inside, and then we flip the patient anti-Trendelenburg and put the bowel back in normal position, and then we start our mesocolic dissection. We start in a line going from the transverse colon up to the ileum, one straight line crossing the superior mesenteric vessel. And what you need to do is to go into the vascular sheath of the superior mesenteric vein and detaching all the attachments, the fatty attachments to the vein. And then when you reach to the mesentery of the ileum, you will find yourself in the space created beforehand, so it's very easy to go through and cut it. And opening up the specimen like a book, you push the ileum to the right side, the cut ileum to the right side, the left ileum to the opposite side, and then you carry on your dissection upwards until you meet the iliocolic pedicle. This is very, very easy because you have a posterior dissected plane already. And when you reach the iliocolic pedicle, you ligate them, and this is the best way because you see on both sides of the vessel up and down due to the previous dissection. After ligating the iliocolic pedicle, you carry on your dissection upwards to the middle colic lymph node area and dissect all the lymph nodes away from the root of the superior mesenteric and the junction of the middle colic to the superior mesenteric artery. And after dissecting the lymphatics, you can make a decision whether you are going to take the main trunk of the middle colic or you are going to spare the left side. In this area, we have ligated the main trunk of the middle colic. And then after that, we switch the camera to the umbilical port and we go opening up the page of the mesogastrium. And what you see here is the right gastroepiploid vein, which you can spare if you want, or you can ligate if you wish. And these are the remnant attachments after ligating the right colic vein. And now what is remaining to do is the transverse mesocolon and then cutting the transverse mesocolon itself. And now this is the final view of the dissection. You have complete dissection of the lymphatics. You have no mesentery whatsoever from this line up to the wall of the colon. There are many ways to skin a cat. This is another example when you see here bulky lymph nodes along the superior mesenteric vessel. So in such cases, we will start the same way. The dissection, the retromesenteric dissection, the opening, the page between the retroperitoneum and the iliocolic page until we mobilize completely the right side of the colon, the retroperitoneum. And this is the duodenum, the triple relationship duodenum, head and mesentery that we talked about. We have to be very careful with it, especially in such cases with bulky lymph nodes. And because there is a heavy burden, lymph node affection in this case, we opted for taking down the greater curvature of the stomach completely. The arcade of the greater curvature of the stomach, the gastroepiploic arcade, is completely taken down, and we are going to ligate the right gastroepiploic artery and vein from their origin and consider them part of the specimen. So we are taking now the greater curvature lymphatics with us, and we are working ourselves down to the origin of the, you see nodes are quite evident here, and we are aiming at the origin of the right gastroepiploic vessels. So in order to reach that origin, we open up the peritoneum between the lower border of the pancreas and the mesentery of the transverse colon, and then work ourselves to the right side to the origin of the right gastroepiploid artery coming off the gastroduodenum. This is the artery right here, and we are taking all the lymphatics around it before isolating it and ligating it. Because we are coming from up downwards, we call this approach the cranial to caudal approach, which is the same thing that we were doing, but from the opposite side, from the caudal to cranial in the previous video. So you can do it cranial to caudal, caudal to cranial, or you can combine them together. Now we are dissecting the vascular structure, the superior mesenteric vein and artery. This is the head of the pancreas here, and the last venous tributary to the superior mesenteric vein coming from the colon. So we have a clean head completely now. All the lymphatics of the infrapyloric and anterior pancreatic have been removed. This is the superior mesenteric vein already dissected, and this is the superior mesenteric artery. And we are now taking down all the lymph nodes around the superior mesenteric artery towards the specimen, towards the transverse mesopolium. This is the reverse view of what you have seen, exposing this the middle colic from the below in the previous video. Now we are going to expose the middle colic artery from above. You have dissected all the lymphatics around the root of the SMA, and now we are exposing the origin of the middle colic vessel. This is the middle colic artery, and we are ligating the main stem, and we are taking it down because there is very heavy involvement of the lymph nodes. Having done this, we can now flip the specimen back and open up the mesenteric line along the axis of the mesenteric vessels. You see here the bulk of the lymph nodes that made us take the decision of doing a cranial to caudal, so that we can know exactly where are the vessels and secure them before attempting ligating the vessels and the tributaries of the superior mesenteric vein. This is the superior mesenteric artery and clips. Now we have flipped all the lymphatics to the right side, and now we can carry on the dissection downwards in the same manner that we have done in the previous video, controlling the ileocolic pedicule now, and then going directly to the mesentery of the terminal ileum and the transverse colon. So at the end of the procedure, this is the view after the lymphadenectomy and the mesenteric resection, and we have cleared all the nodes that have been there completely. So this is another way of doing the same thing, but from a little bit different approach. So if we go to the evidence of what we're doing, the very first revelation of the technique by Hohenberger was in 2009. He presented a paper analyzing almost 1,300 patients. He operated in the period from 1978 to 2002. And he split this time period into 1978 to 1994, which is before implementation of the CME and CVL, and then from 1995 to 2002, where he started to implement the CME and CVL. And according to him, the results, the local control and the survival increased significantly after implementation of the CME and CVL. And in the same line of thinking, if we are from a different area in the world, the Japanese Society guidelines in 2019, they necessitated an D3 lymphadenectomy in all lymph node positive cases, in all T3 and T4 lesions, and even a subset of T2 lesions. So the emphasis on central lymphadenectomy is becoming gradually the standard, at least in some parts of the world. But the problem with the evaluation, the real evaluation of the CME and the CVL is that we have a very limited randomized controlled studies. What we have is systematic reviews and meta-analysis. And what makes the procedure nowadays more acceptable is that if you review the literature from 2009 until 2020, you will find 13 systematic reviews and meta-analysis. And then in the year 2021 alone, you have 9 systematic reviews and meta-analysis. So the procedure is gaining acceptability and popularity a little bit. You will have in the literature a big bias. You will have papers with very strong emphasis that D3 lymphadenectomy definitely and most certainly enhances oncological clearance in patients with the right side of the colon. And on the other side of the spectrum, you will have people who are still skeptical and asking the question, is complete mesocolic excision worth it or not? Because you must remember that you are working in a very dangerous area, and injuries to the superior mesenteric vessels have occurred, and they are very serious and with potentially catastrophic consequences. So where are we in reality? Most definitely, a lot of meta-analyses and reviews, they have shown that CME is more or less safe and with a bigger and greater yield in lymph node harvest. And this has an implication oncologically on the results. You will find maybe 4 or 5 meta-analyses going into the same line of thinking. They are saying that it is a good oncological technique, and they are emphasizing that no significant post-operative complication, or it does not increase very much the risk of the surgery. But you always have to remember that the evidence of the survival benefit for this technique is not very clear until this day, and maybe because we do not have enough randomized controlled trials. In this very good review, it has 17 studies analyzed with around 4,000 patients, and they are conducting that there is an improvement in the overall survival and disease-free survival in the CME group. But on the other hand, you will find meta-analyses which states that oncologically you might have a very good reasoning to do a CME and CVL, but at the expense of a higher complication rate. This has to be in mind when you embark on adopting this technique. You can have a very good oncological result, but you must be aware of the potential complications that come with the technique. So it needs training, and it needs a full setup and a high volume center. Along the same line, this is another meta-analysis denoting the potential higher postoperative adverse effects in this technique. And this is logical. If you do more, you put yourself and the patient at more complications. This is understandable. So, where are we? Are we going to settle for less oncological adequacy or a better oncological adequacy and a better survival and local control with the inherent increased risk and the potential severe complication that can come with it? And as surgeons, we have to walk on this tightrope, and with good preparation, good training, to have a system implementing the new technique, I think you can do get the better of both ends, to have the good, adequate oncological control, and to be safe, and to minimize as much as possible the potential complications that can happen. Thank you very much.
Thank you very much, Dr. Ahmed Shukri Hafiz, for that comprehensive and lucid presentation. And I really thank you. On a Sunday morning, you spared your time to be with us. I'm sure everyone has learned a lot, and it was a practice-changing talk for me. Thank you very much. If you have any questions, one or two questions, we can take that up. So in the previous talk, I don't know whether you joined or not, sir. Sir, can you put your picture in the PIP image, or you can, now since the talk has ended, can you come live so that we can be more connected with you?
Okay.
So in the previous talk, and this was our aim in keeping these two talks together. In a previous talk, we saw Dr. Kalai speaking about a different technique of right hemicolectomy, the medial to lateral approach standing from the left side. And you gave a different perspective of the retroperitoneal tunneling, that protects the retroperitoneal vessels. And to me, it also facilitates the ileal stapling. We got two different perspectives over there. So thank you very much for that.
Thank you.
Yes, sir. Dr. Somesh Chandra.
Thank you, Dr. Hafiz, for a very enlightening talk, and we all enjoyed it here.
Thank you, sir.
Like you said, there are many ways of skinning the cat. So we'll not get into the details of techniques of how we do it, because they would come differently from different quarters. But you said that the concept of TME has been extended to colon, from the rectum to colon, and we do a CME. So we have likened the rectum to the colon, but can we liken the left colon with the right colon? Or the left colon and the right colon have to be treated differently? It appears that there are some reports which say that D3 for left colon may not be that useful. Your take on this?
Well, it's what we do for right is what we do for left. It's for left, it's easier to do a CME and CVL, central vascular ligation, because you only have the IMA, and traditionally, if you do a high ligation, you are taking the IMA very close to the aorta. It is easier to do an CME, even if you do not term it as a CME, because CME have been more stuck with the concept of right colon dissections. But actually what you're doing in the left colon, unless you are doing a left colic sparing technique, so that you are breaching the mesentery in this area to dissect the left colic artery and spare it. If you're doing high ligation with the IMA, it is equivalent to what you're doing in the right side. Whether this is appropriate for the left or the right or the rectum, it has been proven beyond the shadow of doubt in the rectum. But to have been proven, it has taken like 20 years to be in the guidelines for the total mesorectal excision, be in the guidelines. So things takes time, and because this is a difficult technique that it's not popularized in every center and accepted and becoming a standard for the surgery, there is a debate about its effectivity and its potential dangers. So, but the concept itself is that you are removing the whole compartment, whether right, left, or rectum. You are removing the whole compartment within its fascial boundaries and ligating the vessels very centrally. This concept is very nice, and it is very clear. It has been documented in the rectum as a very efficient mean to increase the survival and decrease the local recurrence. And we are having preliminary results with the colon, whether right or left, that it has an oncological value, and it is debatable, the idea of the increased complications. It depends on your training and your volume of cases and the expertise of the surgeons and all these things. So the concept itself is, I think it's very valid, whether you apply it in the right or left. And I think one of the very important things about this concept is that you can actually minimize your surgery. If you apply this concept to splenic flexure carcinoma, for example, you do not need to do an extended right all the way to the left colon, or you do a subtotal colectomy. If you put this concept into action, you need to only remove the segment of the colon with its mesentery, 10 centimeter proximal and distal to the lesion, down to the central feeding vessel, and you can preserve a big length of colon. So it actually, the concept can have an impact on minimizing the surgery that you do and the loss of unnecessary colon that you can remove in certain parts of the lesions that are particularly in certain sites, like splenic flexure carcinoma, for example. I don't know if this covers it, but this is the way I think.
Thank you very much. We get your message loud and clear that if you're going to do a surgery, it's better to do a complete job rather than leaving disease behind. I think.
Yes, if there are no further questions, we can conclude the talk. Once again, thank you very much, Dr. Ahmed Shukri Hafiz.
Dr. Hafiz, thank you very much. Excellent disposition.
Thank you. It was an honor.
And we look forward to having you here, sir, for further many more events like these.
Would be my pleasure. Would be my pleasure.
Thank
you very much.
Thank you. Thank you, chairpersons. We now move on to the next talk of splenic flexure mobilization by Dr. Ashwin D'Souza. We are running short of time and we will have to finish quickly. This will be followed by inauguration.
Sir is professor and surgeon in HPB and GI services colorectal unit at Tata Memorial Hospital, Mumbai. I would like to invite chairpersons Dr. Sunit Popat sir, Dr. Amit Shah sir, Dr. Anish Nagpal, Dr. Rakesh Patel, Dr. Kaushal Anand, Dr. Jignesh Meva and Dr. Himesh Chauhan. Also the delegates who have registered for upper GI and colonoscopy hands-on workshop, please proceed to the multipurpose hall outside. Thank you.
Sir, I would like to begin by saying that splenic flexure mobilization is the Achilles heel of minimal invasive colorectal surgery and one of the most difficult technique, and we are looking forward to you making it easier for us.
I'll try my best. Thank you, Dr. Ashish, for this invitation. So I will present to you our technique for laparoscopic splenic flexure mobilization, which is required in two situations. First, when we deal with rectal cancer to get length, and second, when we do left hemicolectomy, where it becomes part of the oncological resection. So these are the ports that we use for a standard LAR, the surgeon using the right two ports. And the differences between that and the left hemicolectomy is that these ports we can take a little superior because we don't go to the pelvis. And the left low quadrant port, we can use a 5 there instead of a 10 because we don't use a fan retractor for the pelvis. So this is the first case, the lesion there we can see in the descending colon. On further cuts, it's actually more towards the splenic flexure. The first part is always to create our space through surgically expose the left colon. So the omentum and the transverse colon is pushed well below the left lobe of the liver. And the small bowel is then pushed into the right iliac fossa and the right hypochondrium, right up to the DJ flexure, exposing the entire left colon. And that's the lesion there, more towards the splenic flexure. So here we would probably include the omentum as well of the left part of the transverse colon. Splenic flexure mobilization, of course, begins medially by doing the medial dissection first. So the right leaf of the rectal mesentery is incised. Here we will do an IMA dissection, but we will not take the IMA because this is a left hemicolectomy. The plane is then continued towards the pelvis and then developed just posterior to the superior rectal artery to enter this retroperitoneal plane. The key we get here is from these small retroperitoneal vessels which have to be taken down, and we can see the ureter exposed there and the left gonadal vessels. We don't look for them, but that's the correct plane when we reach it. Then we go towards the IMV at this point to develop the plane below the IMV, incising the peritoneum there. And again, the plane here is just behind the IMV. So little care to, with fine dissection with the cautery to actually find this plane and dissect just above the Taltz fascia there. We then proceed for nodal dissection at the root of the IMA. Even for a left colectomy, we would complete the nodal dissection, as I said, but we don't take the IMA. So that's the nodes coming off the IMA right till the root. And we will continue along the length of the IMA until we expose the left colic artery, that is the origin of the left colic. And depending on the location of the tumor, we may even take the first sigmoid if it's required, if the tumor is more towards the sigmoid colon. That would be enough for this because this we are only going to take the left colic for this patient as the lesion is very close to the splenic flexure. So that is the isolation of the pedicle for this dissection. The left colic artery, the first branch of the IMA, which is clipped and divided. The IMV then has to be taken at the level of the first sigmoid artery as it comes out from the IMA. And actually these are the main feeding artery for this lesion. because we have to, as per the new T-Rex study, only 10 centimeter of bowel is required on either side of the lesion, and the feeding artery is in that area. So we continue the medial to lateral dissection here, again staying above the Stolz fascia and actually going in that fusion plane between the two facial planes, as Dr. Kalarasan very nicely mentioned, for right colon. So that's the embryological plane. Then we go for the IMV division. Here the IMV is dissected right at the lower border of pancreas. And once we take this IMV, we then begin the medial cut on the mesentery of the transverse colon, going to the mesentery of the descending colon, anterior to the body of the pancreas. So this is the medial end of our mobilization. As we cut this, we go superior to the or anterior to the pancreas and enter the lesser sac behind the transverse mesocolon. That is the entry into the lesser sac. And then we can take down these attachments of the transverse mesocolon to the anterior and lower border of the pancreas, taking it really near the splenic flexure. This cut on the mesentery can be taken right till the origin of the middle colic artery. So that will give us complete mobilization of the entire left colon. We can see that's the middle colic artery there. So that is the complete mobilization, which sometimes is required for this left colon for a left hemicolectomy. I place the gauze piece there, half inside the lesser sac and half at the splenic flexure. We'll see later on how that is of use to us. Lateral peritoneal attachments are taken down fairly easy. This is for left hemicolectomy, so I will mobilize the entire left colon right up till the upper rectum and then decide the resection based on the location of the tumor. As most of this dissection is done medially, this lateral attachment can be taken. One maneuver, this one where the assistant holds the proximal descending and the surgeon holding the distal descending colon, sort of straightening it out so that we can take down these lateral attachments easy until we see our gauze piece. So once we reach this gauze piece, we go to the supracolic compartment and enter the lesser sac. Entry into the lesser sac can only be confirmed once we are clearly seeing the posterior wall of the stomach. Sometimes this omentum is fused in many layers. So until we see the posterior wall of stomach, so that was the anterior wall which we saw there, we have to take a slightly deeper plane and dissect between the transverse mesocolon, and that's the true entry into the lesser sac. The vessels, vasa recta of the middle colic, of the transverse colon can go a little high up here. So don't stay too close to the colon. Here we are taking down the omentum because the lesion is at the splenic flexure. When we take the omentum, be careful to protect the left gastroepiploic vessel at its root from the lower border of pancreas. To complete mobilization of the entire left colon, we have to take down the omentum almost near the falciform ligament, which is up to the midline. So that is exposing basically the middle colic artery from the anterior surface. We saw it from the posterior surface. So that's the middle colic artery there. So this mobilizes the entire left colon from the middle colic. For this last portion of the splenic flexure, I use this Saklani maneuver. I call it so because I learned it from Dr. Saklani. So we need to have this traction on the splenic flexure to put these tissues at stretch. So what I do is the scrub nurse working through the right lower quadrant port holds the descending colon. The assistant is given the omentum to lift that up and create this tissue under traction. The left hand of the surgeon holds the transverse colon and pulls that medially. The right hand of the surgeon working through the right lower quadrant port then use the energy device to divide that tissue, which comes nicely under stretch here. Be careful with the stretch because sometimes that can actually cause splenic tears, as it was beginning to cause here for this patient, because the structure of the spinocolic ligament is actually stronger than the texture of the spleen. So that the capsule was beginning to get peeled here, so quickly cut it medially. Not much of injury there, easily controlled by just some Surgicel. But that the splenic capsule at least has been opened, although the parenchyma has not been injured. So that's one precaution when we give traction at the splenic flexure. Just control the traction so that we do not cause splenic injury. So with this maneuver, this final tissue comes under stretch here, that is controlling this little ooze which was coming from the splenic parenchyma. When packing this, it is important to put a gauze piece that gives tamponade between the diaphragm and the spleen, because that will sort of give you your pressure. Otherwise, there is no other way we get good tamponade. So with that tamponade, with the gauze piece both behind and in front, that bleed sort of got controlled. So again, using that Saklani maneuver, this last bit of tissue, which is always the difficult part to come under vision. And we can see that gauze piece that helps us, half in the lesser sac and half in the descending colon, which confirms that we have mobilized everything lateral to the gauze piece and completing the splenic flexure mobilization. Second case, this case is a little bit, the lesion may be a little lower down the descending colon. Again, the steps are essentially the same. We again begin medial to lateral. If you come to our OT at TMH, you will see that everybody does the same thing repeatedly over and over again. I think Dr. Ashish has been there. So that's the way we have standardized, and no matter who is operating, me, Dr. Saklani, fellow, begin the same way, then again get the plane below the middle the IMV. And then that gives us this sort of bird's view between the IMV and the IME that helps us to take that accurately at the root. Again, nodal dissection at the root of the IMA. And then here again, we would again go for taking the left colic and the IMV. So all splenic flexure mobilization essentially is done medial to lateral. It is only the last part that we go for laterally. That's the IMV being taken at its lower extent, and then the clip on the left colic artery. Again, preserving the IMA, as again this is a left hemicolectomy. So that is the reason why I put this case, is because we saw an additional artery that is here. So this is, we see sometimes the accessory middle colic. It's good to confirm by seeing the true middle colic, because we do not want to include that in our dissection. So that was the true middle colic that is there. And this was actually very close to our resection, coming within 10 centimeters proximal to the lesion. So we considered this as one of the feeding arteries, and this accessory middle colic had to be taken. So that is the IMV being taken at the lower border of pancreas. And then going anterior to the this part of the maneuver is, we should keep this mesentery from the transverse colon on the descending colon intact. The moment we are not seeing that mesentery anterior to our dissection as we go on the pancreas, then we are at risk of damaging the arcade. So that landmark has to be kept. So once again, confirming that the IMV is separate from this accessory middle colic. Many names for this, artery of Moshkovitz and the whole legend of names, essentially it's the same thing. So we isolated this artery and took it. Again, for a left hemicolectomy, we really have to mobilize completely till the middle colic vessel, because we have to exteriorize I exteriorize the colon and do an extracorporeal end-to-end hand-sewn anastomosis. That's the entry into the lesser sac. A little pull back on the harmonic as we cut this final layer, because the pressure in the lesser sac is negative. So there's the chance of injuring the stomach there. And we can actually do our mesentery division, including this artery, so that this entire thing comes into the site of specimen extraction. As sir pointed out, if you're doing splenic flexure via robot, that's the port we use for the robot, exactly same as Dr. Kalarasan. But as we go to the splenic flexure and we want to get this traction, that is where the robotic ports start colliding, and that is where the surgeon starts losing its temper and starts swearing at the assistant, because that triangle is where the ergonomics of the robotic instruments for this port position, where the fighting starts happening. So what I have shifted to do is, I spend 10 minutes or maybe 20 minutes doing this first part laparoscopically through the robotic ports itself. We can use the energy device which is not there on the robot. So all I do is take out this, the omentum from the left part of the transverse colon, enter the lesser sac, and then just divide this omentum from the distal transverse colon, taking it towards the splenic flexure. As we go towards the splenic flexure, we can see that the traction here sometimes will pull up the mesentery of the transverse colon. So we are taught that we should go close to the colon, but you can see that the mesentery sometimes gets pulled up because of adhesions. So see the difference between these two fats, the omental fat and the mesocolic fat, and then continue the dissection. So object here is not to mobilize the splenic flexure, because that we're going to do with the robot medially. The object here is just to divide the peritoneum at the bend of the colon. So that's the peritoneum there at the bend of the splenic flexure. The object is to just divide this peritoneum, and we'll see how easy we can meet it with the robot. In my experience, I think this saves about maybe 40 minutes to an hour. Doing robot, we don't have to undock, put an additional port. We can just divide this peritoneum also at the lower part of the pancreas. No dissection really is required, just the peritoneal division, because that dividing form medially, as we push, it tends to keep on pushing the peritoneum rather than dividing it. So once that is divided, we can put a gauze piece here and place the gauze piece well in that area, and then position the colon as we normally do, dock the robot. Again, robotic or lab, whatever we do, the protocol is the same. Plane below the superior mesenteric artery, develop the medial to lateral plane just above the retroperitoneal vessels, then identify the plane below the IMV. The more we standardize, the more it becomes boringly similar, and the more predictable are our results. So that's the plane there below the IMV. Then this is for a low anterior resection. So we would take the IMA for this patient. So that's the nodal dissection at the root of the IMA, which is isolated, clipped and divided. And then we will do the standard medial to lateral dissection. I have kept this speed at original speed. We can see that robotic works a little slower because we are working through the robotic interface. And that is in keeping with the time is always a little longer for robotic as compared to a laparoscopic procedure. But essentially the procedure is the same. And as we go medial to lateral, we can see that with just little division and getting the right plane, moving upwards towards the pancreas there, and we have our gauze piece placed there, and with as we go down into depth, we can easily see our gauze piece. We know that we have mobilized everything lateral to the gauze piece. So essentially that completes the splenic flexure mobilization without any collision with the perfect ergonomic position of the robotic arms. And I do think it saves a lot of time because we have a good energy device which we can use laparoscopically, but cost and other issues for robot is getting energy device to divide momentum and everything is an issue when we use only robotic. So with the gauze piece there, we can just cut across the gauze piece and the entire splenic flexure is essentially mobilized. Last part here is to complete this medial division of the mesentery of the transverse colon on the anterior surface of the pancreas and to take the IMV. So we see already we have entered the lesser sac there. Robotic instruments working medial to lateral, they work really good. But for that small portion of the lateral to medial that is required for the splenic flexure, there I feel that with this port configuration and not changing and putting in the additional port, we struggle a little bit. So I tend to use the robot for what it's used best. One word of caution here is avoid the fat next to the pancreas. So there is peripancreatic fat there. If we enter that peripancreatic fat and not in the exact plane, then we are going to get bleeding like that from the pancreatic vessels. So stay above the peripancreatic fat and just at the fusion plane between the colon, the colonic fat and the peripancreatic fat. So with good traction, we can just take these last attachments of the mesocolon of the transverse mesocolon and complete the mobilization. Again here, the object is to meet our gauze piece. So we can already see the gauze piece in the depth, and that completes the complete splenic flexure mobilization right up to the middle colic artery that is there. Again, going from lateral, we don't have to go all the way up. because we have made those incisions in the peritoneum there. So with good traction, again here, meeting the gauze piece from 3 points. One is when doing the Taltz fascia, second is when doing the dissection along the lower border of pancreas, and third is when taking down these lateral attachments. So these are the 3 points we meet our gauze piece that we have placed, and that completes the splenic flexure mobilization when doing robotic. So thank you very much. Yeah.
Thank you, sir, for this wonderful talk. Any questions from the audience is welcome.
So you showed it so great laparoscopically. Do you actually need robo for this surgery?
Yeah, so robotic advantage for colon is not that much, but in the next talk you'll see the little struggle we have for laparoscopic in the low pelvis ISR. There I think the benefit is little there for the robot, yes.
Another appreciation is for your use of monopolar cautery. The way you develop the plane, it was wonderful to see. People are always in the frame of mind that you need a harmonic or ligature to develop these planes, but I think even monopolar hook can also give you the best dissection. Amit?
Sir, actually, for the younger colleagues, the retro mesocolic dissection, sometimes in laparoscopy for initial experience is sometimes is tricky. So I started my this kind of mobilization by doing the entering the laser sac first. What you do in the robotic. The same way I started doing, so that you can do with head elevation and then put patient in the tender bed position and do the everything in standard bed position only. Then you need not to do again head elevation. So it's just for the younger people who may find difficult.
Yeah, so what I used to do first for the splenic flexure, I used to do the reverse Trendelenburg as you said. But as you see in the later video, I have changed my technique a little bit. So that you will understand later as I show. We don't need to change the position for that. But your point is well taken. Just like we do for robotic, we can start with lesser sac as well first, because that would give us some landmark in the lesser sac. We can put a gauze piece there. And I do understand the plane above the pancreas there is a little bit tricky. And in the beginning, it's maybe a little bit difficult to differentiate between the peripancreatic fat, especially in the obese patients. So there, access to the lesser sac, putting some gauze piece there will help, definitely in the beginning.
Pancreatitis, some collection there because we have injured a bit of pancreatic capsule with the harmonic here and there, which when you learn to get into correct plane, you tend to avoid.
Yeah, that's true. So we should try and avoid that, injuring that pancreas. So above the peripancreatic fat, the plane actually is between the two fats, not seeing the capsule of the pancreas. Yeah.
Thank you very much.
Thank you.
Thank you, Dr. Ashwin and the chairpersons. We will now proceed for the inauguration ceremony. I would invite Dr. Ashish to do the honors.
We'll get the stage ready for the inauguration. Following fantastic sessions by Dr. Ashwin D'Souza, Dr. Kalerasan, and from Egypt. We'll have this inauguration and then we'll continue with our workshop schedule. Talk by Dr. Ashwin D'Souza again. So, friends and seniors, this is a special occasion for me, witnessing my mentors, accomplished seniors, and enthusiastic friends assemble for a single theme workshop on minimally invasive colorectal surgery is really a fulfilling and incredible feeling. I wish to express my sincere gratitude to all the illustrious surgeons and physicians participating in this inauguration, A special mention to Dr. Nayan Swadhya, my first mentor in surgery. Dr. Dr. Rupesh Mehta, if can join Dr. Pankaj Modi, sir. Dr. Sunil Popat, please, sir, join us for the... Can we have the chairs? Please arrange the chairs. Sir, Dr. Swadhya, sir, please. Dr. Asit Patel, if he's there in the audience, please. Thank you, sir. Dr. Asit Patel, if he's there. Dr. Pankaj Modi, sir, yes, please join us on the stage. Dr. Ishit Shah, if he's present. Dr. Balkrishna Tanna, sir, please join us. Please, sir, whatever suits you. So I continue to be profoundly impressed with our faculty who have traveled from Mumbai and Pondicherry, Dr. Ashwin D'Souza and Dr. Kalai Rasan from Tata Memorial and the Glorious Jipmer respectively. And I sincerely thank them for taking all the trouble of traveling for this scientific cause. Sir, we have learned a lot from you. We have learned the tricks of the trade and we continue to practice the way you do. Thank you very much. Sir, please join us on the stage. Dr. Kalai and Dr. Ashwin D'Souza. Yeah. So this is my first time I'm organizing some scientific event, and please pardon any deficiencies from my side. So I especially want to acknowledge and thank Dr. Ahmed Shukri Hafiz, who joined us online. We keep cursing the virtual world, but these are virtually the masters from whom we have learned the tightrope walk between surgical advancements and patient safety. I also want to thank Dr. Sanjeev Haribhakti, who will be joining us in the afternoon session, and other speakers and chairpersons for putting the best foot forward in disseminating the knowledge and skills in this domain. I want to specially thank and welcome all the delegates and residents who have made this event memorable. And there was in the morning a fantastic parallel postgraduate session. I thank all the teachers who have traveled from, visited from medical colleges, sparing their time on Sunday from VSLG Civil Hospital and elsewhere. A big thank you to my organizing team, Dr. Maulik Mehta, Dr. Ankur Patel, Dr. Asit Patel. Maulik, Ankur, if you could please join us. You guys have been phenomenal in this event, seeing the light of the day. So we'll now have lamp lighting, please, dignitaries, please. much as I would have liked to listen to many of you or all of you, we are really running short of time. We are behind the schedule by half an hour or so. And I request all of you to please take your seats and we can resume the scientific session with Dr. Ashwin D'Souza once again for another mesmerizing video talk.
Our next session is on lab TME for rectal cancers by Dr. Professor Ashwin D'Souza. I would welcome on stage Dr. Mannari, Dr. Manish Gandhi, Dr. Harshad Soni, Dr. Chirag Desai, Dr. Naresh Gabani to chair this session. Thank you.
Hello.
So, can we start? We'll start. Good. So
Yes,
this case is little different from the previous one. The previous case was edited and selected from 3-4 cases to show technique. This is more of a workshop case where we will see the problems as we face it, and we will see how we try to overcome it during the laparoscopic case. So this patient is a 65-year-old male patient, a lot of comorbids but well maintained, bleeding PR, growth at 7 centimeters. Scopy is showing the growth at 9 centimeters, rest was all normal till cecum. Biopsy was intramucosal adenocarcinoma in a background of Willis adenoma, MSS. PET CT was done outside itself, it shown it was non-metastatic. That is the MRI, which shows a T3A N1 upper to mid rectal lesion. So our plan for this patient was to go ahead with short course radiation and early surgery. There was just one positive node. As I mentioned, the surgeon uses the right 2 ports, the left hand providing counter traction and the right hand is the working port. And the assistant provides 2-point traction using the right and left hand through the left upper and lower quadrant ports, camera in the center just above the midline. So we gain access and do the staging laparoscopy that is there for standard procedure as we begin all cases. And right at the beginning, I take this camera port back until the black line reaches the rectus sheath and fix it in that position. This helps getting good access to the root of the IME and prevents that port from going and migrating during the dissection. Right at the beginning, we see omental adhesions. So this is the real life case that we have. And they're not just small flimsy adhesions stuck to the diaphragm. And I have edited quite a portion, but all this is densely stuck there to the diaphragm. Taking down as much we can reach the spleen. The object here is to free the omentum because we need to place the omentum along with the transverse colon below the left lobe of the liver to get place to mobilize the place the small bowel. Further adhesions between the falciform ligament and the omentum. So object here is just free the omentum enough so that we can reflect it below the liver. Going down along the falciform, the adhesions were just dense right in the Morrison pouch. So I decided maybe that's too much. So omentum is going fair enough below the left lobe, but not on the right side here. Morrison's pouch is all fused, so we will leave that. Trying to flip that last part of omentum, further adhesions there. So as I'm taking down these adhesions, already I'm preparing my mind that most probably this is going to be a difficult splenic flexure with the omentum all stuck there to the colon. So I'm already getting ready for that. The transverse colon is then pushed below the left lobe of the liver. And then we start with the usual maneuver of giving Trendelenburg position and trying to position the small bowel. Here the colon did not go into the Morrison's pouch because of the adhesions that are there. And that, as you see later on, restricts the place available to position the small bowel. Bowel positioning sometimes is taken for granted, but can go up to half an hour, 40 minutes sometimes. It becomes difficult. So here first objective is to reflect the small bowel along its line of attachment of the small bowel mesentery from the right iliac fossa towards the DJ flexure. Colon also quite distended, we can see there, filled with gas. And that's the jejunal loops which I'm trying to push on the left side. Normally I try to put all the small bowel on the right side, but when it doesn't get positioned like this, I went back again and the bowel again is falling towards my view there, as you can see. So okay. So then, and these conditions, I will keep the jejunum on the left and keep the ileum towards the right and get enough access only in the area where I'm working. One useful trick is here, if the colon is distended, pass a Foley's catheter per rectally, deflate that colon, and you will be surprised how much room you will get. Initially, we are not able to access and even see the pelvis, but after deflating the descending and the sigmoid colon, with this Foley's inside, they can see the colon there has gone down completely. Then we can actually get good access to the pelvis. It's a narrow pelvis, but at least we can see into it right at the beginning. And this small bowel is going to be a little bit difficult. It happens sometimes. It happened in this case, so I just want to show how we deal with it. No matter how much we pushed over here, it was falling back. So the first thing we do is put in a gauze piece and try to wedge the gauze piece between the small bowel and the lateral abdominal wall. Here we use the full length gauze piece to try and wedge it here. So initially it was holding there to some extent. Our access here is to just keep it lateral to the common iliac vessels. As long as the bowel remains there, it's fine. We have enough access to the root of the IMA. So first gauze piece placed there, looks promising to start with. But then we need to put the jejunum also towards the left. So the bowel holding there in position. Jejunum also is falling inside. So a second gauze piece here, again full length gauze piece to keep the jejunum on that side. Object here is just to expose the IMA to its root. And as we shift to the different parts of mobilization of the colon, we'll have to reposition the bowel so that we get our exposure to the area we are moving. Then starting to raise the rectal mesentery to expose the IMA, but again, the bowel is coming inside. So this is edited to maybe 3 minutes, 4 minutes, but it is quite a lot of time was invested in this. So the main route is sometimes we have to take down these additions. The only reason why I'm using a cautery here, I would have used a scissors, because the scissors that was on table in this on this set was not working well. Again, real-time problem, so that's the scissor we had. So anyway, we managed to mobilize somewhat. And with that little bit mobilization, the colon remained there, just lateral to the iliac vessel. So that's the aim for mobilization, minimum required to access the right leaf of the rectal mesentery. Procedure again begun, incising the peritoneum along the right leaf of the mesentery, going down towards the pelvis and above towards the root of the IMA. Here we are looking to see the lower border of the superior mesenteric artery. We can see those pulsations there. If we go anywhere posterior to that, we are at risk of damaging the hypogastric nerves right at this level. Taking down these peritoneal attachments, again, we are seeing the undersurface of the artery, and the plane is just below that, and all this fibrofatty tissue actually has the abdominal sympathetic plexus, which has to be preserved. If we damage the nerves at this level and preserve the main trunks of the hypogastric, there's no point. So again, staying here, trying to find the plane. It's also a fatty patient here, making small cuts to drop these retroperitoneal vessels individually until we find that plane there. So ureter there, and that is the gonadal vessels there. Again, always make a small cut on the retroperitoneum vessels and try to drop them down. So the vessels like that, we just cut them because those vessels belong to the retroperitoneum. That is the actual final plane of fusion, embryological fusion plane between the colon and the retroperitoneum. Continuing this plane little superiorly, and then as per our procedure, we have to go for the IMV. So again, using the gauze piece to push that jejunum away and tent up the IMV with the left hand. Again, object here is to go just below the inferior mesenteric vein, first incising the peritoneum there. We can see we don't have much access because the mesentery of the small bowel is quite fatty, and we don't have much room. But staying just posterior to the vein, we are able to find that plane and continue this peritoneal cut down to the root of the IME. So put a gauze piece there to help keep this mesentery away and help us to find that plane we dissected later on when we go to clip the IME. Then we continue dissecting at the root of the IME. Here, to avoid injury to the hypogastric nerves, I dissect only on the right side, taking the small sympathetic branches as they leave the abdominal plexus, aortic plexus, and they go on to the IME. So relieving the rest of the plexus behind, taking all the fibrofatty tissue from the inferior surface along the right surface to the superior aspect. Again, we can use harmonic also, but monopolar works well in my hand, so I use the monopolar for this as well. Dissecting, taking out all the nodal tissue, and that's where our gauze piece for the IMV plane helps us to find our endpoint. So usually we are able to see this, but because the access was very limited in this patient, that gauze piece helped us to find our endpoint. Here there was a lot of this neural tissue around the IMA, which was too big to be taken. So we have to thin it down. Sometimes there is considerable amount of this neural tissue, and to able to comfortably put a clip, we have to thin this down. Then going just flush to the artery, and we know that the left hypogastric trunk is deep to our mixture. We are not dissecting that at the moment. The moment we clip and divide this artery, then we will get good access to see the left hypogastric trunk, which can be preserved. Again, double clip, we all do that, I think, because direct branch from the aorta. And then not much place. If there is place, we can use energy, but here not much place, so just scissor to divide. And once that is divided, the assistant will lift up this the IMA, and we can see the left hypogastric trunk, and we need to only divide the branches that go onto the IMA. So this preserves the sympathetic supply at its origin from the abdominal aortic plexus. Then the medial to lateral, again staying in the correct plane and going between the embryological fusion layer between the mesocolic plane and the torus fascia. Try and go as much medially as possible, because splenic flexure mobilization is more a medial affair. Laterally, it's only to take down the attachments, and continue above till the lower border of pancreas, and continuing lower down right up till the right iliac fossa. Now we proceed to take the access to the lesser sac, as we have seen for splenic flexure mobilization. So take down these attachments, peritoneal attachments between the DJ flexure and the IMV. Bowel has to be repositioned, because this patient did not have a habitus to get all the bowel in the right side at one time. So now the bowel is pushed on this side. You can see the access we have, it is very less. But as long as we can see the entire laparoscopic instrument and to see the pedicle we are ligating, that's all we actually need. We do not need full retraction as we require in open surgery. Just the area of interest, the entire blade of our energy device and the pedicle, if that's under vision, it is fine. Then holding up the mesentery of the transverse colon, again the plan is to divide this mesentery along the anterior border of pancreas. So now here is that patient with a lot of retroperitoneal fat, and very difficult to distinguish what is the peripancreatic fat and what is the mesocolic fat. But there is a plane between there, and if we go carefully, that's entry into the lesser sac there. But I could not proceed any more from medial to lateral. I would have liked to take this plane right down to the splenic flexure, but this bowel kept on falling into our view. So then I accepted this level of mobilization and decided to approach all this from the lateral side. Again, in my mind, I'm thinking that this is going to be difficult because of the omental adhesions that we saw at the beginning of the case. But it's a difficult case and we have to do it step by step. Here is where that, what I call the U gauze piece technique, it helps a lot. Because we can put one end of the gauze piece inside this lesser sac area which we have opened. And the second edge of the gauze piece, we will put at the splenic flexure below the colon. So medial to this gauze piece, in these two planes, we know that we have mobilized everything. If you are able to meet this gauze piece from the lateral side, then that would confirm a complete splenic flexure mobilization. Lateral attachments were probably the simplest part of this case. It is important not to enter the retroperitoneum and stay just outside the mesocolic plane here, because you can end up mobilizing lateral to medial in a different plane, and then you keep on stripping and you don't meet your medial plane. Same maneuver, the assistant holds the proximal descending colon, while the surgeon holds the distal descending colon, straightens it out, and then the lateral peritoneal attachment comes nicely into view. So once you straighten out this descending colon in this manner, the entire lateral peritoneal attachment becomes easy to access. I use the use energy device for this part because we do not want to give too much traction as we go to the spleen. The object at this part of the procedure is to at least see our medial end of the gauze piece. Now this medial to lateral I could not access from the medial to lateral approach, so it has to be done through the lateral side because of the bowel coming in front. And we can see the colon actually going all the way laterally there. So I decided I could not see the gauze piece. I decided to go that little later and go to the supracolic first. Supracolic, while opening, I found that we soon entered a space there, but as I said, until you see the posterior wall of the stomach, we are not sure we are really in the lesser sac. So I thought I was in the lesser sac here. I went and looked and I saw that, yeah, there was some stomach there. That looked like stomach there to me. So I kept on dividing it here. And then as the window opened, so this technique I use, I do not put the position, change the position, but the Trendelenburg helps to put this mobilized omentum. I keep on reflecting it backwards and then lifting up the cutting edge medially. As I saw the window, that is the anterior wall of the stomach, so we have not really opened the lesser sac. So we have to take a deeper plane. So lesser sac entry is only confirmed once we see this posterior wall of the stomach. So now I am confident that we are in the lesser sac and we can go ahead. Again, respecting the mesentery of the transverse colon and where it is fused with the omentum. So we are taught to go close to the colon when taking off the omentum, but when doing the inner layer, always see the mesentery of the transverse colon. Sometimes because of the traction, it gets pulled a little up. So if you go too close, you'll end up damaging the vasa recta from the marginal to the transverse colon. So as we go towards the splenic flexure, we have to divide two layers, the inner side from the lesser sac, which is relatively easy for this patient. And then we'll have to go to the outer side where it is attached. So there are those 4 layers of the omentum as it forms the lesser sac. So the outer layer is a nightmare, but we have already expected this when doing the omental additions. So there is no option. We have to take this down slowly, seeing the colon on one side and careful use of the energy device so that we gradually and systematically take out these omental additions from the entire splenic flexure. Otherwise, there is no way we are going to get the length that we need. So that is working from both sides, the inner side and the lesser sac side, and from the lateral approach. So until all that is left is just the bend of the splenic flexure, and then we can deploy the Saklani maneuver to get that bend under traction. So we saw our medial end of the gauze piece there in the lesser sac, so that is at least one endpoint reached. But the lateral end of the gauze piece we have still not seen because of these significant So that's what I said, move the omentum back over the spleen as you dissect it, and then hold the anterior dissecting edge instead of changing the position. So this is actually the final medial to lateral which we are doing from that's the gauze piece that has just come into view there. And then we can take out these final lateral attachments. The gauze piece should have actually reached this area we were dividing, but we could not access that. This is the Saklani maneuver, where all that is left is this bend, that is the assistant pulling up the omentum. And then systematically we have to take down these final attachments of the splenic flexure to the splenocholic ligament, which has to be divided. Right, so the gauze piece here, especially for this very fatty patient, plays a very important role, because as we go down here, we are also concerned that small bowel may be coming medially, but we can actually cut directly on this gauze piece, knowing that the small bowel is medial to this, and all that remains is this tissue anterior to the gauze piece. So I'm not really seeing much. I'm just staying on top of the gauze piece and dividing these final attachments. And this is where placing this gauze piece in this U fashion helps. And once we release this gauze piece, we are confirmed that the entire splenic flexure has been mobilized. So that was a difficult splenic flexure. What I showed before was the textbook one. Once again, reposition the entire small bowel. It has to be done. Jejunum, here we can put considerable amount of jejunum on the left side because we are not going to access that again. Get more space on the right side. So we can put this bowel actually deep into the Morrison pouch. Sometimes we don't do this maneuver, but by putting this terminal ileum deep into the Morrison pouch, we get little more access. We get more access, and this bowel comes out of view there. Again, we only need access into the pelvis. So as long as we have that access, we are happy. Rectal mobilization begins with this 2-point traction, one at the IMA pedicle and one on the upper rectum. And then we incise the right leaf. The end point here is the medial aspect of the rectovesical fold. The ureter will lie lateral to this medial aspect, that is somewhere here. That is the medial aspect of the rectovesical fold. Dissection here is by good anterior traction of the left hand, and to stay at this interface between the areolar tissue and the mesorectal fascia. This areolar tissue is the presacral fascia that protects the presacral parasympathetic nervous plexus. So that is the basic principle for this posterior mobilization. Stay at the interface between the areolar tissue and the mesorectal fat. With serial traction and going down, we continue and we reach the levator that is just seen there in the midline. Then we go for the right anterolateral dissection. Begin the peritoneal dissection, peritoneal cut here, and then continue anteriorly. I would keep the lateral dissection towards the end and try to develop the anterior plane first, because posterior we have already developed. Once we develop the anterior, we can meet the anterior with the posterior around the lateral aspect of the rectum where the plane is least well defined. One important part here is, as we give traction, the inferior hypogastric plexus, which is this white structure, gets pulled medially. We have to divide the branches from the inferior hypogastric plexus to the rectum while preserving the rest to the bladder. And as we divide that, we can see the plexus actually goes laterally. So continuing that posteriorly, then finishing the anterior dissection more. Here, because the pelvis was narrow, I could not finish the full anterior dissection first. So little anterior, then do the lateral, little more anterior, do the lateral to completely mobilize the right side. So that is little more lateral going ahead. As we go down below the level of the seminal vesicle, there is the lateral recess of the mesorectum. So this is got by following the fat that goes a little lateral and right up till the lateral pelvic side wall. The smoke you see is because of the short course radiation, and this is operating on the 5th day of radiation. So within 7 days, it is okay. After 7 days, the edema becomes prohibitory. Dissecting anteriorly here, just posterior to Denon-Villiers fascia. This is a T3A lesion. For anterior based lesions and anterior peritoneal reflection involved, we would take the Denon-Villiers fascia as part of our dissection. Once that is defined, we do the anterior lateral portion and taking off this mesorectum right up till this areolar plane with the lateral pelvic side wall. Now while dissecting here, I encountered this vessel that I hit. I don't think it is it is the middle rectal. Maybe I went little too lateral and hit one of these prostatic vessels. So put one clip but did not stop. So tried second clip, that also did not stop. Then try with a energy device, but that the clip was coming in the way. The problem here is because of the traction, the moment we cut these vessels, they start retracting into the pelvic side wall. So time for a little suction to see exactly where this bleed. It's gone really lateral. It's retracted there into the pelvic side wall. Two clips not able to control. So we have to recreate that tension to pull this tissue really medially as it was when it was cut. So once we are able to do that, then that will come into view and then we can deploy a clip on it. So we actually take for granted how much traction we have to put to actually put the rectum medially as we dissect. So two clips there and that sort of control this. Here I did go little laterally. I should have stayed on a little medial plane, that plane. If I stayed on that plane, then probably I would not have injured this vessel. So as we go down, follow the mesorectal fat. If you go too laterally, you may hit these vessels that are actually going to prostate and bladder. So continue dissection until we see the endopelvic fascia right on the right side. The question is, this is a 9 centimeter growth, why are we dissecting so low? So the secret to good rectal transection laparoscopically is actually a good rectal mobilization. So especially for the narrow pelvis, unless we get the rectum out, we are not able to get below with the current stapling devices that we have. So proceeding for the left lateral peritoneal attachments, here we use the fan because it does help. And you can see how narrow the pelvis is, just about the fan fits inside this pelvis. For the left side, I put a suprapubic port, and it is surprising how much traction moving this fulcrum of this port closer to the rectum gives. You can see the traction, the total ergonomics changes. And with this suction, we can also suck out the smoke as the cautery is activated. So just by using the suction through the suprapubic port and giving traction on the mesorectum here with the suction, with intermittent suction, we can get good view and dissect just outside the mesorectal, the Denon-Villiers fascia anteriorly and then continuing laterally just outside Denon-Villiers fascia. Again here we see this is the inferior hypogastric plexus which gets pushed medially, and these are the nerve fibers that we have to cut that go towards the rectum from the inferior hypogastric plexus, and as we cut them, that plexus goes back to the side wall after the traction on it gets released. We have to continue our dissection here right down until we see the endopelvic fascia on the right side. So continuing here just outside mesorectal fascia. Here I was careful not to go too lateral because we had bleeding on that side. So yeah, so this probably would be the vessel that I hit on the other side, but that was not part of the dissection. This is the mesorectal fascia and that is the endopelvic fascia over the levator, which is just come to view on the right side. I don't usually use a tape, but when we do, that's how we put it in. The cut edges in first, ask the assistant to hold that, and then the U of the tape, we put in a grasper, hold the cut edge and bring it out through this, and ask the assistant to hold it with a needle holder. The reason why I put the tape, because I wanted to do an intraoscopy to see the lower extent of the tumor. It was quite a small tumor, and after mobilizing I could not really palpate it. So it had gone above. So if you don't put this, the entire rectum gets insufflated with the scope. So that's the colonoscope going in. And to see the level, we have to put off the light, and we can see the light of the colonoscope there. And under vision, the lesion is actually just at the anterior peritoneal reflection. So we need to go at least 3-4 centimeters below that to able to staple and put the circular stapler after rectal transection. So I had to increase this mobilization, continuing both on the right and the left side, essentially taking off the mesorectal fascia from the endopelvic fascia. So that is the right side, dissecting between the mesorectal fascia and the endopelvic fascia. A lot of smoke because of the radiation. So that is the final rectal tube that is coming into view where the mesorectal has ended. Then lastly, we'll do the anterior dissection. And here again, staying just posterior to denonvillous fascia to expose the muscular tube of the rectum below the end of the mesorectal fat. Taking on this, the last portion is the posterior part where we have to divide the anococcygeal ligament. This gives us significant length. The rectum really comes out, but we should be careful that we stay close to the levator when we divide, and otherwise we can risk damaging the posterior rectal wall, and that would convert a straightforward LAR into an ISR. So let's be careful here as we divide this anococcygeal ligament. After dividing this, the rectum comes out quite a bit. Again, I still feel we need a little bit more anteriorly to comfortably put our stapler. I'm aiming here to go at least about 3 centimeters below the anterior peritoneal reflection. The patient was very short and stubby, so that didn't leave much rectum behind. So first step to easy stapling is to do good rectal mobilization. Now the current stapling devices that we have are little limited because first of all, the rim of the pelvis limits that, and it is only flexes to 45 degrees. The new Echelon Plus goes to 60, but because of that, we cannot get a right angle transection of the rectum. So what I do is move the rectum to the left side and aim to put the first stapler just across half the rectal diameter. So once that is done, the rectum opens out, and then we can push the second stapler across the entire rectal stump, and then try and take out this intersection between the two staple lines in the circular stapler. Another trick, always put the fat blade posteriorly because the thin blade can go through the rectum. So same maneuver, no angulation to the echelon, straight inside, engage full rectum, hit against the levator, do a full bend, come back, and actually pull the rectum to the left side, and pull back a little bit to take only half circumference. So we are getting nearly 90 degrees to the long axis of the rectum and the stapler, as you can see. If we try to engage full rectum for this, then we are going to get an oblique staple line. Once the first cartridge has been fired, then the room opens up, place opens up considerably even in this narrow pelvis, and the second cartridge can be deployed in the same manner. Again, engage without angulation, hit the levator on the other side, bend completely, pull back until we reach the intersection of the first staple division, then pull the rectum completely to the right side, and we can see that the stapler has comfortably gone across, and we can see the green portion of the cartridge, ensuring that we are using only 2 cartridges. More than 2, there's data to show that it increases risk of anastomotic leak. So that is comfortably gone across, even in this narrow pelvis with a 60 echelon. We could use 45 as well, but sometimes the rectum is quite bulky, and 45 we may have to use 3. So 2 cartridges, we get division, and the final rectal stump on the specimen side you can see is nearly horizontal. When putting the anvil inside, we try and get the intersection there. You can see it's almost in the center, and I try and get the spike out either on anterior or posterior wall because it offers least resistance than trying to go through the staple line. So that's comfortably there, and then I exteriorize the specimen through by enlarging the left lower quadrant port. So engage this stapler, and then we can close under vision. Once it is engaged, need to confirm the orientation, either follow a tinea or follow the mesentery. And then as we close the stapler slowly, just hold the mesentery and keep it at 9 o'clock position so that it doesn't come in the staple line and it avoids that last rotation as the stapler finally gets approximated. So we can see, although this is a mid upper rectal lesion, we have had to divide because of his habitus and small size of rectum nearly at the pelvic floor. So that is this. We use the Covidian stapler with the tiltable head. The head tilts, and we can just take out the stapler. We always do air test. We put a Foley's catheter inside, and we will leave that catheter inside for 4 days. Remove it on the 4th post-operative day. Fill the pelvis. We can use either 2 bowel graspers, or if you have a laparoscopic bowel clamp, that's also fine. Otherwise, just hold the bowel and press it against the pelvic brim. Good air test to make sure that there is no leak. And then place 2 drains. We place 1 drain behind and 1 drain in front. We use these JP drains. This helps to prevent small perianastomotic collections, which actually is not a leak, but if it gets infected, then it leaks into the anastomosis. So we take these drains out fast, but there is a lot of dissection there. And ever since we started placing these 2 drains, anterior and posterior, we have at least decreased the immediate post-op perianastomotic collections and decreased the chance of these collections getting infected. Such a low anastomosis with short course radiation, we would do an ileostomy and mark the ileostomy proximal and distal limbs, and that is exteriorized. Final histopathology, patient was discharged on post-op day 5 is what we routinely do. MDSC, margins all negative. Closest was CRM nearly 2 centimeters. 5 nodes were positive, so good we actually gave this patient short course radiation, and that was T3 and 2A, MMR protein proficient. Thank you.
Ashwin, congratulations.
Thank you, sir.
That reminds me of your father, Dr. L.J. D'Souza, who was my boss. And I left Tata Memorial Hospital in 1993. What I remember when he used to teach anterior resection, that time not laparoscopically, the 10 commandments. Do you remember?
Yes, sir.
So one of that I saw that about you put the Foley's catheter and emptying the rectum. Do you remember the other things which you used to say? Because at that time the splenic flexure mobilization was not common.
Not routinely done, yes.
Not routinely done.
Yeah,
so that covers the other points.
Yeah.
But any other things that which we have learned that you laparoscopically translate into the...
So essentially all the principles of TME dissection we maintain the same. The only thing is the form of retraction. So before we used to have that divas and the Saint marks and all that. So we do not need that type of retraction now when we go laparoscopically. We only need the retraction at the point of where we are dissecting. So essentially the principles all have remained the same. We have just added 11th commandment, and that is to do it laparoscopically. So post radiation we do stoma for all patients. Because if they have a leak, sir, salvaging that leak to functional status becomes a little bit problematic. So they get a lot of fibrosis, pelvic sepsis, that will heal, but then finally to close the stoma and have a functional anastomosis becomes an issue. So post radiation, which are all the low cancers, we do stoma for all.
Sir, excellent demonstration. Just 2-3 points I would like to know. One, there is a lot of small bowels absolutely refuse to come out of the field. So just putting extra additional port makes life much simpler. One thing that we do extra is, what we do is we use bulldog clamp, tie the silk thread at the tail, put it in the abdomen, catch the mesentery of the small bowel, and through the suture passer we bring it out. This makes life much easier because, see, we can do it, but obviously in other ways, but then that exhausts our mind, and sometimes it becomes so much irritable. So this is one way we can do it.
Next case, I'm going to try that one. That's a good tip. Because you don't need a port also, just suture passer and you can hold it in position.
And bulldog is very tissue friendly basically.
Yes, yes. What bulldog clamp do you use?
Laparoscopic bulldog clamp through the 10 millimeter port.
Okay. Good idea. I think I'll use that next time.
Sir, excellent demonstration. Here, Rashesh, here, down. Sir, I really congratulate and thank you for showing all the struggles. You could have easily edited those and put a simpler case as happens in the workshops. But I really thank you for showing all the intraoperative small complications. Sir, have you ever, yeah, he deserves a big round of applause, definitely. Sir, have you ever tried a epigastric port between the xiphoid and the umbilicus that will help you retract the small bowel? It will also help you the cranial tract. The one tip that again I want to highlight is the cranial traction of the mesocolon. That is, the transverse mesocolon.
Yes.
That opens up the mesocolic plane from beneath. And if you leave it to the assistant from one of the superior ports, you can incise the mesocolon just above the pancreas and get the splenic flexure from there, the mesocolic plane from there. So have you ever tried it? To me, it is very, what you call, it's very useful kind of.
Epigastric port
between xiphoid and the umbilicus, and you can use it to retract or if you are not able to reach through your two right hand and left hand working port, you can climb up, use this epigastric port as your left hand working port, and continue with the right. To me, it is very ergonomic.
Yeah, so I used to do that, sir. I used to do that. Put another port in the epigastrium, and that helps in the traction on the omentum and also on the mesocolon there. But now I find maybe somehow I can manage by avoiding that.
That is for lesser models like us. Thank you very much.
Sir, one last question. What is your take on putting camera on the right of the midline? Some people put the camera on the right of the midline and they say it is a little bit easier to go deep in the pelvis. What is your take on that?
For me, the right of the midline gives you better access to the root of the IMA, that is true. But for the pelvis, I prefer the midline view, sir. Because then you can see both right side and left side in good perspective. Otherwise, you're little skewed on this side and you tend to go more on one side than the other. So pelvis I prefer in the midline, but for the root of IMA, yes, maybe little on this side. So we can use the trick that Dr. Kalai had shown, make that 12 port over there. So for the beginning part, you can put, if you're not comfortable with the midline port, you can move it to the right upper port, if that is also 12. But I found that by taking this little step of pulling that port back as far as possible and stitching it there, that gives good access with good pneumoperitoneum. That small thing, and during the case, that doesn't go inside and out the port. So that does not, that gives you a constant view for the root of the IME, and I think that also works well.
I like the details you describe while dividing the lower rectal stump, how you use two cartridges or the details you went into. So what are the tips for a little higher division where there is a bulky mesorectum?
So the higher one comes in when you are doing a tumor-specific mesorectal excision for the upper rectal cancers. There we have to divide the mesorectum completely with harmonic or any energy device. There, sir, I feel that one cartridge is usually enough after dividing the full mesorectum. So I very rarely use two cartridges there. That is for quite simpler rectal transection. Problem comes down when the lower rectum, you cannot really bend it to get the right angle. So upper one is, it feels okay, sir.
Thank you.
Yes, so that what I said was the tumor-specific TME, which is only applicable for lesions that are above the anterior peritoneal deflection, upper rectal cancers, where we need to get only 5 centimeter distal margin. But any lesion that is in mid and lower rectum or at or below the APR, it is full TME for all of them. Yeah. So this is only the upper rectal cancers.
Thank you, Dr. Ashwin, for this wonderful insights into the intraoperative complications which one can face during such a procedure. Thank you all the chairpersons. Our next speaker for the day is Dr. Kalai Rasan, who will guide us about lap intersphincteric resection. To chair this session, I would like to invite on stage Dr. Shailesh Patel, Dr. Hitesh Chawda, Dr. Bharat Shah, Dr. Hemant Lehua, Dr. Nitin Singhal, Dr. Premal Desai. Thank you.
Thank you. I think that was a wonderful presentation from Dr. Ashwin. So, since the initial part, I think most of the abdominal and the pelvic part was covered. So I'll focus mainly on the intersphincteric anatomy, and so I'm going to show the robotic video because intersphincteric anatomy, it is better shown in robotic than at laparoscopy. So apologies for that. So I'll quickly take you through the anatomy and then the so a video of the procedure. So that will be the overview. So what do you mean by intersphincteric? Because there's always confusion when you call that you have done an intersphincteric resection, when you call as ultra low. So we'll just clarify that mainly for the purpose of residents and the anatomy, the technical points. So we all know the anterior resection is above the peritoneal reflection, which is mainly done for the distal sigmoid tumor, and we call it as anterior because we approach through the laparotomy in contrast to the posterior approach commonly done in pediatric age group for anorectal malformations. Then the low anterior resection, we go below peritoneal reflection, usually for the rectosigmoid or the upper rectal tumor. When you call as ultra low, so your division is at the level of pelvic floor, which means the mesorectum has ended and you divided at the level of pelvic floor. The difference between the ultra low and the intersphincteric resection is you don't go into the intersphincteric plane in ultra low, whereas you go into that plane in intersphincteric resection. So that's the key difference which you need to understand. And for that purpose, we need to know how to enter the intersphincteric plane, what are the landmarks to go into the intersphincteric plane. So that's just explaining what I have mentioned so far. So the intersphincteric resection means, so we have gone into the intersphincteric plane, and depending upon our level of transection, it could be partial, in which you have taken part of the internal sphincter, and generally it is at the level of dentate line. And if your level of transection is at the intersphincteric groove, then you have taken whole of the internal sphincter, that is a total intersphincteric resection, and anything in between is called the subtotal intersphincteric resection. So we need to understand the anatomy so that we know how to enter the intersphincteric plane. So we know that rectum has the circular and the longitudinal muscle at the level of the pelvic floor. So the circular muscle becomes thickened and forms the internal anal sphincter below the level of the pelvic floor. And then the longitudinal muscle gives some fibers towards the sacrum and coccyx, and this is called the hiatal ligament. So these are the extensions of the longitudinal muscle that goes towards the coccyx. So once you divide the hiatal ligament, then you go into the intersphincteric plane posteriorly. Now this is the hiatal ligament. So this is basically the extension from the longitudinal muscle towards the coccyx. You can see here, so normally the posterior plane will be very kind of loose aerial tissue, and this area where you have the hiatal ligament, you feel that slightly more fibrotic, and then once you divide this, so you can see the contracting fibers. So the contracting fibers are the pelvic floor because they are the skeletal muscle fibers. The internal sphincter, they are smooth muscle fibers, so they don't contract. So that is one of the way of knowing that you have, this is the pelvic floor muscle and then the internal sphincter. So the hiatal ligament is a good anatomy for posteriorly. So again, so that is, I mean, sometimes we call this anococcygeal ligament, but this is different from, strictly speaking, the anococcygeal ligament is from the lower end of this longitudinal muscle fibers going into the coccyx. That is different from the hiatal ligament. So this basically differentiates the post-anal space into superficial and deep. So then the anterior, because it is the anterior anatomy which is really difficult to understand and appreciate. So I mentioned that posteriorly it extends as hiatal ligament. Anteriorly, the longitudinal muscle fibers send some fibers towards the urethra. This is called a recto-urethralis muscle. And dividing that recto-urethralis muscle allows you to enter into the intersphincteric space. Basically, the intersphincteric space is space between the internal and the external sphincter. And the same in female, you have the rectovaginal septum, which is more fatty. And then as you come towards, it's less defined. It's called as anterior dense tissue. But technically, it is not difficult to enter into the intersphincteric space in female. Only in male, we have challenges. So this is, you can see the, this is the pelvic floor muscle. And then you can see this is basically the rectal muscle fibers extend anteriorly. It's called as recto-urethralis. Again, it's not, you don't see as a distinct. The key is giving a good traction anteriorly. And you can see here, these are the neurovascular bundles. Okay, so which means they do not belong to the rectum. So you need to stay posterior to that, these vessels. You need to stay posterior to that. And these fibers which are going towards that, so that is the recto-urethralis. And then you kind of keep reducing your traction, increasing, identify that, and then divide the recto-urethralis muscle. So that will lead you to the intersphincteric plane anteriorly. Again, it becomes easier to define this anatomy in the robotic because you have the very stable vision. So that is the main reason I selected the robotic case. This is not very specific for the intersphincteric. Just to again emphasize that point, normally when we call TME, it is, we call it as between the presacral and the mesorectum. So mesorectum encloses the mesorectal fat. And this presacral fascia, it's actually two layers. The one layer which covers the presacral vessels, and the second layer which covers this nerve. So when we call it as TME, it is between the mesorectum and the layer of this layer of presacral fascia, which is also called as the pre-hypogastric fascia, also called as the Kinugasa fascia. So when we call TME, it is between these two planes and not underneath. So this is one of the very basic anatomy point which we need to remember. You can see here, this is the hypogastric nerves, and the hypogastric nerves are covered by a layer of fascia. So our layer of TME plane is between that fascia which covers the nerves and the mesorectum. So once you go in that plane, then you preserve the nerves and also the sacral fibers, the parasympathetic fibers which come from S2 to S4, which joins with this nerve fibers. This I'll skip. We generally, when you do ISR, we do a high ligation of IMA, not for oncological reasons, but to gain length. Because studies have shown when you do a high ligation of the IMA, you gain at least 5 centimeters additional length, could be even up to 10 centimeters. So that is the main reason for doing high ligation. So I'll directly go to the video. Before that, now when we typically, I mean, even I understood, like when you do ISR, you have to do a anastomosis from the anal canal. But now, like after robotic, we just gone very deep. And then if you have the robotic stapler, you can still do a anastomosis from the abdomen. So ISR does not mean that you have to do the coloanal anastomosis from the perineum. You can still do a stapled coloanal anastomosis. So, but only thing is you need to apply your stapler in the exact location where you want, which means roughly around 3 centimeter from the anal verge. So you need a good traction on the proximal colon using the umbilical tape. So we just use suprapubic port in difficult cases. Start with 45 mm cartridge. Obviously, if you have the robotic platform, because you have the 3D vision, then it does help. So I'll show one of the case. Probably the initial part, bit of repetition, but that's a laparoscopy, so you can see a robotic one. The steps going to be same, except that you'll have a stable vision, so you can do it much more comfortably. And so first is getting into the proper plane, the TME plane. So whenever we do this procedure, we always keep thinking in our mind, am I seeing a structure which I'm not supposed to see, which means in a plane. So the things what we are not supposed to see is ureter lying bare, gonadal vessels lying bare, or the psoas muscle. So which means if any of these structures are lying bare, then you know that you have gone slightly into the deeper plane. So that is always something which is useful to keep in mind. So here, as it was rightly highlighted in the last talk also by Dr. Aishu, so stay close to the blood vessels because you will have the sympathetic fibers. So it's very, very important to stay close to the blood vessels rather than moving away. Because that risks the injury to this nerve. So you can see this is the left colic, and then we are going proximal to the left colic. So we do that high ligation. Just skip it. So that's the division of the vein. So I thought we'll focus more on the pelvic part. So as you can see here, we keep the gauze and then match that plane laterally. So at one point you can see here the muscle is, so mainly just to show that it's lying bare. So which means I've gone in a slightly deeper plane. So you quickly adjust the plane so that you stay in the right plane which you created from medial. So that's what I mentioned. So if you are seeing structures which you are not supposed to see bare, then reorient your anatomy and then stay in the right plane. So staying in the right plane is key in this surgery. So you can see here all the ureter, the gonad vessels, all of them are covered by this fascia, the retroperitoneal fascia. So that's the part of the splenic flexure. Obviously, it is very important to do that. Now we go into the pelvis. So staying in that plane which I mentioned between the Kinugasa fascia or the pre-hypogastric nerve and the mesorectal fascia. Then we keep going posteriorly till we reach the hiatal ligament. So I've taken the male pelvis because as we know that it's male pelvis is what it's a bit challenging to go into the intersphincteric plane. So again, when you do a lateral, so you need to remember that it's not preserving the hypogastric nerves at one place. So we need to preserve them posteriorly, laterally, anteriorly. So just keep that in mind. So good traction, counter traction is the key. Dr. I should mention he does the anterior before doing the lateral. I mean, we do the, so that's some differences. We do the lateral and then come to the anterior. Again, you need to remember, see, this is very important. So you can see this is actually the nerve. So sometimes if you not careful, because here also the plane appears good. But if you go in this plane, then you are actually going lateral to the nerve and you risk of injury this nerve fibers. So that's very important, staying in the right plane. So once we do the both sides lateral, then going into the anterior is relatively easier. So you can see here, so we need to stay posterior to the denodulus fascia, which means you should not be seeing the seminal vesicles. You can see here the seminal vesicle. They should not be lying bare, should be covered by the denodulus fascia. And then, so traction, counter traction, so you lift it. We stay post. Actually, so there is a difference in the, understanding. And some anatomy books tell the denodal fascia itself is 2 layers. So you go in between the 2 layers. But the point to remember is when you are doing the surgery, the key is this should not be exposed. So you should have the fascia covering the seminal vesicles. Otherwise, if they lie exposed, then you risk injury to the neurovascular structures, because neurovascular structures will be underneath that fascia. So you should not. We tend to preserve it. We keep going in that same fascia, because prostate also, again, we don't get into the prostatic plexus, because if you stay in that fascial plane, so then you see the fascia. This is the levator fascia. This is the fascial covering the pelvic floor muscles. So we try to preserve that, because again, that is one of the landmark. The fascia covering the levator, the pelvic floor muscles. So where that ends, that tells you the place where the intersphincteric planes begins. You can see here. So this is the fascia which is covering the levator muscles, and that is again one more landmark laterally. So I told posteriorly we use the hiatal ligament, anteriorly rectourethralis muscle. Laterally we use this fascia as a landmark. Again, one more landmark is you can just apply cautery on the muscle fiber. The portion of the external, the skeletal muscle will contract, and that again tells you where the skeletal muscle ends and the smooth muscle begins. So these are the 2 landmarks for the posterior, the laterally. So So you can see here where this fascia ends. So this is our place to get into the intersphinctic space laterally. Now, so the bladder also we take a stitch as you go into the deep pelvis, so that you don't have to use the one of the arm for retracting that. So retracting the bladder just improves the exposure. Then we tie the umbilical tape, and this will be held by the assistant, because we want to pull the rectum away from the out of the pelvis, because when you want to enter the intersphinctic space, you need some room in the pelvis to go around the lower rectum. So this is what we do. So take a stitch on the bladder, retract it, pull nicely the rectum out of the pelvis, and then the fourth arm will be retracting the prostate, and then you go in. You can see here, so this, you need to preserve that, this neurovascular structures. So that will be preserved if this fascia the denolus fascia is preserved. And then you keep going. Now you can see, you start seeing the pelvic floor muscle fibers here. So that is lateral. And you can see that is the fascia covering the pelvic floor muscle. And anteriorly you have the recto-urethralis. So when you reach the, now you can see the mesorectum has disappeared, which means because we have gone into the pelvic floor, so there won't be any mesorectum there. And then you have this, so you can see here we have just applied cautery, and you can see the from the contraction. So the skeletal muscle fibers will contract, the smooth muscle fibers do not contract. So that tells you where this ends. So two landmarks where this fascia ends, and also by the contractility of the muscle fibers. So these are the landmarks you use, and then you enter into the intersphinctic space. So now we are entering into the intersphinctic space. You can see here that is contracting, but here you don't see any contraction, which because we have entered into the intersphinctic space here. You keep on increasing the traction, because now you are actually getting the anal canal into the abdomen. So this patient, the tumor was 4.5 centimeter from the anal verge. So normally we use the ISR when the tumor is at the juxta-anal. So now this is actually the anal canal, which is into the, pulled into the abdomen. So we are now, actually this is a part of the intersphinctic dissection. Now, so this is not done for ultra-low. Ultra-low you stop where the mesorectum ends, but here you are going into the intersphinctic space. So actually when you, so at this point, actually I'm telling my resident to do a PR. So they are not actually able to put the finger inside, which means we have gone up to 2 centimeter from the anal verge. So that indicates that you have gone into the intersphinctic space, and this is actually clamping the anal canal. So, so I'm asking to do the PR, and so they are finding it difficult, and they're coming by the side. So we are just now coming bit lower. So I'm coming bit higher up, and then so so the point is, which means we can go right up to maybe 1.52 centimeter from the anal verge from the abdomen itself. But the challenge is not going to till that level. The challenge is applying stapler at that level. What we normally do is, if you want to do a stapled anastomosis, you need at least 3 centimeter, because the staple head has to come into the anal canal. So we generally do a staple anastomosis if we are able to staple maybe around 3 centimeter. Otherwise, we do the dissection from the perineum, retrieve the specimen through perineum and do a hands-on anastomosis. So in this, we are able to apply the stapler at least 3 centimeter from the anal verge. So this technique is we have used a suprapubic trocar, and then as you can see, the stapler is coming vertically down, not horizontal. Because at that level, getting the stapler in the horizontal orientation, it's not that cannot be done. If you have the robotic stapler, you can do it. But we don't have the robotic stapler. So this step, we undock, and then a suprapubic trocar is placed, and the stapler comes vertically downwards. So again, we just reconfirm. And again, usually we require 2 staplers, similar to, because anything at that level generally requires 2 staplers. And usually when you do the stapling, and if you observe, so there will be muscle fibers around. So you won't actually see any kind of a bowel wall. So I'll show it when we are applying the stapler. So now it's become routine. Routinely we use ICG to check for the vascularity and decide our level of proximal division. And you can see here, so the ICG shows this is the demarcation. Sometimes it may not be visible. So to the naked eye, it might appear this part is well vascularized. This is a useful adjunct. I think we should use it more often whenever feasible. So you can see here the bowel actually, so this is the point which we have marked based on the ICG perfusion. But with the naked eye, obviously like the pulsation is one thing, but both of the sides appear almost the same color. And then now you can see, so actually now with the stapler head, we'll again get that anal canal out of the sphincter. Otherwise, you can see it is surrounded by the muscle all around. So it's actually a bit challenging to get the stapler head in. And you can see here it's actually bounded by the muscle fibers. So only when it is the stapler is completely engaged, then you will see the wall of the anal canal, and then you engage both the heads. So this is ISR with a trans-abdominal anastomosis. So it's actually a colo-anal anastomosis done from the abdomen itself. No, we use 29 or 31. I think this completes that. So if you have to do, I think the perineum. So if you have to do the, from the perineum, so this is very short clip. You either use a lone star retractor or the stay stitches. And then what we do is we can take the pursing suture. I mean, Rashesh told me to record one perineum. I did, but most of the time my head was covering it. So this is not presently recorded one. And So the point you have to remember is, if you want to make your perineal dissection easy, the key is doing a good dissection with the abdomen. So if you do your dissection right up to 2 to 3 centimeter from the anal verge, then easily you can enter posteriorly in that plane. And then once you enter posteriorly into that intersphinctic space, which you obtain from the abdomen, then you just have to follow that laterally and anteriorly. But if you stop well ahead of the intersphinctic space from the abdomen, then it's a bit challenging to do the perineal part. So that is what we try to achieve. We try to do the most of the dissection from the abdomen, and we use this approach only when we feel that we cannot do a transabdominal anastomosis. And in that scenario, we just do this and deliver the specimen through the perineum. And then do the coloanal anastomosis. You can carry on. Yeah. I think this, it's only short video only. Maybe we can discuss. We are skipping the open house. Okay.
Ultra-low stapler anastomosis vis-a-vis hands-in anastomosis. What is the comfort level of the patient post-operatively?
Yeah, that
because
is, I think
many times the staples, every day they wash their staples.
Sorry, sir, can you please?
Staples. Staples giving a discomfort.
Okay, discomfort due to the stapler.
Because it is coming right at the...
Yeah, actually, that's a good point. In fact, one of the patient had this problem. I mean, she was complaining of pain post-operatively. So we are not sure whether it is due to the stapler, but then we gave the pudendal block in this patient, and patient got relief from the pain. So could be maybe because of the staple line coming up to the anal canal, maybe
but
reason.
there is a real issue because, you know, their comfort level, their surgery done very well. They tell us that they wash clips every day, you know.
Okay. Sometimes. That I haven't heard from the patient, but one of the patients had pain post-operatively, but relieved with pudendal block.
Same is the case in MIPH. When by mistake sometimes they apply the language, the patients are miserable. Okay. It's a wonderful demonstration, extraordinary demonstration.
Thank you.
Excellent presentation. So I just wanted to ask, how are the leak rates, and how do you diagnose before the ileostomy closure, and how do you deal with it?
So generally, the leak is not a very major problem in ISR, because actually the anastomosis is much lower. So the leak often is due to the poor vascularity. So that is the important thing in because initially when we started doing it, when we don't even that time use ICG. So the patients in whom we had this defect, the anastomotic defect, so it manifests as stricture later on rather than the leak, because this anastomosis is so much lower within the sphincter complex. So the collection will not be that significant unless you have a major defect in the anastomosis. So the important point is, don't make sure there's no tension. And second is, ensure that the vascularity of the part which you're going to anastomosis is good. Diagnosis is relatively simpler because you can easily do the rectal, you can feel the anastomosis. And in the ISR patients alone, we do routinely the covering stoma. There are, in fact, a couple of patients we did even avoid covering stoma in this patients after ISR. When we are completely satisfied with the anastomosis, didn't have any issues in those patients. But the functional outcome is the only thing. So we are not really enthusiastic in doing ISR unless the patient completely understands what will be their outcome. So we do it only in well-educated patients who know what they don't want stoma and they are okay to have increased stool frequency. So only in those patients we do it. Technically feasible, but we have to keep that in mind that many patients will not have a very good functional outcome. So important point to remember when you do ISR. Main thing is the one is stricture because of this is what we had in the initial phase. Probably because of maybe the vascularity was not good in the tip, which was anastomosis. The main is about the incontinence and the increased stool frequency. So the LAR syndrome is much more severe in ISR.
What about the flatus incontinence? What you will do when the flatus incontinence?
So it does happen. So we actually did the manometry in these patients, both pre and post-op. So in 70% of the patients, the resting pressure was much lesser than the preoperative. This is at 3 months. But when you repeat at 12 months, because this was part of a thesis, so we did up to 12 months. But at 12 months, that percentage reduced from 70% at 3 months, it reduced to 55%. But even at 1 year, 55% of the patients have reduced resting anal pressure. So that contributes to some amount of stool seepage and flatus incontinence in this patient.
In your series, how many you had done this ISR?
So our number total is 28.
Okay. And in all that, out of that, you have to convert in the colostomy permanent. Is there any?
Yeah, this is what many actually ask, how many you have converted. So far, we actually offer that to the patient. But patients then, no, it's okay with this.
Okay, then patient have to keep the diaper.
Probably we actually counsel these patients what will be the outcome. In fact, we tell them to speak to the patients who previously underwent ISR. Only when they are convinced, then we do it.
Then the perineal erosion is there, so many patients having?
Yeah, perineal erosion was not a very major because we tell them to take care of that. So in those patients, we in fact actually advise them to do this enema in the morning so that they don't have a continuous seepage happening throughout the day.
You are advised to apply some ointment in post-op?
Yeah, we apply the stoma cream around the perineal
protect
region.
the erosion. Okay, thank you. It's very good.
Biofeedback. Yeah, we advise them. So actually, because we cannot really, what to say, the complaints cannot be assessed. But most of the patients, when we ask them, the questionnaire, which was part of the thesis, they told they are doing that. But we don't have any objective way because we don't have that biofeedback in our center.
One question.
Yes.
Really excellent video. Really excellent demo of full anatomy, rectourethralis, hiatal ligament, excellent. Just one concern in the obese patients which have really fat in mesorectum. Any concern of exteriorizing that specimen through the anal canal?
And then do a delayed.
No. Any concern of sphincter injury? Well, you know, the anal opening is really small.
Okay.
And then the mesorectum you see is really bulky. And I've had difficulty in, pulling that specimen out through the anal canal.
Okay. Yeah.
And then after pulling it out, the major part comes out, but then the colon is quite thin.
Yes.
So I always push it back to check orientation, wash and everything. But in these patients, I see there are the sphincter tears,
Yes.
And I stopped actually doing that for these bulky patients. I rather put one abdominal incision, take it out through there, and that sphincter anatomy remains good. Looking back at our results, we see in the thinner patients, they are doing quite well with their functional status. But it is that final act of, really forcing that specimen out through the anal canal, especially when it's not the usual ones, the bulky ones. There I find it, and you've already cut the internal sphincter. So that integrity of that structure is already compromised a little bit.
No, no, in those patients, actually, even we have done that. We given
Yeah.
suprapubic incision and taken it. Because we
Yeah.
had a very bad experience with one of the patients in which we really struggled. So we don't mind giving because
Exactly. So
suprapubic can get it.
Yeah, we have also changed because it comes out. I mean, you can dilate the anus as much as you want, but then that causes an uncontrolled tear over there. So I think that functional results are much better if you avoid that a little bit.
Sir, in male patient, how many patients you have faced the impotence they will develop?
Sorry, sir?
In male patient, they will develop impotence.
So when we, as a part of this questionnaire, so even this sexual function also was part of it. It was there in 15%. It was not high, probably maybe because of, I think, the nerve preservation which we are following. So it's not as high it was documented in the
You are taking the consent previously or not?
Yes.
Okay, thank you.
All this will be told to the patient.
Okay, thank you. It's very excellent, very good presentation.
Thank you, Kalarathan sir, for such a detailed discussion on this difficult topic. I am very sure all the small tips and tricks which you have told will be very beneficial to the young surgeons. I would also like to take this opportunity to invite you all for AccuracyCon 2025, which is happening in Ahmedabad in September on 11, 12, and 13 September. We will now take a small break for lunch. Thank you.
Post lunch upstairs in HT Parekh Hall, we have the stapler session. Those who have registered for the stapler, please proceed over there after lunch. And we'll have a discussion on perioperative complications in colorectal surgery over here. Thank you.
Hello, 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 check, hello, hello, check, hello.
Hello, check, check. Hello, one. Hello, check, check. Hello, hello, one, two. Hello, 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 check. Hello, hello. Hello, hello, check. Hello, 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 check, check. Hello, check. Hello, 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 check. Hello, 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 hello. 1, 2, 3, 4. 1, 2, 3, 4. Hello, 1, 2, 3. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4.
We will now move on to the panel discussion on intraoperative complications and management in colorectal surgery. Dr. Ashish will be the moderator for this session. I would request our panelists to take their seats on the stage. Dr. Ashwin, Dr. Sanjeev Haribhakti, Dr. Dhaval Ragade, Dr. Jitendra Mistry,
Dr. Dhaval
Dr.
Rajde.
Amit Acharya,
Dr. Dhaval Rajde.
Dr. Dhaval Raje,
Rajde.
Rajde.
Ajay Raj. Dr. Amit Acharya is there. Can we have Dr. Amit Acharya if there
Hello,
in the
check.
audience? Yeah. Please join us on this stage, sir. So, after the, I would say, great morning session where the experts demonstrated their skills, we are now on to discussing something that is real life. You know, complications. Although sir did show some few of the complications, but these are the real life complications. And I would start to say with a claimer that all these complications are mine. I have not borrowed from anybody, and hopefully we'll have some insight on managing these complications. So this is the panel here. We have a esteemed panel. Dr. Sanjeev Haribhakti is a consultant GI surgeon. Sir, can you settle down, please? Sir, excuse me. Sir, can you settle down, please? Sorry. Dr. Sanjeev Haribhakti, consultant GI surgeon, Kaizen Hospital, Ahmedabad. Dr. Ashwin D'Souza, professor GI oncosurgery, Tata Memorial Hospital, Mumbai, colorectal division. Dr. Dhaval Rajde, consultant oncosurgeon, Ahmedabad Cancer Hospital. Dr. Jitendra Mistry, consultant GI surgeon, Mission Care, Vadodara. And Dr. Amit Acharya, consultant GI surgeon, Bilroth Hospital, Rajkot. So I'll start with this case, first case, 67-year-old female, obese with a BMI of 31, carcinoma mid-rectum, 6 centimeters from anal verge, circumferential, CT3CN+, posted for open TME post, neoadjuvant chemoradiation, 8 weeks after completion. That was the time when we were selectively doing minimal invasive colorectal surgery. She had a bulky rectum and mesorectum. There was peritumoral edema, adhesions, radiation induced, and although she was a female, she had a very male type of pelvis, wherein you don't have space due to obesity. And the rectal stump was divided after mobilizing the splenic flexure and all, dividing the IMA. The rectal stump was divided with contour with difficulty. There were 2 or 3 attempts at division, and it was a difficult transaction of the rectal stump. Subsequently, we inserted the circular stapler number 28 through the anal canal, and this is what happened. Staple line disruption, about 30% in length in one of the corners. So this was how it appeared when we transected, and then there was a defect over there when we placed the pin of the stapler to engage in the anvil. So Dr. Amit, I'll start with Dr. Amit Acharya. How would you salvage this complication?
It's a doom for any colorectal surgeon. But I would go for a suturing of that defect and a divergent stoma, definitely, and put a drain.
Yeah, good, crisp answer. So
Don't have any stump left together.
Dr. Haribhakti, Dr. Ashwin, any other opinion?
I would like to stress on the prevention before going to the management. I think these are the cases where there's a very small rectal stump. When we insert the stapler from below, there is a very high chance. And that's why normally in cases like ulcerative colitis, where there is such a small stump, what we do is dilate the little bit anal canal, place 3 Ellis forceps on, so there's some counter traction, so that just by the force that does not penetrate. I've also faced a similar situation in laparoscopy, and we can resort to suturing. It is difficult, but it is possible. Somebody pushes from the perineum,
Yeah,
with a
please.
perineal push.
Push, yes.
This portion can come up. You can use a Hager's dilator or a rigid sigmoidoscope or something so that you can see that area where you want to take a suture, because that will come out through the opening and it will show you exactly what you want to suture. So these are some of the guides that will help us to do the suturing. If there is a complete blowout, then one can take a purse string and do a single stapling anastomosis.
Sort of double purstring kind of a technique. Any other views, Dr. Ashwin?
So the staple line opened when the stapler is put in from the anal opening. Yeah. So one more thing, while especially after long course chemoradiation, and now we are seeing more and more delay from radiation. So that makes the rectal wall less pliable.
Mm-hmm.
So while closing the stapler, I think we have to close it very, very gradually, because that edema which is there, it takes time to dissipate. So if we close it rapidly, then that's when the staple line opens up.
Honestly, sir,
two more things, just two more things.
Please, please.
The only question is, I take for granted that we have done good technique while doing this, and this is purely a staple line failure. So in such situations, there is still no guarantee of how your circular stapler is going to hold on the rectal stump. So in these situations, especially when this staple line opens up, of course we will stitch that, again put the stapler, fire the circular gun, but if possible we will reinforce transanally, because we are still afraid about the circular stapler line which is also going.
So that is a good point, sir. Yeah. And Lone Star retractor can help, or taking sutures. Yeah. So that's what we also did. We took these sutures and we performed the circular anastomosis. But I think another point to be noted is one shouldn't pull on just to bring the staple ends together. Should not pull on the staple, and we'll see that later. Pull on the rectal stump while performing the anastomosis. So we completed the circular anastomosis difficulty. The leak test was positive, as expected. Staple line was reinforced with interrupted suture, and a loop ileostomy was performed. Immediate post-operatively, day 1, day 2 were uneventful. Day 3 onwards, I think she had a sluggish stoma output, started developing fever, tachycardia, vomiting, no organ failures, no peritonitis. Distension was there, but the abdomen was soft. And PR, there was a defect palpable in the staple line at around 3 to 4 centimeters in the left lateral region, about 2 to 3 centimeters. So this is an anastomotic leak. There is no escaping from this fact. How will you evaluate, Dr. Dhaval Rathi? How will you evaluate this patient?
Obviously, a scan is to be done just to make sure that there is no residual collection in the pelvis. The drain is working well. You have to just make sure that the patient is sepsis free. Cover it with the antibiotics, obviously, and then wait and watch. If there was any doubt intraoperatively about the vascularity of the stump of the descending colon, then you have to confirm it with the colonoscopy. Just the vascularity, nothing else. If the vascularity is good, then you can just wait and watch and hope that the stricture that is formed is not really.
What kind of a scan would you? I mean, oral, rectal, IV, all three, or would you just do a plain scan?
No, rectal contrast. Plain scan is good enough. At the most, IV contrast, which can indirectly give you the idea about the vascularity of the descending colon, maybe. But then that is it. Rectal contrast, I don't
Is that your policy also, not giving rectal contrast? Because I believe rectal contrast will increase the accuracy of diagnosing leaks.
Yeah, but here that we already diagnosed the leak. So the rectal contrast is not going to help for the diagnosis, because we can feel the defect. So main thing, as he said, is we have to see the collection. As you said, patient is not septic systemically. So it is only localized infection. So I think our approach would be to pigtail that, drain it, and if possible, try and take transanal sutures. That would be what I would.
Okay. So we did a CT abdomen. We discussed the protocol. We gave a rectal contrast actually, but I accept your suggestion about not giving as well. There was a perianastomotic localized small fluid collection with air, and there was no collection elsewhere in the abdomen. So this is just to take a look at the CT findings in a colorectal anastomotic leak. What are the possible findings. You can have disruption in the posterior wall, the continuous pieces side. You can have contrast extravasation, and you can have extraluminous. Pardon me, I don't have the scan. This was long back. I don't have the scan of this patient. In any case, further management, sir, would you like to add in, Dr. Haribhakti, sir? Would you like to add anything?
So I think one should think of nutrition. If the stoma is not working and she has persistent ileus, then one should think of a central line and a nutrition. The course of management will be conservative because this patient will eventually improve because there is no sepsis. I mean, there is no definite collection to enable. It's a small leak, and she has a covering stoma. So I think she will come around. It's only a question of time. But I think apart from antibiotics, we must think of nutrition in this patient and start with parenteral nutrition by the 3rd or the 4th day at least.
Point well taken, sir. You mentioned this, Dr. Ashwin, image-guided PCD, maybe not in this patient, but what in general, if you were to encounter such a case, what is the success and what is the route? I mean, of course, abdominal, but access-wise, have you found that they are always accessible?
Yeah, most of them, because they are pretty much just above the pelvic floor. So it is just going through the perineum or through the buttock, they go in and they're easily able to get access. If there is a collection, it has to be drained because otherwise the local sepsis is not going to be controlled. And if possible, we always try to at least achieve mucosal closure because that prevents that cavity from getting recontaminated. So if
you're talking about transanal suture, is that
transanal suture, we'll try if it is low down. If it is higher up, then we'll ask the endoscopy people if they can put some clips. If not getting full thickness, at least mucosal closure. So that helps the healing process.
Dr. Jitendra Mistry, any other points you would like to add, or practically everything is covered?
So, I mean, everything is covered, but one is that if transabdominal, if it is not accessible to drain, there is already gap in the anastomosis. You can put a small catheter and wash from below.
Yeah,
that is
so
one point. And repairing the anastomotic dehiscence is very important if it can be done for a functional point of view. Otherwise, it will stop, but there will be a so hard area that patient will have a lot of functional problem later on.
So this is what he is talking about, abscess drainage through the disrupted anastomosis. We have done it on one occasion, not in this patient.
Can I make a comment,
yes,
please?
Please go ahead.
What I have felt is that when we have done a really good TME where we have preserved the fascia on the levator ani and all that, the sepsis is really not bad. But when we have disrupted all fascias, then the sepsis really goes into perineum, deep into perineum, and then it is really difficult to control that sepsis. When we have really done a good job, the leak is a concern, but it really remains contained.
Yeah, so after the morning session, having watched them, now we will do a good TME. When would you consider anybody, re-exploration not in this patient, but in general, Dr. Jitendra Mistry, when would you?
So when there is a significant collection or generalized peritonitis, obviously we'll need to re-explore. If there is a proximal and gangrene or completely ischemic, I think we need to re-explore.
Would you take it out, or would you just do of course this patient had an ileostomy, suppose it's not diverted?
So definitely, if there is a re-exploration for leak, there should be always a diversion if not done in the primary surgery.
So we followed all this surviving sepsis guidelines, of course, nutrition also, although we didn't institute, but in a formal way. But we did follow the surviving sepsis guidelines, and she made a slow recovery. She had a prolonged ICU stay, total 7 days, and she gradual resolution of sepsis, and bowel function returned within a week. She had a bad SSI, surgical site infection, and discharged in a stable condition, but there was a prolonged hospital stay of about 16 days. 1 week later, she came with a fecal discharge and gas through the vagina. Fistula was felt on PR with surrounding inflammation and edema. Sir, what should we do now? Further management? How long should we wait?
Yeah, so this is become a complex and chronic problem.
And that is why I was telling that we should not pull on the rectal stump because the vagina gets caught. Of course, in that anxiety and panic, not sure whether the posterior vaginal wall was palpated for, and that it was not caught in the stapler. But this is what happened.
Yeah, so we would wait at least 6 weeks before we go in.
I take for granted that patient is actually stable and it is just a low down fistula.
Yeah.
So usually these don't cause much problem systemically.
6 weeks is good enough time, sir, for the inflammation to subside?
Yeah, 6 weeks
Not
is
longer?
about fine.
Any
You
other
could
views?
at least 6 weeks. If you wait, you can go ahead. You can take it up at 3 months also.
I think in a situation like this, even when the repair is fraught with the risk of recurrence, we need good healthy tissues for them to take the sutures, and it should be a double breasted repair. So I would wait at least 2 to 3 months so that there is some amount of fibrosis and there is healing. The inflammation will subside in 6 weeks. Infection will subside, but the fibrosis to set in, it's something like a bile duct stricture after cholecystectomy. Inflammation subsides in 6 weeks, but we don't go in after 6 weeks. We wait at least 2 to 3 months after a cholecystectomy so as to get a good repair.
The patient was clinically stable, ileostomia is functioning, she was tolerating diet. These are important parameters while judging a patient post-operatively. We waited for 6 months, sir, in this case, not only because this was the first time we had encountered this complication and we were not sure what to do, but also because her general condition was poor in terms of comorbidities. So, yes, so we couldn't give an adjuvant to her. And we ultimately did a graceless interposition flap in conjunction with a plastic surgeon. He chose to repair it with this technique, and she recovered gradually, and ileostomy closure was performed 6 months later. So any other opinion differences in management? Would you, Dr. Raja, would you do anything different?
I just want to understand what was done. Was this purely done from the posterior vaginal wall, or was this done transanally also?
Perineal approach.
No, perineal fine, but through the transanal or through the posterior vaginal wall only?
Through the posterior vaginal wall, but
So
of course it
you
was all one. You know, fused the anal canal, there was a defect there, so it doesn't matter. It was done through the vagina. So the vagina dissected the tissues and placed.
But so then
closed.
the defect in the
Yes.
rectum was closed,
Closed.
then the gracilis flap was interpositioned, and then the posterior vaginal wall was closed.
Okay, shall we move ahead? So this is second case. This is an intraoperative complication. 65-year-old gentleman, carcinoma rectosigmoid, planned for a laparoscopic low anterior resection, partial TME. The dissection is done. The IMA, IMV planes have been developed. Splenic flexure is mobilized partially. The rectum is transected, and specimen with the descending colon is removed from the peninsula incision, as is our policy. This is I am creating the background for the video. After exteriorizing the descending colon, resecting the specimen, the anvil is placed and a purse string with 2-O-proline is placed, and anvil is placed into the descending colon for the anastomosis. This is the video after placing the descending colon inside the abdomen. So we're trying to bring in the stapler from the anal canal. The staple pin will come out shortly into the cavity. Now, to our horror, the anvil slipped inside the anvil head, and then we are doing frantic efforts to retrieve it out so that we can engage it comfortably to the staple pin. There is a lot of struggle over there. There was a lot of struggle over there, and finally we engage it. And just before firing, we notice there is a twist in the descending colon. One can see that there is a actual 180 or even more. And then we try to derotate it. It is done. We are successfully able to detort it, but please notice that the end has become ischemic. I'll just stop it over here. We'll talk about prevention. Sir, Ashwin sir.
So when we put the anvil inside, even before we bring the gun from the bottom, at that point is the time where we maintain the orientation, and we bring the anastomosis, bring the anvil down into the pelvis and check the orientation of the colon. Either we can check the mesentery medially, or if sometimes the small bowel comes in the way, even if you see a tinea in continuation, then we can confirm that there is no twist. So that's the first thing, and then everything is in position. Then after you start putting the gun in, then we just have to connect.
Okay. Sir, Haribhakti sir, anything else you want to add?
So I think for the twisting, Ashwin has also already mentioned the two ways how we prevent the twisting, seeing the mesocolon medially and following the tinea right from the staple end to up to the, at least to the descending colon. Making sure that no small bowel also goes behind the mesocolon also. And for the vascularity part, I think ICG is now a very useful tool to prevent such mishaps that can help us. But definitely in this patient, this will require a revision, a re-resection.
Yes, so,
it will.
Can I make a small comment, please? As sir mentioned about vascularity and ICG, what I do in my cases is I will always cut a marginal artery without applying a clamp, confirm the brisk arterial bleeding from the cut, and then apply the clip. This is just indirect way of confirming the vascularity when you don't have ICG, and you don't have ICG all the time.
My only question is, it was vascular before you put an anvil, no? When suddenly it became ischemic.
Yeah,
So was it any manipulation during that anvil?
I believe that while retrieving the anvil out of that struggle
You
that led to we did check the orientation. We marked our anvil knot at 12 o'clock, and we look at the anterior tinea also. We follow all these steps, but perhaps. And the other thing that probably also made this complication was that we sized with the anvil head before the anastomosis. The sizer for the this one staple and the actual staple were different, because you have different companies giving different the anvil head sizes. So that is probably one thing which one should be careful. And if one is sizing, then there should be the same company as one you're sizing. So again, quickly, correct staple number, sir, Ashwin sir?
There are sizes, but we don't use them anymore. So
we use that anvil.
We don't use the anvil also. We use 28 for all of them. Standard, or if it is upper rectum, then 31.
31.
Yeah.
Okay. Fairly standard, I believe. Okay. Fine. So so now, sir, how will you salvage this complication? Jitendra, how will you salvage?
So,
no, we didn't fire.
So if we have not fired, we can disengage the stapler.
Yeah, that is what we are
We can bring the thing out again, transect further proximally, and redo the anastomosis.
Fairly straightforward, isn't it? Yeah, so after a lot of struggle, it was not coming out, it was not disengaging. We had to cut the first string and bring the anvil out of the colon. Significant struggle over there. And then we revised the anastomosis, and now you can see we are doubly sure. We are also marking the anterior orientation, and then we stapled this, and luckily patient recovered uneventfully.
Do you think rather than financial, a small periumbilical midline would be little more helpful in manipulating the specimen outside and putting it inside in a correct line? Because I feel that financial is too low, and sometimes while putting it, it twists and you cannot identify the thing.
I think the lie is controlled under laparoscopic vision only, so the excavation segment is not there. But just speaking regarding this, I went one step further. I made the same complication, and I had fired the circular staple. So when I looked back and saw that that the colon had turned 180 degrees, or maybe more than that. So one good tip here is that when we obviously had to go and staple lower again. So you leave that anastomosis, you can actually give good traction on that, and that staple line is quite strong, a circular staple line. So you can use it like a real rectum, go down, dissect more rectum, and then comfortably restaple again. So there's still hope, even if we fire the circular stapler.
Okay.
So you use that, give good traction like you do for normal rectum. Nothing happens to that staple line.
Once again below the
Transected once again below. Go again, mobilize more, go just below that, transect it and redo the whole thing. It's still possible.
So that is after you fired and discovered. That's a good tip, sir. So coming to case 3, and this is not an uncommon complication that we face, bowel obstruction after laparoscopic or robotic APR. 65-year-old gentleman underwent laparoscopic APR for CA anorectum, TNT protocol. He had a small synchronous solitary liver met which had responded well to chemo, and then RF also, which also gave a good response. He underwent lap APR and then developed small bowel obstruction after initial bowel movement on 3rd or 4th position. And this is not uncommon. You have initially the stoma function, and we are excited that we have achieved some of the milestones of minimally invasive surgery. So congratulating yourself just to find that the patient has developed obstruction. He failed conservative therapy with NBM rise tube aspiration for 72 hours. This was the scan that we did, and there is bowel dilatation, and in fact the radiologist said that there is a gradual transition at the distal ileum at the side perineum, in the perineum. Management, sir, Ashwin D'Souza, I believe, sir, you do a lot of this Bakri balloon and stuff, sir, empty pelvis syndrome. How will you prevent it, first of all? Any tips for perineal closure? Bakri balloon itself, how will you treat it?
So Bakri balloon we only place following total pelvic agitation.
Okay.
Because it works only by impingement against the circumferential bony pelvis. Okay. So if we put it in APR, then anteriorly actually the bladder gets compressed against the pubic symphysis.
Okay.
And there is a risk of pressure necrosis of the posterior bladder wall. So for APR we do not put it. Okay. We do face empty pelvis syndrome following APR also. So in addition to what you mentioned, we would also give head low. We would give some head low that helps sometimes to open. Helps us resolve. The thing here is we would do a scan, and if there is definitely, maybe after 72 hours you said, and if there is a definite cutoff in the pelvis, we would rather go in earlier than late, because that bowel, especially in this male pelvis, it gets stuck there and it forms adhesions and it does not open. If we go later on, those adhesions, then we start getting serosal tears in the bowel and everything. So we will go in earlier than late if the patient does not respond 72 hours. Okay. Go in laparoscopically, and with the help of 2 suctions, one in the right and left hand, one irrigating and one just levering the tissue out without any traction, because bowel is all dilated. So the object is not to trace the whole bowel, just to release that what is in the pelvis. So you don't have much access because all small bowel is distended. But it still works laparoscopically. We give good Trendelenburg. Access is only for pelvis with 2 suctions, one irrigating and one suctioning, and just gentle easing. We just deliver that bowel out, and then either we'll put an omental flap, which is difficult if bowel is dilated. Then we just drop the bladder down. Okay. So we release the anti-attachments of the bladder falls down and obliterates the pelvis. So then that prevents the bowel from falling in again.
So you have high volume rectum, this one. Have you used mesh for preventing these sort of situation?
No, we have not used.
Not used mesh. Any experience of nobody uses mesh during the momentum?
There is also data which says that after laparoscopic colorectal surgery, post-op adhesions, the risk of needing surgery is higher compared to the open colorectal surgery.
Yeah, because sometimes you miss the plane and create raw surfaces.
No, I don't think there is a high risk, but at least equivalent risk has been found in cases like ulcerative colitis. Anyway, in this situation, I think, in my opinion, the most important way to prevent this problem is to do a good peritoneal closure at the end of APR. Yeah. I think peritoneum is a very smooth surface, and most of the times, if you do it meticulously, you can actually reperitonealize the entire pelvic floor. And most of the time, what happens is at the end of the procedure, we are so, we feel that now stoma is done and resin is removed, then, we just put the drain and cup out.
Have you had the need to mobilize the peritoneum both sides?
No, generally not. No. I think, yes, because all APRs we have started, because we have had this very frequent problem. And that's why we have started closing peritoneum for all cases. Even now, robotic cases also, we close the peritoneum at the end of the procedure. So that is one. And number two, for management, as Ashwin rightly pointed out, early re-intervention, re-laparoscopy, and that is a good thing. We generally, what we do is we start from the IC junction. We find the IC junction, go back proximally, and then go to the site of obstruction and then relieve them. Most of the times, I think it would be possible to do it laparoscopically unless there is gross distension.
Dr. Dhaval, you stress the accurate perineal closure. Would you like to share that?
Accurate perineal closure actually is maybe not to prevent this, but accurate perineal closure in the sense that I will ensure perineal closure in 3-4 layers just to make sure that there is no air leakage, there is no intraperitoneal pressure leakage from the perineal wound. That really prevents ileus, that really prevents Hessen's bowel function recovery. That is my feeling. I'm not sure. I don't have data or anything, but I find it very useful. I will have very little perineal infections, wound gap, anything. I will always close it very meticulously in 3-4 layers. The perineal, the fat also.
And in this current era, Dr. Ashwin, there is no place to close the levator. Am I right? You can't close the levator if you have done a. So that is a point to be noted for junior audience, that you can't close the levators.
So again, here can I just
two questions. One from and then Manish Gandhi.
Cases that we take for APR, mostly the levator is involved.
So my idea of removing levator ani, say the disease is on the left side, I will remove the levator ani on the left side radically, but not on the right side. So here I have this policy of removing tumor-specific levator ani rather than knocking it off all around and then having a big perineal defect. So
but even with one levator, it becomes still difficult to close.
Yeah, you can't close it, but I believe that maybe you leave behind some strength on the perineum to prevent herniation.
Dr. D'Souza, I got the feeling that you don't close the peritoneum. Sanjeev, you told that you close. I always close, but the point is, sometimes the peritoneum is not that much left, and sometimes when you close, there is a little tension. In that case, don't attempt to close, or while starting the dissection on the mesorectum and mesosigmoid, there you start nearer to the bowel so that you leave more of the flap of this, and then go in the desired plane. So if there is small, then I've seen smaller rents, you have closed and something opens up and there invites more trap of the bowel.
Yes, Dr. Manish, you wanted to say?
Mostly it's a neoadjuvant PTRD. It's very difficult to close the peritoneum. Once I have attempted, that leaves a small gap, and then from that bowel is herniated, it's got obstruction.
You generally get the peritoneum on right side, but on left side you generally don't get enough peritoneum to come it closer.
Okay, so we were not aware of this, the lap again. I mean, we thought laparotomy would be safer than because of the adhesions and all. So we did a laparotomy. We did a safe visualizes. The ileal loop was stuck in the pelvis, and more or less we did the same. We only addressed that loop and released that. He had an uneventful, although slow recovery after re-exploration. So these are two cases. We have some time left. I'll just go through these two small clips that highlight the complications that can occur after benign disease as well. So this is a 64-year-old lady, partial rectal prolapse with post-hysterectomy, and we were planning a ventral mesh rectopexy. This is okay. So we placed the finger in the vagina and trying to dissect the rectovaginal septum, and one can see that there are too many muscle fibers that are coming up in the dissection, and subsequently we'll see that there is plenty of bleeding as well. Still we aren't aware of the complication that we are about to create. We are going intradetrusorial actually. The detrusor is getting exposed, it is getting dissected. We had to bipolar a lot.
There was dense adhesions between the vagina because of the previous hysterectomy and the chronic prolapse. And there, the Foley's bulb is visible, and we find that we've injured the bladder. Suturing was not that difficult a task. We had to retain the catheter for 2 weeks. So this was, yes, Dr. Dhawan.
I would comment on the prevention part here.
Yes.
That rather than putting a finger, it is better to put in a sponge stick in the vault, keeping it up so
Yeah,
that you know where the vault is and you work between
No, no,
vault
it
and rectum,
Yes.
not between vault and bladder.
Yeah, it was. Any other comments? Any questions from the audience, or as we go ahead? We have some time left. We can have some questions, and okay, we will take it at the end. This is my final.
In the last case, in benign disease, I think we should be working close to the rectum rather than going away from the rectum. I think that's important as we go.
What did you do for the vault prolapse?
No, we dissected and we placed a mesh. It is debatable to place a mesh when there is contamination.
Posterior rectopexy, right? Or anterior?
Posterior rectopexy with vault suspension kind of a thing in a T-shaped manner. We suspended the. Luckily, nothing happened, but it is debatable to place a mesh when such a complication has occurred. Yes, please.
Usually the urine are sterile.
Yes.
So one
That
can
was our-
avoid with.
No, my question is what was to be done for the vault prolapse?
So this is a short video clip showing the IMA stump bleed during lap APR. Luckily, it was from the distal stump, and consequently, it was handled. Just want to highlight that sometimes we feel that these hemlock clips are sacrosanct. They can't fail, but this can happen to the proximal stump as well, and that's the time you can have a real challenge on table. So this was easily controlled because the vessel was dissected, and
I think in this case, there was a takeoff of left colic and IMA.
Maybe.
So the distal clip was on both these vessels, and it was not completely occluding the left colic. So that's why this happened. So I think if you could either separately dissect both and apply a clip, or apply two clips, that's what we sometimes do. One on the IMA, one on the, if you are going low ligation. Otherwise, go around and put a complete clip and make sure that it's a complete hemorrhage.
And so out of blue, it is more common during the when you use a local made hemlock clip applicators.
So when you mentioned bleed from the IMA stump, I had a little more exciting bleed. So we had put clips, and then end of the procedure, I was just taking out one gauze piece. The edge of the gauze piece got caught onto the hook of the clips on the IMA. Both the clips got avulsed. And
we
IMA
saw
was-
that video when we attended, when we visited your center.
Yeah, so that bleed becomes little bit this thing. The thing is, you can always catch that stump, and there is always little more length, because if you go to the neural plexus little bit towards the aorta, you get little more length, and you can put another clip down there. We were able to do that, but we can't even take that for granted. Removing gauze piece, everything should be done under vision and laparoscopy.
Any questions from the audience? We are on time. Yes, Dr. Kegur.
You are using a 5mm clips over here.
10.
Okay, so my personal experience is that whenever you're using a good, I preferably use always a VAC. So if you use a VAC 10mm, you will hardly encounter clip unlocking once it is locked. You have to literally cut it. But if yes, you are using a 5mm clip, or you are using a local med, then there is a very, very, very high chance what you have demonstrated that tend to happen.
5mm clips are very good. We have been using routinely all 5mm clips, and they're fantastic. They don't open up once you apply them.
Couple of cases which I encountered, they were all 5mm size.
I was called for intra of help, and urologist was doing nephrectomy, and he applied hemlock in a renal vein. And what happened is, after fire, the clip get stuck to the one of the jaw and couldn't open it. So what we have to do is we have to put another trocar, we clipped just distal to it, and then we dismantle it. So this can happen with the local made. That's
Local made also, I think a good local made and the because not everybody can afford wet clips like Dr. Keyur and I mean wet clip applicators, I would say.
And we encountered, I mean, just an extension of the same complication that what once we encountered in our unit, we had been doing open shot of APR. So happening, junior colleague was doing it. And he has nicely made this flap of sigmoid, and then he was dissecting the standard way of mesentery. I was also in the theater itself. I was watching it, him doing it fine, okay. So he was just dissecting with the monopolar diathermy only, but the IMA was so thin. Even I could also not make out that probably it's an IMA. He just swapped the cautery. It just got away. It got cut with avulsed exactly from the root of the aorta. Yeah, I mean, immediately he had to put the finger, and then obviously it was anyway open, so we could close it. But yes, that also at times happened in elderly patient with a very thinned out IMA. If you are not and putting it very much taut, he thought that probably it's a fascia. He just divided it in a one go, and then I mean, literally we had to repair on aorta itself. There was no stump at all.
So I've covered many complications. Fortunately, I have not had ureteric injury so far. And any other?
I will just add to this clip thing. While doing lap whippers, I was using this Johnson made multiple clip applicator, multiplier clip applicator, where you are, and I didn't knew this at that time, but you are supposed to half fire to load the next clip before you fire the clip. And I didn't knew this, and I fired one and then fired another, and the clip applicator locked on the gastrocolic trunk. Does not open, I'm not able to remove the instrument, can't do anything, and I didn't have clip proximal to it. And then I had to do something similar with another trocar, parallelly place another applicator, place one more clip, then cut in between and get the clip applicator out. So you need to learn your instrument really well before using it.
Point well taken, point well made also. Yes, Dr. Keyur. And Dr. Amit. Dr. Amit first, because he has had the opportunity. You go ahead.
Was unfortunate to get it. I had
So
a.
you have more experience than
No. I had duodenal obstruction because of the age of the mesentery, mesocolon. We mobilized the splenic flexure and did the LAR. So the age of the mesocolon means I have done a very high IMA ligation. So the duodenum DJ flexure was very high. So I have mobilized the DJ flexure and did the IMV closer at the root. So when the surgery was over, everything was fine. Very nice length, everything. On the fifth post-op day, patient had bilious vomiting. And I found it probably SMA syndrome. But when I re-explored, it was the age of the mesocolon, which was compressing the DJ flexure. And from that day, I now check not only the bowel is of good length, the mesentery has to be also lax. And I always keep the DJ flexure above the mesocolon before I complete my procedure.
That is one of the standard.
That point is, I think, sir also mentioned. Well, see, checking the lie, not only check the lie of the colon, check the lie of the small bowel. So at the beginning of our procedure, we take a lot of time to position small bowel, but at the end, we don't take time to see that it's positioned back properly. The rest of the small bowel is fine. DJ flexure and first jejunal loop should be on top of your mobilized colon. So that is what we also started doing.
If there are no more comments or questions, Dr. Keyur wanted to say something.
I mean, just as we have a time. So coming back to the first slide, I mean, first case that we discussed regarding that perianal leak, we encountered, obviously everybody would have encountered the same thing. So in couple of cases, what we have done is that maybe day 5, 6, you encountered or you come to know that there is some pelvic collection. They are very difficult to drain it from above, we all know. So what rather we have done is this simple corrugated drain. What we did, we drained it transperforation.
Yes.
We try and put the through the you cut the corrugated drain into half. We give a lavage from there only. Put a drain for a couple of days. Fix it to the perianal skin. Leave it for a couple of days and then take it off. so that it won't lead to further, I mean, stricture or complications. So that can be drained per rectally also, per rectally.
I mentioned that.
There is one Chinese study, but I don't know how good it is. But the thing is that it just renders the sphincter a little incompetent. It's like
The collapsed bowel has a better vascularity, and therefore I always feel sometimes that I sometimes circumvent the diversion. In many cases, I don't do diversion. Where these, if I do, or we do, and then we keep the bowel collapsed, which anastomosis bowel, that would prevent. This is my just
yeah. So that just prevents the buildup of gas.
gas, and when gas, and then the bowel wall thickness because of the gas distension, and the borderline ischemia is taken care of if that is remaining collapsed. So there is a
So I really thank.
One of the techniques that we use for prevention of leaks, especially when there is a doubt whether to do a stoma or not. These days, in the bygone days, whenever there was a doubt, we would do a stoma. Today, when there's a doubt, we don't do a stoma. So in such cases, we use a trans-anastomotic drain. And there are a lot of studies, a lot of systematic reviews, meta-analysis, which have shown that it's quite an effective treatment. You put in a 32 French drain transanally through the anastomosis into the proximal bowel. So that will decompress the bowel and that will reduce the chances of an anastomotic leak.
So on that note, I thank all the panelists for their wonderful insights into the management of difficult problems. We will now move on to the next section. Dr. Sanjeev Haribhakti, please. So you loaded.
Thank you, everyone. That was a very insightful discussion. I would request the delegates who have registered for Stapler hands-on classes to go for the workshop. We will now move on to our session on benign colorectal diseases. I would like to invite Dr. Sanjeev Haribhakti sir on stage to speak about laparoscopic restorative proctocolectomy. The chairpersons for this session are Dr. Ankur Tiwari, Dr. Karthik Sutharia, Dr. Bhavin Patel, Dr. Hemant Panchal, Dr. Viral Shah, Dr. Shashank Desai. Thank you.
Good afternoon, everyone. I congratulate Rasesh and his team, the GastroPlus team, for this meeting. And I'll be sharing our technique of laparoscopic RPC IPA over the next 35-40 minutes time that has been given to me. So laparoscopic RPC IPA it's a complex procedure, but it involves all the principles of laparoscopic colorectal surgery. So it will be like a revision for you since morning. Left colon, the right colon, the rectum, all the principles are covered. In this presentation, I'm going to cover these topics briefly, very briefly. So RPC IPA has become the standard treatment for intractable cases of ulcerative colitis and FAP. Since it was first described by Parks and Nichols from London in 1978, and then Utsunomiya described the J pouch. This has become now the standard procedure, then laparoscopic, and even robotics is now gaining traction, while the transanal approach is quite debated. So the rationale for doing RPC IPA is that it's a one-time cure for these patients, ulcerative colitis, who have otherwise to require a lifelong treatment. It avoids the complications not only of the disease, including malignancy, but even of the treatment. And some of these treatments, as you know, are immunosuppressants, steroids, now RPC IPA also preserves the sphincters and avoids a permanent stoma, and it avoids the lifetime medications, the rising costs. It improves the quality of life of these patients who are otherwise very young in the prime of their life and having a disease which has multiple relapses and remissions. It improves the nutrition and psychological effects, and the risk of malignancy also is almost abolished. We can't say 100% abolished, but almost abolished by doing this procedure. Now the indications can be divided into two, emergency and elective. Acute severe colitis in an emergency sometimes requires surgery if it is not managed by medical treatment. Toxic megacolon, generally, if this kind of complications, even perforation has a very high risk of mortality, and that's why these patients may require surgery. But the commonest procedures are done in elective setting, chronic intractable disease, which may be because of steroid dependence, malnutrition, suspicious or proven malignancy with long-standing disease. Strictures in ulcerative colitis must be considered malignant until proved otherwise, because localized strictures are very rare in ulcerative colitis and rarely for extraintestinal complications. So this is an algorithm from our recent book that has been released, the decision-making algorithm. In acute severe UC, initially these patients are treated with high dose of steroids. 3 to 5 days, if they don't respond with the UC disease activity index, then the options are to use either infliximab, cyclosporin, or to subject them to surgery. Biologics are other options today which can be used, but these treatments, of course, cannot cure these patients, and surgery, on the other hand, can be curative, and that's why it should be considered early in the algorithm of these patients. With chronic intractable disease, patients who have moderate, severe pancolitis by definition is anything beyond the splenic flexure is called pancolitis. Patients having repeated relapses, nutritionally they are going down, having steroid dependent, refractory or complications of steroids, who have nutritional problems, and sometimes even for cost considerations, we may have to do a one-time treatment rather than a lifetime treatment. So these are the three options. Apart from the RPC IPAA, we have the colectomy and the ileorectal anastomosis, where we can preserve the rectum in about 5% of patients with UC, where rectum is preserved or spared. We can use this, or sometimes even in young females who have not yet born their family, we can preserve the rectum and do ileorectal anastomosis, and later on, after they complete their family, convert it into a pouch operation. A total proctocolectomy with a Brooks ileostomy is done mainly for people who have very poor anal tone, elderlies with severe comorbidities. These patients also have a one-time procedure which can cure their disease. So currently the two-stage RPC IPA is the gold standard operation. Most of the patients undergo this procedure, where initially after an pouch is created, a loop stoma is created, and then subsequently the stoma is closed in about 6 or 8 weeks after the procedure. But in some cases, we can also resort to a single stage pouch. It is very rare, and patients, and sometimes we have to also resort to 3-stage pouches also, where the first step is a subtotal colectomy, the second step is the ileal pouch anal anastomosis, and the third step is the loop stoma closure. For a one-stage pouch, the indications are patients who have no immunosuppressants, or those who are highly motivated, those who are willing to go back again in case their pouch leaks, and they are nutritionally well preserved. These are some of the patients in whom we can consider. With technical factors during the surgery, there is complete donuts, ICG is clear, no air leak on anastomotic testing, complete donuts, and the surgeon is experienced, then in such highly motivated people, we can resort to a single stage pouch. Though it is, with this kind of patients, is very rare to get in clinical practice. Most of the patients who come in practice are who have already received steroids and nutritionally low. So most of the times we are not able to do a single stage pouch. For a 3-stage pouch in emergency, when we do it for acute severe colitis, it's always a 3-stage. And in elective setting, patients who are on high dose of steroids, immunosuppressants with albumin less than 2.8, and who have been on long-standing biologics, these are the patients who would generally be resorted to a 3-stage pouch. The J pouch is the commonest used pouch, easy to create, simple, straightforward, because it can be stapled. Its contour is good, it has been proven. But in some selected situations, one may have to use a W or a S pouch. S pouch, has better emptying. The W pouch has an emptying issues, and the H pouch is the new one that has come up. But most of the times, the J pouch is created with a stapled 15 centimeter is normally what is required, and then we cut the end of the pouch of the distal end of the ileum, and also double overrun it, because this is the area where leaks can happen. And this is, I'm not able to show with the pointer, but this is the area where the leaks from the pouches can happen. So one needs to do a double layer closure of the distal end of the pouch. And then mostly it's a double stapled anastomosis, which is the standard. So these are the steps of a laparoscopic pouch surgery. I will discuss this when I show the video, because in the video we'll cover all the aspects, the technical aspects of the pouch. Now the first step, we start with the left colon mobilization, where we first do the medial to lateral dissection. Subsequently, then we do the IMA ligation, the IMV ligation, and after that we go medial to lateral to go to the splenic flexure, and then we go supracolic medial to lateral splenic flexure, and then turn down to the lateral ligaments. Finally, complete splenic flexure is mobilized. Next step is to go down to the rectum, completely mobilize the rectum circumferential as we go down, and then divide the rectum on the pelvic floor. Then the team shifts on the other side for the right colon mobilization, and initially we go from the infromedial to the supralateral approach, then take the hepatic flexure from above and lateral attachments, and finally hepatic flexure is completely mobilized. So after this, there is a mini laparotomy. So these are the standard port placements. We use a 5 trocar. Camera is at the center, 2 working ports on the right side, 2 ports on the left side. So this is for the left colon mobilization, where the surgeon is standing to the right of the patient. And the first step is to get the small bowel out. And we use the bowel graspers, and we have a steep Trendelenburg position here so that the small bowel will remain out of the abdomen. Next, after initial brief assessment of the abdomen, we lift up the sigmoid and the rectum so that the IMA pedicle becomes taut. So that is the first step. We have found that taking the vessels at the root is always easier rather than going too close to the colon. And this is the surgeon who is standing on the right side and the assistant on the opposite side. With the traction applied, the IMA pedicle is taut. You can see how the 2 assistant graspers, they lift the rectosigmoid and the rectum so that the IMA becomes taut. The surgical landmarks, including the sacral promontory, where the incision is placed, and the right ureter are seen before we place the incision. Once this is taut, I generally prefer to use monopolar spatula, which I found very useful, which allows us to do a very quick dissection. It's a very sharp dissection, something like that we used to do in open surgery with the cautery. It's very similar. So once the peritoneal incision is placed, the pneumoperitoneum helps us in the dissection. The incision is then cranially extended to come to the close to the IMA pedicle. The most important landmark after you place the incision is to look for the IMA or the suprahemorrhoidal artery, for that matter, distal to the offtake of the left colic artery. As we go, you'll see all these lymph nodes. These are all inflammatory nodes. This patient is having ulcerative colitis. It's not a malignancy. You can see the IMA, and the dissection has to be just below or just posterior to the IMA. So that is where we keep dissecting, starting medial to lateral, using traction and counter traction. So these are the 2 most important tricks in this surgery: having good traction, counter traction, getting into and remaining into the correct plane, because these are avascular planes where you can use monopolar cautery and identify all the important structures. You now see that we are going, this is the gonadal vein on the left side being exposed. So the ureter will be medial to the gonadal vein. It will be on the floor as we find the gonadal vein, the ureter, then the gonadal vein, and then we go more lateral. So medial to lateral, we go till the white line medially. And once this is done, only then we will ligate the IMA. IMA is not ligated till we identify the ureters and the left gonadal vein. So now we can see that the left ureter is on the floor and the gonadal vein is also seen. So subsequently, now the next step will be to go to the root. If this is being a benign disease, we don't need to go right at the root or do a high ligation of the IMA. This can be done, even distal to the offtake of the left colic artery, so that we may have to get the left colic at the second clip. So we use this, get a good dissection so that we have a good space to apply at least 2 or 3 clips. On the artery, we have a policy to apply 2 clips and do a ligashure to divide the distal part of the artery. We don't use the clip on the specimen. It's not needed because ligashure does a good job. Whereas for the vein, we have a policy to apply one Hemlock clip for the IMV. In malignancy, this division is done much higher than in the benign disease. Here you can see. So after this is done, the traction is changed of both the assistant graspers so that we can start going from medial to lateral and do dissection of the splenic flexure. Actually, it's not just the left colon now. We are going more cranially towards the splenic flexure of the colon. So this is the medial to lateral approach to first mobilize the splenic flexure as we go down. It's important to remain anterior to the gerotas fascia, between the mesocolon and the gerotas fascia. Sometimes in thin, this was a very thin patient. Sometimes we will land up in the wrong plane, expose the kidney. You will see here, but most of the times you have to get anterior to the gerotas fascia. Here, the perinephric fat is very little. You can see here as we go towards the splenic flexure of the colon. Good traction, counter traction is the key to this surgery. Towards the splenic flexure of the colon. The distal transverse colon is also seen. One can even see the body and the tail of the pancreas as we go down from here, as we go deep. So subsequently, this is the getting into the correct plane behind the colon up to the white line of the TOLT. So this is the plane that, is a avascular plane. You don't need any harmonic scalpel or any ultrasonic energy here. Just a simple traction, counter traction, and a monopolar dissection is good enough. And if you are in the correct plane, these are all embryonic fusion planes, and there won't be any bleeding as we keep dissecting into these planes. So once you are in the white line and you have dissected completely as much as you can, because here the small bowels will not fall. You have the mesocolon as a curtain above, which helps us. And that's why you should try to do as much as you can right till the splenic flexure. Even you could divide the peritoneum laterally and see the spleen and come out on the other side. Next, now we have introduced this step where we start the splenic flexure mobilization from medial to lateral in the supracolic attachment. So we start from the midline, from the, you can see the falciform ligament on the left upper side, from where we start, and then go towards, so it's a mid-transverse colon going towards the splenic flexure of the colon. So this also is a very good technique, and this helps us to mobilize the splenic flexure completely and get the omentum away from the colon, because still the gastrocolic omentum is taken off from the colon. You are not able to get completely the colon out through a small incision. So this is, you can see that we are getting into the lesser sac and then coming towards the splenic flexure of the colon, completely dividing the gastrocolic omentum from the distal transverse colon going till the splenic flexure. And most of the times the gastrocolic omentum is attached till the proximal descending colon. So you go till the proximal descending colon and completely remove the gastrocolic omentum. So with this complete mobilization, the omentum is away, and what remains is the retroperitoneal attachments of the splenic flexure of the colon, which you can take easily when you come from the lateral to the medial side to do the splenic flexure mobilization completely. So this is the gastrocolic omentum being taken away from the distal, from the proximal descending colon on the left side. So this is a step that we have added later on. Previously, we were not doing this step, but we have found that by doing this step, you get a very good clearance. When you come from lateral aspect, it's much, much easier. Now, if you want to take the vessels inside, this is the time that you should take the sigmoid mesocolic vessels, but the vessels can be easily taken outside extracorporeally. There is no real benefit, in our opinion, of taking vessels inside, because this is a benign disease. The vessels have to be taken very close to the colon, and that's why there is no real benefit of taking vessels inside. So we have taken vessels inside in many patients, but we found that it's not really much useful. So if you want to do that before doing the lateral dissection, you should take the vessels inside. Now this is the lateral attachments of the rectosigmoid. We start from the rectosigmoid, and as we go up towards the left colon, here we will see, we'll come into that space that has been created from the medial to lateral dissection, so that you'll identify the ureters in the floor as we go up. And as we go up from the left colon towards the splenic flexure of the colon, you will actually meet that plane which has been dissected from the other side. So most of the dissection you see here is also with the monopolar spatula. One can use a hook instead of a spatula. It's a personal preference. But there is no benefit of using harmonic. Harmonic creates a lot of smoke. It destroys the tissue planes and it reduces the speed of your surgery. So we believe that, only at the time of the splenic flexure, because it is deep and contains the omentum, we need to use the harmonic as we go up. That's the white line, the descending colon. As we go up towards the splenic flexure, you can see here that it meets the previous plane that has been created from the left side. And as we keep going up, we also have to go posteriorly so that from the gerotas fascia, the colon is separated. And this will land us to the complete mobilization of the splenic flexure of the colon. Posteriorly will be the gerotas fascia, because that has been dissected previously. You can see the spleen now coming into the view. And then you pull down both the colon closer to the splenic flexure, splenocolic ligament. The splenic flexure needs to be completely dissected to get the omentum away and the splenic flexure down. So that completes the complete mobilization of the left colon with the splenic flexure. Some of the greater omentum or the gastrocolic omentum is still adherent, which is being separated here. And one needs to get into the lesser sac to see the stomach from lateral aspect to completely mobilize the splenic flexure of the colon. So it's a very painstaking division, but only when you do this, from a very small incision, you will be able to deliver the entire colon outside. Now, once this is done, our attention now comes towards the rectum. So the next step after the complete splenic flexure, we make sure that splenic flexure is completely mobilized as we come down before we switch our this thing to the rectum. Now for the rectum, the surgeon's camera position will be the same essentially, and the monitor also is towards the left lower aspect of the head end of the feet end of the table, and the rectum is now pulled out by one assistant grasper and lifted up by another assistant grasper. So the two assistant graspers use this endoclinch kind of forceps which give a good grip, and the appendices epiploicae are the ones that are held. We never hold the colon directly with any laparoscopic instrument. That has been our policy right from day one, because colon is a very thin walled structure and the traction required is very long. You'll need to pull it out and pull it up, and most of the time these tractions are outside the field of view. Even so, if injury happens, you won't know. That's why we don't use directly hold the colon, but we hold always the appendices epiploicae to mobilize the colon. Now next step is to get down posteriorly on the right side and then posteriorly on the rectum, and the plane of dissection in the upper part of the rectum is in the TME plane. So that's why, because it is a avascular plane, it is much easier. We prevent injury to the nerves by going closer, and we identify the nerves most of the times in a laparoscopic case because of its magnification, and make sure that we preserve the nerves, because these are young patients and nerve preservation is very, very important. Autonomic nerve preservation. So as we go down first on the right side, then posteriorly completely we go down as much as we can, keep dissecting in one position as much as you can, and you need to be in the correct plane so that you use the spatula as a dissector as well as a cutter. So it serves dual purpose. You can see the levator now getting into view. Subsequently, then we hold the rectosigmoid, take it on the right iliac fossa, and now come to the left side. On the left side also try to preserve the peritoneum, remain close to the rectum as much as you can as you go down, and make sure that you identify the ureter again before you going down. You can see the ureter on the left side, the gonadal on the left side, remain medial to the ureter and the gonadal, and then keep traction, counter traction, dissection. These are the only tricks of this surgery. So it's actually teamwork where your assistant also helps you. In this patient, we had to take this stitch for hitching up the uterus because it was coming in the way as we were going down into the pelvis. Most of the times, even the assistant graspers can retract the uterus and take it away from the harm's view. But sometimes to get a good vision, you may just hitch the uterus up, and that will give us a very good view for the pelvic dissection lower down. So you can see the middle rectal can be coagulated here. As we go down, we start coning much earlier than in the cancer case. So as we come down onto the middle rectum, you can see that we are going through the mesorectal fascia now, or the mesorectum, as we go down. Next, after taking the left side, we do the anterior peritoneal division with the left side. So that is how we will expose the anteriorly, make a space between the rectum and the vagina. But that dissection will be done later. So you can see here, then we come from the right side to the anterior, divide the peritoneum. As we go down, you can use a hook here also, because anterior peritoneum can be better divided. As we go down again, we'll see the vagina as it curls up, and then we cone down and go close to the rectal wall. So as we go down, we keep going more towards the rectum, coning down, or getting close to the rectum. Next, we do the more anterior dissection again. We use again traction, counter traction, and just push the vagina away and keep dissecting with the hook perpendicular to the rectal wall as we go down. So that is, you can see that, all the fat we are dividing, getting close to the rectal wall, and that's anteriorly, you can see the vagina being separated. And it's a very painstaking dissection, because you want to go all around of the lower rectum completely on all sides, and going till the levator ani on all the sides. So this has to be done very meticulously, because you don't want to keep a long stump. There is no haste, or one has to give enough time to do this dissection, going down, making sure that you don't injure the vagina, because the pouch vaginal fistula is one of the worst complications of this operation. So one is very careful and do this dissection, keep going down. It's almost that we go till the intersphincteric plane is reached posteriorly, because then once we are there, we'll be able to keep a very small rectal cuff, a very small stump. So posteriorly, one should go right till the intersphincteric plane is reached all around. So this dissection keeps happening till we go down circumferentially all around the lower rectum before we apply the stapler. So one should not be in a haste of applying a stapler. Make sure that there is a good dissection lower down. Otherwise, what happens is that the long rectal cuff remains, and this creates cuffitis. A long rectal cuff creates a lot of problems for these patients, and it's a very bad complication of this surgery. That's why it's very important to have a very small rectal cuff as you go down and do complete dissection. So once complete circumferential dissection is done, the next step is to have the stapler, fire the stapler. Again, more dissection is being done. So now, because this is a female pelvis, a wide pelvis, we are using a 60 stapler, and we are able to fire it with one stapler, but most of the times we need two firings of 45 stapler. Especially for a male pelvis, we always use a 45 articulating stapler. We articulate and go down and do a complete dissection, so that there is a very small stump. Before dividing, we always put a finger into the stump and make sure that the stump is not more than 4 or 5 centimeters of stretched rectum after the stapler. You can see here that the finger coming into the rectal stump to make sure that the stump is not bigger. So the assistant puts a finger before we fire the stapler to make sure that it's a small stump. If it is 4 or 5 centimeters on a stretched rectum, then you are right on the pelvic floor. So that is a guide for us. In this patient with the one firing, it's a rare situation that with 160 firing you can do it. Occasionally in a female patient with good mobilization you can achieve this. And then the less the number of firings of stapler on the distal stump, lesser is the anastomotic leak. And it has been proved by evidence that more the number of staplers you fire on the distal stump, more is the anastomotic leak. The next step is to get to the right colon. The surgeon and the assistant shifts to the other side, and they change places. The foot switches are all changed, and then the two assistant ports are now used by the surgeon as the working ports, and the two surgeon's ports are now used as assistant ports. The small bowel is now again folded up on the upper abdomen by bowel graspers with a steep Trendelenburg position, we get all the small bowel out of the pelvis and folded up. And then we expose the root of the, this is the IMA artery and the vein, you expose the root of the mesentery. So from the IC junction, the RIF grasper and the DJ flexure by the right upper quadrant grasper, both these graspers lift up the root of the mesentery, and then the incision is placed. One identifies the duodenum, the third part and the second part before we put the incision, and then this peritoneal incision is then extended towards the ileocecal junction and from the DJ flexure. So once this is done, this is quite well done in laparoscopy. It's very difficult robotically because you don't get this space, and robot is a very space constrained technology. It requires a lot of space inside. So this becomes little difficult. In a robotic platform, we enter from the ileocolic pedicle. That is our technique. But in a laparoscopic platform, this is how we go from below. And here you can see the second part of the duodenum being viewed in the posteriorly. It is being separated from the mesocolon medially. So medially, the most important structure is the second part of the duodenum. Laterally, we have the right ureter. You can see here, it's a mesocolon is being separated. And here also the trick is traction and counter traction, because you have to get into the correct plane. These are all embryonic fusion planes, which are avascular planes. So the second part has to be completely separated from the mesocolon. Mesocolon is completely separated, and this you can see on the right side the Gerota's fascia and the right ureter and the right gonadal veins, which will be pushed posteriorly. So with this, the right ureter, the right gonadal vein, all this, after this complete mobilization is done on the right colon, again, if you want to take the vessels inside intracorporeally, this is the time you should take it intracorporeally. But nowadays, we also prefer to do it extracorporeally rather than taking them intracorporeally. So once this mobilization is completed, then we come again, just as in the left side, what we do is we take the gastrocolic omentum. Similarly, here also we will take the gastrocolic omentum after this complete mobilization is done. So here the right kidney is also exposed. Most of the times it will be the Gerota's fascia, but it's very thinned out. Gerota's here, and that's why the right kidney is exposed here. So once the right, this retroperitoneal is mobilized, you can see here that this is some lateral mobilization of the ileocecal junction is being done here, so that when we come from above, we don't need to do this again later on, because the bowel position is very conducive for us to do this mobilization, lateral mobilization. So we'll do some of the lateral mobilization before, as much as we can on the right colon before we go up and then come back again. So then the specimen will be completely separated. So this is the right colon. As you see the traction being increased. Now again, we come from starting from the mid-transverse colon and then going towards the hepatic flexure. That's the gastrocolic omentum being lifted up. And here only we use the harmonic for taking the omentum. Rest, we don't use the harmonic or the ultrasonic energy in this surgery. We use all monopolar coagulation. So this is the similar to what we did on the left colon, starting mid-transverse, going towards the splenic flexure. Here we are starting mid-transverse, going towards the hepatic flexure. So these are now very standard steps that we follow, so that we are able to execute this operation in a very standardized fashion. And it is even good for the trainees to learn this procedure, which is quite a complex procedure. This is the hepatic flexure of the colon being taken, final mobilization. That is the gallbladder here. The duodenum will be visible very soon as we go down. Because we have done the complete duodenal mobilization, we are quite confident as we come from above that duodenum will be quite posterior, because we have already, separated it from below. As you see, the active part of the blade is up, the upper part, the lower part is the inactive part, because the harmonic or the ultrasonic energy heats up quite a lot, and it's very important. You can see the duodenum, the second part here, down below. And it heats up quite a lot, and it can create a lot of thermal energies, injuries. And that's why it's very important to, this is the gastrocolic omentum being tucked away. And this is the final mobilization of the hepatic flexure of the colon, dividing the hepatocolic ligament. You can see the second part of the duodenum here easily. And then the next step is, after mobilization, we use a mini laparotomy. This is about 3 inches of incision, about 6 or 7 centimeters, depending on the obesity of the patient, where the entire mobilized colon is exteriorized. The small bowel also is completely exteriorized. It is checked for any inadvertent injuries or any inadvertent pathologies. And then both the flexures are mobilized. Some part of the omentum which is still not removed is removed, and subsequently the colonic vessels are taken with ligature very close to the colonic vessels, colonic wall. We don't use stitches for any of the vascular pedicles because that increases the risk of obstruction, and the end of the staple line is buried with a second layer. An ileal, terminal ileum is folded on itself to create the J pouch, which we create with, we used to create it with 2 firings of blue cartridge, but then we had encountered some bleeding in the pouch in a couple of patients, and now we have shifted to using a white cartridge, using 3 firings of GIS 60, because in GIS 75, we don't get the white cartridge, is not available. So we now use the 60, 3 firings of 60, so it's an 18 centimeter pouch. This is a slightly older video, so it's showing a blue cartridge with 2 firings of GIS 75, so that makes a 15 centimeter pouch. We use a 28 circular stapler, so the anvil is picked up and purse string is applied. The purse string end is kept anteriorly, so as a marking, so that there is no twisting of the, and then we place the pouch first, and then followed by all the small bowel is placed inside. There are several techniques to recreate the pneumoperitoneum and do re-laparoscopy for the pouch channel anastomosis. This is one of the techniques, using a glove port over a wound protector. We have some hand ports also which we can use. And finally, a double staple pouch anal and rectal cuff anastomosis is constructed, making sure that the lie is good. There is no tension on the pouch. The pouch is lying easily on the pelvic floor. The orientation is okay. There is no small bowel going behind the mesentery. All these precautions we need to take. Run the small bowel completely, so that making sure that their lie is not twisted, and the root of the mesentery remains in the straight line. So with all this checking, we then fire the stapler, and then we do the leak test. The pouch, as you say, is very easily sleeping on the sacral promontory. Actually, it should not be just standing, but it should be reclining on the sacral promontory. That means that there is not much tension on the pouch. If there is tension on the pouch, we have to use a lot of relaxing incisions and techniques which to enlarge the pouch. So there are several complications to this operation. It's not a very, it looks quite an easy surgery, but it is fraught with a lot of morbidity, and that's why a lot of counseling needs to be done for these patients for these kind of complications. We have published our techniques. We first described a hybrid single incision pouch, the first of its kind in the literature, in 2010, and we have also standardized our technique of laparoscopic RPC, which has been published. So whether to do it open or MIS, there are many studies in the literature. There are some systematic reviews, meta-analysis, which have shown that the early recovery is much better with laparoscopy. Overall, the long-term functional results and the morbidity is essentially similar, but the risk of fertility and urinary dysfunction is less with laparoscopy than with open pouch. What about robotics? We are not sure. Still, there are very few studies or cases reported of robotic pouches. And this is another systematic review, meta-analysis, also showing the same thing, that laparoscopy takes a little bit more time, but the early results are much better, and the pregnancy rates are also better. So these are the 10-year outcomes from one of the largest centers of Cleveland Clinic, Victor Fascio's unit, compared the UC and the FAP. And they found that these patients, some of these patients do have a minor incontinence, and these are the risk of complications The pouchitis risk was reported as about 35% versus in FAP it's about 19%. So it has to do something with the disease itself, that pouchitis happens in the long term over a 10-year period. And this is a quality of life assessment done at the Cleveland Clinic. 90% of the patients report an excellent quality of life. Some restrictions in a few of the patients for diet, social, and work restrictions. Our own experience, we have so far done, this is my personal experience, 222 cases so far. Since 2006, I think it's been laparoscopic. Most of the cases, 165 are laparoscopic pouches, and majority are, two-stage pouches, laparoscopic assisted, 162, and only few cases are single-stage or three-stage procedures. This is our data on 165 laparoscopic pouches, their morbidity and mortality and outcomes. We have had our fair share of complications, pouch hemorrhage, anastomotic leaks. Pouchitis risk is 17%. Cophitis, we had one case of pouch vaginal fistula, and 3 patients we had to take down the pouch with the pouch failure. Functional results have been very, very satisfying. Most of these patients have an average frequency of about 6 a day, 1 at night, or at the most 2 at night, and about 4 in a day. So to conclude, laparoscopic RPC-IP has evolved into a very standardized procedure, and now the focus is how robotic can help these patients, or SILS or TATME can help these patients in selected situations. Most patients have a good long-term outcome, but procedure still has a significant morbidity, and that requires thorough counseling. Intestinal obstruction, pouchitis are some of the things that we still have to maneuver with, and the complications, sepsis, because these patients are on immunosuppression, and late complications have to be managed for these patients. And some patients may require pouch failure and pouch excision also. Thank you very much.
Case. Sir, you have covered I think everything that pertains to doing a ulcerative colitis surgery. But how do you counsel young patients coming for a surgery? The patients who are taken up electively for the surgery, what are the key points that you include in counseling? Because after the stoma closure, there are some issues with the young patients particularly. So how do you take them?
I think that's a very good question. Counseling is a very important part of this surgery. And counseling does not mean convincing. Counseling means educating. And I always make it a point to educate the patient. I never try to impose the surgery on them. Let them earn this surgery. So on an average, at least I do about at least 2 or 3 sessions. I don't try to sell the surgery. I try them to buy the surgery. They must be convinced that this is a better option for them. So in any patients who have a moderate to severe pancolitis, I will counsel surgery. In mild proctosigmoiditis, I don't even talk about surgery to patients. But for any patient who has moderate or moderate to severe pancolitis, I will, or rare cases, even severe proctocolitis. But these are in our series less than 10%. In the Cleveland Clinic series, 35% at proctosigmoiditis, but we don't operate mostly for proctosigmoiditis. We generally operate for pancolitis. So in a sense, I think it's important to just tell them what are the pros and cons of surgery versus the medical treatment. Both are effective. You can tell them it all depends, nutritional sequelae, all this risk of complications of surgery, complications of the disease, its treatment, and all these we need to counsel them. Most of the times, the first initial reaction is surgery for this disease. That may be the initial reaction. But some patients feel, no, I want a one-time cure. I want to get rid of this disease. I'm tired with this disease. I've been suffering so much. I'm not able to eat. My nutrition is going down. And they are convinced for this surgery. And then we decide, then the second time we counsel them about the stages, the way we are going to do it, what are the likely complications, pouchitis, risk of pouchitis, risk of all this, how it will be managed. All these we explain them well in advance, well in detail. So it's not like a routine surgery where we can just try and operate these patients, because these are the patients who are going to be with you for life. Once you operate them, any problems is going to happen to them, they are going to come to you. That's why it's very important to spend good time to develop a good rapport with these patients. And they are very, very satisfied. It's a very satisfying surgery. Once they are rid of their problems and they have a good result, it's a very, very satisfying surgery.
Thank you, sir. Sir, one more thing. Do you kind of fix the pouch after doing the anastomosis? After firing the stapler, do you try to fix the pouch? Do you want a prophylactic stitch to avoid
We
the
don't use the fixation of the pouch. In our series, we just had one patient who had a pouch volvulus, but that was many years after the surgery when the pouch had enlarged so much, and then it had just like a sigmoid volvulus, the pouch had undergone a volvulus. Fortunately, we could salvage the pouch in this patient, but I have not found that it requires to be fixed. It's not described even in the literature, and that's why we don't resort to fixation of the pouch. Generally, it gets adherent, so the lower part, because it's a raw area in the pelvis, it just gets adherent there in some days. And then when it enlarges up, it goes into the abdomen. It does not remain in the pelvis. It becomes a big size pouch once over a period of time.
Sanjeev, how many times your pouch reaches comfortably all the time, or sometimes it bowstrings, sometimes?
I think most of our patients are quite slim and trim. I mean, they are, very narrow built. So most of the times pouch reaches, especially since we have started stapled pouches. When we were doing hand-sewn pouches, I remember more than 20 years ago, then there was a lot of struggle, to get the pouch, to do a pouch annals, sutured anastomosis, there was a lot of struggle. But since the stapled pouch, I think that's not a big problem. While deciding, finally, what we do is we try to pull it down and see which is the most dependent part to decide which is the apex or the pouch which will come down. It should reach at least 2 centimeters below the pubic symphysis. If it reaches 2 centimeters below the pubic symphysis, it comfortably reaches down. If it does not, then we use some, tricks like making some, openings into the mesentery.
So that in that case, I sometimes divide the main artery, which goes down, although it does not compromise the blood vessel because it is all very, very.
So what we do is when we take the right colon, we go very close to the right colon. So we preserve the complete ileocolic. Sometimes we even preserve the middle colic right branch. So we have an alternate supply.
So that
in case we need to divide even
we need to
the
divide,
ileocolic,
there is
then we get a blood supply
very good
from the middle
collaterals.
colic. So that's
You said it's quite a lengthy surgery, so why don't you use the vaginal prop inside and then hook the vagina anteriorly so that between the rectum and vagina, as I saw here, the vaginal wall is falling lax and maybe taking more time there. So a traction between the two can
definitely help.
If there are no more comments or questions, we can close. Thank you, sir. Thank
you
you, Dr. Sanjay Haribhakti, or sparing a time on a Sunday afternoon. Thank you very much, sir. Really appreciate it. We have an exciting session coming up. Dr. Roy Patankar, sir, has already joined us from Mumbai on Zoom. Sir, can you hear us? This is Rashesh here. Please unmute yourself. Are we ready?
Yes. Hi, Rajesh.
Good afternoon, sir.
Good afternoon to you.
Dr. Roy needs no introduction. He is a master trainer to many of the surgeons, even in this audience. Very passionate surgeon, and he's a prime example of how one can continue with academics and teaching even in busy private practice. Sir, we welcome you to this event, and thank you for sparing time on this Sunday afternoon. He will be speaking on ventral mesh, laparoscopic ventral mesh rectal, something which is very close to his heart, I believe, in addition to laparoscopic anti-reflux surgery. Am I right, sir?
Absolutely, Rashesh. Thank you for that. I actually enjoy functional bowel surgery, and as Sanjeev also has said, I think this is actually much more of a responsibility as compared to doing anti-resection. Because in a malignancy, patients often forgive you some morbidity, but in this there will be no forgiveness. Whether they develop an LAR syndrome or whatever, there is very little morbidity that is acceptable to the patient. Can I start, Rajesh?
Yes, sir.
I would just like to invite the chairpersons for this session. Dr. Kaushik Gajjar, Dr. Shailesh Shah, Dr. Nishit Patel, and Dr. Jainam Shah. Sir, you can start.
Thank you. Can you see my slide?
Yes, sir.
Wonderful. So I'm going to talk to you on ventral mesh rectopexy, which is one of my areas of interest. As Rashesh said, we have a pelvic floor clinic in our hospital. We see a lot of incontinence, obstructive defecation. We have our own technique of doing MR diffeography. We have a separate innovative technique of doing biofeedback. And that's one of the areas of concern. I think if you look at full thickness rectal prolapse, I think 90% of surgeons in our country are doing posterior rectopexy, either sutured or mesh. And we keep doing the same technique for every rectal prolapse that comes to us. As time progresses, you realize that anatomically you're reducing the prolapse, but the evacuation of bowel is not always good. And this is very typically seen in what is called the Dunning-Kruger effect. Over time, you realize that you need to taper or tailor the operation for the patient rather than the problem with our surgeons is we learn one operation and we do the same operation to all our patients. So as Einstein said, any fool can know. The point is to understand. And the first thing that we have seen and published is that almost 27% of patients with full thickness rectal prolapse will have some problems with the anterior compartment with the bladder and the middle compartment with the vagina and uterus. And if you just simply sling the rectum up without doing anything to the anterior compartments, likely these problems will develop de novo after your rectopexy. This is particularly important because of these autonomic hypogastric nerves. And as they say, every problem has a solution and every solution has a problem. Till date, there are 106 operations described in literature for rectal prolapse. But let's look at the results of the posterior suture rectopexy, which is excellent efficacy and control of the prolapse, but the constipation rates from 11 to 20%. Posterior mesh rectopexy, again a low recurrence, but between 10 and 20% de novo constipation. I'm not even talking of patients who previously had constipation. So we looked at these patients very carefully and we published this in the Indian Journal of Radiology some years ago. And we were doing various operations. We virtually do both perineal and abdominal operations. And we published both in the World Journal of Colorectal Surgery and JMAS on these two techniques. So this was first described by Andrew Duhour, a Belgian surgeon. Just to give you briefly, the key issue of this operation is to go really deep in the pouch of Douglas, dividing the rectovaginal septum and going to the pelvic floor as is seen here. After this, there are many ways of deploying a mesh, and I'll talk about this as we go on. One conventional way in male patients, when there is only a posterior compartment problem, then we put in a straight mesh and suture that to the sacral promontory. Coming on to patients who have prolapse with ODS, that is the real challenge. And if you look at our patients very carefully, many patients will actually have constipation or ODS as part of their pathophysiology. Our pre-op workup is MR, diffeography, manometry, and a colonoscopy. We use a 10 millimeter port head down position. Patient is kept either flat or in a low lithotomy position. One of the things that I want to emphasize is the manometry is optional. But MR diffeography I would do in every single patient in order to visualize the anterior and middle compartment. These are my ports. My working port, they're very similar to what I do for a anterior resection. The first step is to hitch the uterus up using a linen or a silk stitch. This is a female patient. The patient is put in a head down position, and the first thing we do is pack the small bowel away. Now, one trick I'll say is please give your bowel prep 24 hours prior to surgery. If you give it immediately pre-op, then you will find a lot of gaseous distension of the small bowel. This entire operation I do with a monopolar hook, sometimes use a bipolar when I come to the lateral ligament, but the funda of this operation is not to do posterior dissection of the ampulla of the rectum. The conventional rectopexy as described by Duhour asked you to preserve both the lateral ligaments, but I divide the right lateral ligament as defined by the St. Mark's group. Over the promontory, you identified both the nerves and you're working in the loose areolar plane. What is really important is the left hand. The left hand is the one that is doing the dissection. The right hand is merely doing the blind division. So left hand dissects, shows you the left loose areolar plane, and then you can work in this area. You must preserve both the hypogastric nerves even in female patients because dyspareunia is not uncommon after any rectal division. So here you see me dissecting the right pararectal space, and I go all the way down till I see the right levator covered by the fascia. The endopelvic fascia must be exposed but not divided. You can see me using a ligature here. This was done live in a workshop last year in a laprosurge meeting that we do every year. So you see the right pararectal space divided, then I work anteriorly. Now the majority of times the failure of this operation is because of inadequate dissection anteriorly. And what I do here is ask one of my fellows to put a finger in the posterior fornix and lift the posterior fornix upwards. Do not pack the vagina, it actually makes your life more difficult. Next is going into the left pararectal gut, and this is a simple operation, takes barely 45 to 50 minutes, and I think Rashesh has assisted me for one of these, so he knows how technically simple this operation can be, provided you remain in the correct planes. The next thing you want to do is to identify the left levator covered by the left endopelvic fascia. Do not divide the left lateral ligament in order to preserve the denervation of the ampulla. What we do next is join these two planes together. That is, the endopelvic fascia must be seen on both sides, and you must divide the rectovaginal area up to the same level, and it is important to go down very, very close in the anterior part. The failure of this operation is because surgeons are worried about injuring the vagina here, but this is absolutely crucial because you remember you're not doing posterior dissection of the ampulla when you're doing this. So this is the right endopelvic fascia seen, the loose areolar tissue, both the nerves have been seen and identified. This is left. I have actually opened the endopelvic fascia on the left side because it was a live case and the moderator was egging me on, but this is how the dissection can be done. Now, what kind of shape of mesh would you use? In just a simple rectal prolapse, who is in a male patient who has no pelvic failure, as in they have no obstructive defecation, I put a straight mesh. But otherwise, I will put a L-shaped mesh, a macroporous, medium weight polypropylene mesh. This is one of my earlier videos, which I was using Ethibond. In the last 1 year, there has been a consensus paper published in February of this year, 1 month ago, which showed that using PDS sutures decreases the risk of mesh erosion. And I think in the last 2 months, we have done 4 prolapses. All of them I've used 2-0 PDS to suture the mesh to the rectum. And this is the suture on the levate ani. So what you're doing here is basically lifting the entire pelvic floor. This is important because a lot of them have abnormal pelvic floor descent and the mesh must be taken all the way down. In a female patient, this is how I would do it. In a male patient, I go up to the mid or the lower part of the seminal vesicles. Remember, in a male patient, the denormalius fascia has 2 layers. One layer must remain on the seminal vesicle, one layer must remain below. You may either put a suture. We currently have been putting sutures, but I think this was in a live workshop and we've used a tacker to fix, but we always put in an extra suture to fix the mesh. And then the last step obviously is to extraperitonize the mesh using 2-0 Ethibond to make sure this is the green thing you saw was ureter. We are currently doing a study to identify ureter using intraluminal ICG. And particularly in rectopexy, it doesn't matter too much. But in a vesical fistula or a vasicocolic fistula, we find this ureteric identification using ICG extremely good. One important point is before fixing the mesh and before fixing this to peritoneum, make sure the prolapse is fully reduced. You may accidentally do the entire rectopexy with the rectum lying out. This, you can see me, I'm using 2-0 muscle, but usually what we use now is 2-0 Ethibond. We are very meticulous about closing this. No proline should be exposed to small bowel at any one point, and even the part below the uterus is carefully stitched. The uterus is then given up. You will never put in a drain, just a good wash. Patient is kept in a head down position for 12 hours, started on clear liquids within 4 hours and progress to soft diet and discharged at usually 36 hours on bulking laxatives. Some considerations that you must remember is any posterior rectopexy will cause de novo constipation in 20% of patients, whether you do a sutured rectopexy or a mesh rectopexy. Number two, anatomical correction of the prolapse is excellent with any form of rectopexy, ventral, posterior, or otherwise. Generally, what I do is, if I have a young patient who has a lot of constipation as well as prolapse, I would do the frequent Goldberg operation or the resection rectopexy, but almost 90% operations in my department. We do on the average about 20 rectal prolapses every year, and they are all, majority of them are now ventral mesh rectopexies. The nervi erygentus, the hypogastric plexus, must be seen and preserved in every patient, elderly, young, male or female. Always image and look at all the three compartments. Manometry I do only if there is SRUS or incontinence from medical legal perspective, and this is a technically simple and reproducible operation. In a young lady in reproductive age who's sexually active, I give them an option of using a biological mesh, but these are expensive, and in fact 99% patients we use a macroporous soft polypropylene mesh. The failure and recurrence rates are less than 1%. The worry for us is mesh erosion. Touchwood, I have not seen this in my series, but literature says between 1 and 2% incidence of mesh infection and mesh erosion. I'm quickly going to show you two papers. This was in colorectal disease in 2014, that is 10 years ago, and this was one of the first consensus statements showing that ventral rectopexy should be recommended for full thickness rectal prolapse. And only last month, this was an article in DCR on an international expert panel consensus. This is an e-publication which clearly mentioned that this actually would be an excellent indication for patients with multi-compartment prolapse, and a biological graft or a synthetic mesh may be used. A lightweight macroporous appears to be most favorable. The collagen meshes have a 1.5% recurrence rate. If somebody has an anterior middle compartment, we always involve a urogynecologist in the repair, and it may also be a good option in young male patients, provided you consent them separately and also take care of the nerves. So finally, this is what we do in our department. We'll tailor the procedure to the patient's fitness and anesthetic risks. In an elderly patient who is grade 3 or grade 4 ASA, we would do a perineal operation. We have published our technique of a stapled Altomeyers, but we also do the Delorme's operation. But the majority of cases, whether they have unilateral or multi-compartmental prolapse in our department, are all ventral rectopexies. Thank you very much.
Thank you, Dr. Roy Patekar. This is Dr. Kaushik Gajjar. Excellent presentation.
Kaushik Bhai, good evening.
Good evening. Now, I have got one personal question. I had done...
A little louder, please. I can't barely hear you.
There is one question. There is a recurrence after anterior rectopexy in a 75-year male with CKD. What would be your advice of second procedure?
The simple rule is failure of abdominal procedure, do a perineal operation.
Oh.
If the prolapse is less than 5 centimeters, I do a stapled Altomeyers. If it's more than 5 centimeters, I will do a Delorme's under spinal anesthesia.
Okay, thank you, sir. Question from audience? Yes, yes.
Sir, how you evaluate a patient of rectal prolapse with some neurological features also, like patient having a sensory loss in perianal region because of previous spinal surgery?
So then this will have to be evaluated by not only doing ultrasound with post-void residue, but also a urodynamic study. We have a very good urogynecologist working with us, and those are patients you must be very, very careful. The ones who come after a spinal injury or a post-op spinal issue do not do well after surgery. So please counsel and take that into account. You must get not only reduction of the prolapse, but also functional emptying of the bladder as well as the rectum. So be very careful of these patients. Neurological patients don't do well with any form of surgery.
Okay, so you refer for your medicine colleague only? You don't
As
perform.
much as possible, unless the patient is incapacitated, I would try and manage him medically with whatever treatment options are possible.
Okay, thank you.
Thank you very much, sir. We would like to listen you again and again, and maybe sometime meet in recent future. Thank you.
Thank you, Kaushik Bhai. Good to see you again.
Yes.
Thank you, Rashesh.
Thank you, sir. Thank you for a very enlightening talk, as always, very crisp, clear, concise. And your workshops are very popular, and looking forward to meet you again
So our next workshop, Rashesh Bhai, is 2nd and 3rd August. I'd invite all of you to come. You'll see about 40 surgeries from lung lobectomy to nephrectomy to anti-resection in 2 days.
Fantastic.
I'll be very happy to see all of you in Mumbai.
Sure, sir. We'll all join in groups and enjoy your academic feast. Thank you very much, sir.
Thank you.
Now we will move on to the last section of this academic carnival. This section is of edited videos. And our first speaker is Dr. Keyur Bhatt. Sir is a consultant GI surgeon at Seeds Hospital, Surat. And he would be speaking on fluorescence guided minimally invasive colorectal surgery, technique of stapled intracorporeal anastomosis. I would like to invite Dr. Anand Patel, Dr. Prem Patel, Dr. Ashwin Gadvi, and Dr. Hardik Bhatt to join the stage as chairpersons.
Good evening, friends. I think we are running a little late in time. Thank you, Rasesh, for the opportunity. And in the last session of the day, I switched it. I just need to rush back to Surat. So I requested, thank you to the other presenter who has allowed me to present in time. I was given a topic of intracorporeal laparoscopic anastomosis of using and stitch them together so that all the use of ICG during the colorectal surgery can be seen over here. So what I have not included in my today's video is the LAR, because we have entire day, we have seen a lot of LAR cases. So laparoscopic right hemicolectomy, how ICG can be a little bit helpful. A lot of things we have seen throughout the day, and by the eminent speakers, we got enlightened by many important things. So I'll be just briefly highlighting upon the things where ICG can be a little helpful in our day-to-day scenario if we have it. So this is how we can identify exactly the artery versus vein. If you give ICG on exactly time, you can, differentiate the vein and artery separately and clip it. I mean, just trying to extrapolate the use of ICG. This is the ileocholic vein getting clipped. While the video is running, what we had been doing in our cases of all colorectal ICG guided surgery, that the recommended dose of ICG is 5 ml to 7 ml. They ask us to dilute. What we do, we dilute in a 15 cc or 20 cc, the same ICG vial that has been provided. Use that entire vial every 3 cc shots whenever we want to use. So only one vial is used for the entire surgery, and we can use it at a multiple point of time, and every time you will get excellent demarcation of the vessel. So it's not necessary that you give full vial at one point of time. So even stage wise and step by step, you can see over here that once the colon is mobilized, in the last step, we want to see the vascularity of the ileum and colon for the right colon. Again, the last remaining 3 cc we have fired. You do a minimal small incision, open Barcelona technique, right hemicolectomy, anastomosis. That is our routine practice. We have never done a laparoscopic anastomosis for the right colectomy. So once even you do extracorporeal small incision Barcelona anastomosis, even after that, in open also, you can check the vascularity by putting ICG, by closing and switching off the lights of OT, and you can still see that, okay, the anastomosis part on the either side is nicely vascular. So this is how the ICG same vial can be used for the entire even 4-hour surgery. So this is a case of a sigmoid colon. Let's skip a little bit. We have seen this the whole day, that how we do a dissection with the monopolar diathermy. Again, this was a case of a little bulky tumor. You can see the tumor is getting light up nicely with the ICG, and there is a large bulk of lymph nodes all across the mesentery of IMA. So in this case, we decided to clip the vein first because we were not very sure of nodal mass which was entangled on the IMA side. So we mobilized the colon from either side. We mobilized the descending colon as well. Once all around colonic dissection was done, the again ICG was given just to identify the root of the IMA. This is the high ligation of IMA just over the root, but there was a messy large nodal mass which was there, which was making the surgery difficult. Once that is done, the vessel is identified, and then finally the surgery is begun in the standard manner. So once this all, skip it. Yeah, another thing I wanted to highlight is that in all the cases of sigmoid resection or even anterior resection, we have a habit to clip the superior rectal vessel even at the mesentery of rectum. Many people, I would say, probably they will disagree to me, but we had experiences in past that even by taking this vessel with a ligashore or any vessel sealing device, it tends to bleed. So we try and put a clip away in the mesentery, try and thin out the stuff, give again shot of ICG. Now you see that the rectum is nicely getting a light up from the both middle rectal vessels. It is getting nice supply, but we could see that yes, there is some amount of dusky area. So we revised in the ICG mode itself so that we can do a marking properly for the future anastomosis. And the descending colon is brought out. It is coming easily inside. We put a small incision again over here in the suprapubic region. We do intracorporeal anastomosis. However, it is done with the open long needle holder, and single layer interrupted anastomosis is done. Again, the vascularity is checked with the help of ICG, and the surgery is finished. So this was the benign case of sigmoid stricture, and we had been doing sigmoid colectomy for a benign case. It was a pretty unique case. In fact, she had an extra uterine sigmoid endometriosis repeated and leading to stricture. So we had to resect it. So I just stitched a couple of videos together to show intracorporeal laparoscopic hand-sewn anastomosis. So once both the ends of rectum as well as the sigmoid colon are resected, a small incision can be taken care to extract the specimen, followed by the end-to-end colorectal anastomosis is done. We have done quite a few cases of end-to-end anastomosis. We do it generally at the area of rectosigmoid junction. In lower rectum, we don't prefer to do a laparoscopic manual hand-sewn anastomosis. So here, our technique is pretty standard. We use 30 or 40 PDS depending upon the thickness of the rectum of the colon. And posterior layer is done in a continuous fashion, starting from standard knot outside and going inside. Posterior layer is over, we put the suture aside, and then we take another suture from the opposite end again, and we continuously bring it to the opposite end. And the end-to-end anastomosis is completed. So this we have done many cases of benign benign sigmoid colonic resection, especially when we are operating for the sigmoid diverticular disease related or diverticular abscess related disease colectomies. So for malignancy also of the sigmoid colon, we have used at times intracorporeal anastomosis. So this can also be done with the help of ICG once we are pretty sure 100% that okay, the vascularity is very good, there is no other issue. One can go ahead with the laparoscopic intracorporeal anastomosis of colon to rectum. We do inspect in the end. If we find that okay, at some space you find a little gap or little bit more gap between the sutures, but that can always be reinforced with the help of multiple interrupted sutures, either Michael 30 or PDS 30 or 40. So again, the ICG probably in this particular kind of a cases gives you a little extra advantage of surety of the vascularity, because you don't see anything or you don't have any translucency test that can be done in laparoscopy. So that helps in doing an intracorporeal anastomosis. Last but not the least is the laparoscopic stapled sigmoid to colon, I would say, anastomosis. The similar fashion, once the area of demarcation is achieved, the bowel is demarcated and bowel is resected, and it is divided. One can still see nicely that the lower rectal stump is having a very good dye, a good supply. The color change can be easily appreciated on either side. In this particular case, like we had a large redundant sigmoid and good descending colon that we have mobilized. So we decided to do, rather than doing an end-to-end anastomosis, we did a Barcelona technique, descending colon to rectum anastomosis with the linear stapler. So it is done in a very similar fashion what we have done for the right hemicolectomy of any malignancy of the right side. It is done in a very similar fashion that if you have a good mobilization of descending colon, that can be brought out. Practically, this is end-to-end anastomosis. Theoretically, one can say this is side to side. So 160 load staple is fired in this side, and then the antrotomy side or the cut and open side is multiple sutures are taken with either 3 or 40 Vicryl. This is a very important step whenever we are doing Barcelona technique anastomosis, that none of the cut end of bowel should remain open, and that should be given enough and good traction by the assistant before closing the gun and firing the stapler, because otherwise this can lead to slip of one of the leap of colon, and ultimately it can lead to leak. So the very similar fashion what we do for right hemicolectomy, same thing can be done for the left colon as well, and depending upon the width, 1 or 2 of 60 or 45 cartridge can be fired, and colorectal anastomosis can be done with laparoscopy as well. Thank you so much.
Yes, sir. Our next speaker is Dr. Devendra Parikh, and he will be showing a video on robotic TME. Sir is a GI consultant oncosurgeon at HCG Hospital, Ahmedabad.
Devendra had some social commitments and couldn't make it. Dr. Bharat from his team, Dr. Bharat Prajapati, will present on his behalf. Welcome, Dr. Bharat.
Hello. I'd like to thank you, GastroPlus team, for inviting me on this beautiful session. So the post-lunch session will directly move on to the video only. So video is about the TME. As we know, the standard of surgery in rectum is total mesorectal excision, and the most important margin, as we know, in rectum is CRM. So we'll be discussing things as we go along the video of robotic dissection. As we know, there are some few technical issues in rectal surgeries, that as we are doing surgery in a narrow male pelvis in a morbid obese patient, then there will be some difficulty in handling instruments of laparoscopy and having narrow space. There is only advantage of robotic system. So this is the Da Vinci XI system. As we know all, it has wristed instrument, 3D vision, 10 time magnified vision, filter of movements. So we'll be starting with the video itself. And as we know, so there are 4 instruments. The first instrument is cardiac, that is retracting the rectosigmoid upwards. Second is the fenestrated bipolar. And in my right hand, there is monopolar hot shears. As we start our dissection along the sacral promontory, we go along the retro rectal avascular plane along the visceral fascia. And that is important that we stay in that avascular plane, so to avoid the injury. And as we all know and we have discussed too many times that high ligation versus low ligation, we tend to do low ligation with clearance of left colic lymph nodes. As we know that literature has shown that as if we are preserving the left colic artery, it has advantages in view of we can preserve the superior hypogastric plexus and proximal nerves, and we can have less stricture and anastomotic leakage if we preserve left colic artery. And after, as we saw, after preserving the left colic artery, we have divided the suprarectal sigmoidal and we have divided the IMV also. Now we are dissecting the mesorectum from the retroperitoneal fascia. As we can see in floor ureter and left gonadal vessel, we are taking down the gonadal, and after taking down the gonadal, we'll start our TME along the posterior plane first. As we know, there is a loose areolar tissue between the mesorectal fascia, that is the retrorectal fascia, and the presacral fascia. In between the hypogastric nerves lies. So as we go along, alongside I have just put a one clip of another posterior exentration video. As we can see, I was pretty sure that I am in the right plane, but as I am advancing, how easily we can go into a one plane below into the posterior plane. As I have dissected plane, ligated the I have ligated low ligation. Then when I am going down, then I have realized that I was one plane below. That was the first cut that was taken at the sacral promontory. Now I am into the right plane. So to stay into the right plane, we need to be very sure that we stay between the two layers of the pelvic fascia. Otherwise we can end up injuring the hypogastric nerves. So so we can see there was the false plane. So I am now into the right plane. This was the posterior extension. Now we'll move to the original video. As we go along into the posterior plane, we can see we can use the curved tip of robotic hot shears, and we can use traction and counter traction. For avoiding the pelvic autonomic nervous injury, we need to have proper visualization, good knowledge of anatomy, proper traction and counter traction. Extra traction will lead to hypogastric nerve injury also. So proper traction and counter traction, that is utmost important. As we go along, we can see the proper mesorectum is being dissected. Now we'll shift the focus onto the left side. As we have to match our posterior dissection that has been already done, the medial to lateral dissection. So we are just opening up the left side, left lateral rectal ligament. Then we'll, as we know, if we have done proper takedown of ureter and gonadal vessel, we are just opening up the visceral peritoneum, so we are not worried about the ureteric injury at this point. And we know that hypogastric nerve runs parallel 1 centimeter to the ureteric course. So we'll stay close to the visceral pelvic fascia. So now we are going along to the left lateral ligament. After completing the left lateral ligament, we'll shift to the right lateral ligament. As we have done posterior dissection up to the levator ani, we will just have to ensure that we are just taking the peritoneal cut. So by having traction and counter traction, we are taking the right peritoneal cut. After and at this point, we may in 30% cases may find middle rectal vessel in lateral rectal ligament, but it can be dealt with either monopolar or bipolar. As we go along, we are shifting our focus to the anterior dissection. As we know, anteriorly, if we are staying between the two layers of Denon-Villiers fascia, there are less chances of injury to the autonomic nerves. And as we know, as we are saying, seminal vesicle is being seen into the picture. As we know, at 10 to 12, 2 o'clock position, the nerves lies. So extra traction by the third instrument, extra traction to the seminal vesicle, and after seminal vesicle to the prostate, at 10 to 2 o'clock position, the traction injury to the nerve can also occur. So we are trying to stay between the two layers of Denon-Villiers fascia here. As we can see, the third instrument is retracting bladder and seminal vesicle anteriorly. Second instrument is fenestrated bipolar, that is retracting the rectum downwards. So as we go along, we after few cuts and few centimeter of dissection, we shift our traction and counter traction. So with proper traction and counter traction, we can go along the proper visceral facial planes. So to avoid the autonomic nerves injury. So now we are about to complete the anterior dissection, and now we are shifting our focus to the remaining circumferential part. So by having traction and counter traction, we are shifting our focus to the right side. The remaining right lateral ligament and posterolateral dissection is being done. In rectal surgeries, the good visualization, traction, counter traction, good knowledge of anatomy, and the small burst of energy, monopolar rod shears energy usage is utmost important. And as we can see, this was case of I think ISR. So after a while, we can see the left levator ani into the picture. We'll start our dissection into the intersphincteric plane. So as we know, above around 2 centimeter above levator ani mesorectum ends. So for as Hildes described that tumor bundles in rectal cancer lies around 3 to 4 centimeter of mesorectum. So we need to have around 4 to 5 centimeter of mesorectal margin in to have good clearance and have negative margins. So as we can see, we are about to end the dissection at the intersphincteric plane, and the remaining cut between the prosthetic fascia anteriorly and rectum. As we know, mesorectum is about to end here. So after completion of dissection, we'll prepare the proximal stump and we'll ensure its vascularity by ICG. And then after perineal part will be done, and hand-shown coloidal anastomosis will be done. So as we can see in this male narrow pelvis, with help of the instrument and good visualization, 3D visualization, we can easily go around. And as I was not able to reach lower down on the left side, I'm shifting my monopolar hot shears into the left hand. So I can switch instrument in between. So I'm taking now monopolar hot shear into the left hand. In robotic surgery, we can use both instruments in right and left hand very easily. So this is the preparation of stump and ICG, and anastomosis will be done. Minimal invasive surgery is going to stay there in GI oncology. We already know that there is enhanced recovery, better functional and comparable oncological outcomes are there. So already it has entered a new paradigm, and all young surgeons must embrace this technology. Thank you.
Thank you, sir. Our next speaker is Dr. Vikas Variku. Sir is Professor of GI Oncosurgery Services at GCRI Ahmedabad, and he would be speaking on laparoscopic APR.
Good afternoon, everybody. At the outset, I'd like to thank the organizers for having me here. So we today had a very long and a hectic day discussing all the nuances of colorectal surgery, and I think most of the aspects have been covered. But I've been given the difficult task of describing a surgery that is something that's not very, the patients are not amenable, the doctors are not very happy doing it, but ultimately at the end of the day, this is a task that has to be done. Greetings from GCRI. The video option is not showing. Can I play it directly? Yeah. Yeah. It's full screen. This is full screen. No. Play directly. How to make it full screen? Yeah, this one. So I'm describing the case of a 36-year-old lady with a rectal growth about 2 centimeters from the anal verge, with involvement of the external and the internal sphincter, as well as the MRF was involved. This is a standard 5-port technique, and it depends on the body habitus. We made slight changes according to it. And we start with packing the small ball in the right upper abdomen and start our dissection at the junction flexure. We mobilize the flexure and get the bowel to the right side, and then continue our dissection below the inferior mesenteric vein and dissecting in the ureters, dissecting in the Toll's fascia and separating the Toll's fascia from the ureter. So here you can appreciate the Toll's fascia and the ureter's fascia that's falling down. And we go in the mesocolic plane till we reach the lateral abdominal wall. So here you can appreciate that I'm going through the ureter's fascia. And we go right until the lateral abdominal wall, visualizing the spleen. And then the dissection is changed to the suprapancreatic plane, and a complete infracolic mobilization of the splenic flexure is done. Because this is an APR, we don't do a very high ligation of the inferior mesenteric vein. And after ligating the inferior mesenteric vein, we switch our dissection to the left colic artery and ligate the left colic artery. And divide the mesocolon at that level. Then the dissection is switched over the aorta at the junction of the aorta and the inferior mesenteric artery. One word of caution is not to use unipolar energy at this region. It's always better to use bipolar so that you don't have any conduction injury to the nerves in that region. So we are preserving the nerves and we are taking all the nodes in a D3 dissection. And we are ligating the inferior mesenteric artery right from its origin from the aorta and making sure that we preserve all the neural structures. So here you can appreciate that the inferior mesenteric artery is being ligated just at the root and its origin from the aorta. Then we take the peritoneal cut over the sacral promontory and start the medial to the lateral dissection and communicate with the plane that we have already developed in our initial dissection. The ureters and the gonadals don't usually come in your way because if you are following the right plane above the ureter, they will fall down. And here it's paramount to stay with. So you can appreciate that the ureter just falls down by itself. You are staying in the plane, so you just stay in the plane right behind the mesorectum and in the plane between defined by the two hypogastrics. I think most of this has already been covered in the previous section, but the important thing here is that you should be able to reach right till the pelvic floor, divide the hiatal ligament, and mobilize the mesorectum from all the three sides. And the pelvic floor should be visualized on all the three sides. The anterior dissection, we preserve it for the perineal portion. And here we are assessing the stoma. And the sigmoid colon is brought out as a stoma, the permanent colostoma. Then we switch our dissection to the prone jackknife position. And a teardrop incision is made. We try to preserve as much as subcutaneous fat as possible unless and until it's a case of ischioanal involvement or there are multiple fistulae. Then the Lone Star comes into place. And we carry our dissection through the subcutaneous fat right till we reach the levators. And the levators are dissected right till their origin from the pelvic side walls. Our guide here is the fascia overlying the obturator internus. I think it can be visualized. So the obturator internus fascia can be preserved unless and until you are contemplating a lateral pelvic sidewall dissection. So we dissect the levators right till their origin from the pelvic sidewall. So here you can and the similar dissection is carried on the other side as well. After completing the dissection on both the sides, we move over to the coccyx and we routinely amputate the coccyx in majority of our cases. And after amputation of the coccyx, we divide the levators. And the specimen is delivered from the pelvic cavity. The anterior dissection in males between the seminal vesicles and the prostate is done. Here it's a female, so and the vaginal wall was involved, so we have taken a cuff of the vagina along with the specimen. So here this can be done very well under vision, this portion. And this is the defect, and this here you can appreciate a cylindrical elapsed specimen. So so this is the kind of a defect that you will encounter after a elapsed resection. And our choice is to put a pelvic spacer along with a acellular dermal matrix. That's the reconstruction that we do for majority of our cases. But sometimes, especially after an ischioanal resection and in resection in which there is a big cavity, so we do a VY advancement, either a unilateral or a bilateral VY advancement according to the size of the defect. So because we have a fair share of patients who come to us after rectal malignancy and they have fistulae, so there we need to do a ischioanal excision. And so here's another case in which we have done a unilateral VY advancement. And this is the final picture after the unilateral. And in certain cases in which there is a deep cavity, we need to deepithelize the medial portion of the VY flap and fill the cavity with this. And gracilis plasty is also used in selected cases, especially in female patients. So we can use a unilateral or a bilateral gracilis muscle to fill the perineal wound defect. And there are a few take-home messages for especially the younger surgeons who want to embark on this procedure. Good preoperative management is essential. Early control of vessels, mobilization, and if you are contemplating conversion to an open procedure, you might be ending up having a bad situation converted to a worse one. Fine. Thank you.
Thank you, sir. Our next speaker is Dr. Daivat Vaishnav. Sir is consultant GI surgeon at Zydus Hospital, Ahmedabad, and he will be showing us a video on robotic hand-sewn ileocolic anastomosis technique.
At the outset, I would like to congratulate my dear friend Dr. Rasesh and his entire GastroPlus team for arranging such a mesmerizing meeting. Lots of things that we are discussing since morning about the dissection part, but lot of things that we have, because colon and luminal organs are less harmful, and that's why reconstruction sometimes remains easier. Lapel. reconstructions remains easier, and that's why most of the time while discussing the disease, we just keep a reconstruction discussion in less than 20% of the time. Video will continue to remain, but I would like to touch upon some of the points, and that is about the robotic surgery. Although robotic surgery has been invented to safeguard the excellent surgeon from the battlefield, and they can just guide the robots to do surgeries in the battlefield soldiers. But now I can say now robotics has taken the center stage in recent years in the minimal invasive surgery. And I'm very happy to hear from two experts in the morning, Dr. Kalayasan, and during last lecture, Dr. Haribhakti sir also mentioned that we try to mimic the minimal invasive surgery as open surgery. And the most disadvantageous step in the laparoscopic surgery is the reconstruction, and that's why lots of laparoscopic staplers and more laparoscopic staplers have been used during laparoscopic surgery, because we were not able to mimic as good as open reconstruction in laparoscopic surgery. And because of advent of robotic, you can see this is a 47-year-old lady, has mucocele of appendix that we did limited resection of ileocolic resection, and then we decided to have hand-sewn anastomosis, avoiding the using of stapler. And you can see, I can say anterior to posterior, just like open surgery. My one of the hand is hanging the suture just like assistant hangs or stretch the suture. I started first from inside out, outside in, and then again came back inside the lumen, and then we started. Yeah. We are using the barbed suture, usually 23 centimeter length. 23 centimeter length. 26 mm needle. Usually we are using, and we use for posterior layer one and for anterior layer another one. But I have kept one or two sequences that what happens same as in open also that happens. You can see I have taken I am taking the sutures. I am happy. My movements are also, although I am also still in the learning curve. This is one of our second case of hand-sewn anastomosis. Last 10 months, around 1 year we have started, and we have now at least double digits, numbers in the double digits. But you can see I am doing this while taking the sutures. I realized that I have taken the anterior leap of the colon. So now what to do? I have taken the anterior, just like sometimes our non-concentrated assistant also in open surgery forget to take anterior leap. So I have taken again inserted the scissor and take that down, and again restarted the anastomosis. But beauty of this robotic system is that you are the camera person, you are the assistant, you are the surgeon. So you cannot blame your assistant or your camera person that you are not showing or you are not doing this thing. In this, I am only responsible for this mishap, and everything you are under your control. Once you have four arms like Chaturbhuj, Dwarkadhish Nijem, you are become Chaturbhuj, and then you can have everything is under your control. So you cannot blame that. Although you can blame always robot, it is not properly showing this. You can see one patch is there because of two cameras. While doing anastomosis on the console, I could not recognize that one camera is not properly functioning. But during this video recording, you can see there is consistent patch. That's why there are two eyepieces. One eyepiece was not properly cleaned up, and I have not bothered Now I realize in between also that there is a slightly longer tongue of the ileum is there, and this is maybe the culprit for anastomotic leak. So again, I have that uh, changed the instrument, asked assistant to put, and then I make it proper. So bipolar is also just inside, so it is not like that you have to ask bipolar, you come in again. Bipolar is inside, I have just did the bipolar thing, and again, now I'm so just like open, you can reach the stage, tighten up. Although these are the not tactile sensations, that is the disadvantage of robotic system. But over the time, once you are doing many cases, you can have a visualization is also like such a brilliant visualization that you can have a that visualized optics you can convert into the tactile sensation. So now I'm starting from again anterior layer. Again, I am checking that I have not taken this side, anterior lip, and lumen is open. So just like the backhand movement, you can of open surgery, you can reconstruct in the robotics. You can easily you can all appreciate how nicely we can do. And how precisely we can reconstruct properly. We have now around 10 cases in last year that we have right left colectomy. Although after Dr. Rase's invitation, we tried to mimic do one of the upper rectal case to do this colorectal anastomosis, but we failed. So we staplered again that stump, and then we did because of it, it's just too low. As the anastomosis around 8 to 9 centimeter. But if the rectum is entirely preserved up to sigmoidectomy, definitely we can consider this near normal anastomosis as compared to the staplered anastomosis. I can just skip. I want to, yeah, this is the knotting. You can see how squaring also we can, at the end, can do proper knot squaring. So you can see after completing, I have seen that this is something is dog's ear type of thing of barb suture is remained. So I have taken one more stitches, Vicryl 30 over that bleeding aim point. And this patient excellent recovery. This patient has history of abdominal tuberculosis around 20 years back, and then a resection was slightly difficult because of adhesiolysis, but recovered very well and discharged on post-op day 5. Thank you very much.
Thank you, sir. Our last speaker for the day is Dr. Ashish himself, whose efforts have made this academic fiesta possible. And he will be speaking on laparoscopic left hemicolectomy with hands-on anastomosis.
Welcome, Dr. Rasesh.
Thank you, Saurabh, but it is never a singular effort. It's always a collective effort. One person may be operating as his maximum potential, but the others also have to chip in. So it is only befitting that I am the last speaker of the day. It not take much time. We have a very hectic function where we'll announce the winners of the quiz and the paper and posters that happened in the parallel session. That was very enthusiastically attended and participated by the PG students from all over Gujarat. So I will share this technique of laparoscopic left hemicolectomy with hands-on anastomy, something similar to what Dr. Keyur showed. We have a descending colon sigmoid junction adenocarcinoma. Video. पहले तो आ गया था. Okay, thank you. Mac is a complicated machine after all. Thank you so much. So we had taken. Oh no, it is vanished again. Oh, okay. So the point that I want to highlight is that despite taking the IMA at its origin, we could salvage a bit of sigmoid and do a hands-on anastomosis through the phalansteal incision. Rest of the technique is pretty standard. We have been seeing it. Throughout the day. This was a lady around 40-year-old, mass at the sigmoid descending junction, and the plan was laparoscopic assisted left hemicolectomy. These are the operative steps. We have seen them in the only difference is the extracorporeal specimen delivery. I start with the IMB first and then move on to the IMA. After identifying the IMV, I believe IMV is a key landmark that needs to be identified in every patient, especially who need splenic flexure mobilization. Video is not playing. And yeah, these are the port position, but similar. Only thing is I place an additional, when needed, I place an additional epigastric port midway between the xiphoid and the umbilicus, and I can move my working ports to my left hand port to the epigastric port. So this is the exposure of the operative field. First step is of course and to move the omentum and the colon beneath the liver. The small intestine was kind enough here. It is not always the case, especially in high BMI individuals. We saw that with Dr. Ashwin is struggling, and if he can struggle, a lot of us can do. So that's the AV getting exposed at the DJ flexure, and this epigastric port sometimes helps retracting this bowel also. It is a that's the lesion there. It's very versatile. You can do a lot of things with that. You often will have to release the DJ flexure to identify the IMV. It is sometimes concealed beneath the DJ flexure, and there it is. It's getting exposed. Now, when you are doing this submesocolic dissection at the IMV, couple of structures that need attention and protection are, one is the ureter. The ureter can come up close and get injured, and the second is the left gonadal vein. So we must stay in that correct plane, take time if needed, and then once you go deeper, you will see this edge of gyrotas fascia, which is very satisfying, and you can just graze on the
edge there. This gauze piece is very helpful. It can not only retract the mesocolon but also help in blunt dissection. So once the edge of the gyrotous fascia is visualized, you drop it down, and the medial limit or the lateral limit or the limit of the dissection is the visualization of the colon there. Now here I'll just pause this for a second. Yeah. So the assistant is lifting the transverse colon, mesocolon anteriorly, something which we saw Dr. Ashwin also doing. It can be retracted through the epigastric port or through the left upper quadrant port. And here I'm entering there is a constant avascular plane just lateral to the middle colic vessel, and you can often see the stomach also through that window. And often with a monopolar, you can just enter that plane, create a plane on top of the pancreas, and exploit this plane further. You can see how the colon is retracted like a curtain on both sides. And here, there is a mistake there. There is a bleeding there, what Dr. Ashwin was mentioning, to not enter into the pancreas capsule. And we can go bit by bit on top of the pancreas up to the colon, descending colon there. And as he said, you must always visualize the posterior surface of the stomach. The mesocolon is there, and we often can go right up to the spleen as well. So once this is done, we can leave a gauze piece over there, as we saw earlier, and take the IMV and connect both the planes, the mesocolic plane and the sub-IMV plane, or the plane beneath, lesser sac plane on the cranium. So this is when you can approach supramesocolic greater omentum division through the supracolic route. Nowadays, I go from lateral to medial after completing the dissection. I'm going from cranial to caudal. If the omentum is bulky, you may struggle here, and therefore Saklani maneuver, which Dr. Ashwin showed, is of great help. It can, and that's the gauze piece that we had placed there. It is visible now, and one can often go right up to if you're incorrect, right up to the mid-descending colon. So after this is done, we take a peritoneal incision on the sigmoid colon. Important landmarks being the IMA. One should always stay close or hug the IMA. The pulsation help, and go bit by bit. Also, I'll just phrase this, and please notice how the IMB pedicle is held up, and this is giving an appearance of a seagull maneuver or a battering maneuver. And if you have the IMB and IMA spread out across like that, you can reach the root of the IMA very well and ligate the vessel at its origin below the left colic. We make slow progress. We must always remember that the plane is higher than one anticipates. And as Dr. Roy said, the medial guide to this incision is the rectovesical fold. Now you can see how we are. You can see this the sympathetic nerve, hypogastric nerve over here. The IMA is over here, and we are going close to the IMA rather than the hypogastric nerve. We like to use short bursts of hook unless there is fat over there wherein I'll switch over to a harmonic. We can make expand the plane and go medially up to the psoas muscle. When the traction, monopolar will need accurate traction and countertraction when it's not available. One can switch over to harmonic, taking small bites. As Dr. Praveen Bhatia says, small bites make small mistakes. So we come back over to this we're taking all the lymph nodes along the, it's not a good idea to keep the harmonic blade like that. The active blade is towards the vessel. So once this is done, we can clip the vessel and divide the IMA. Subsequently, we can exploit this medial to lateral plane and then come laterally. We're doing a bit of meso-rectal mobilization, upper rectum, so that we gain length for the anastomosis, which is planned actually extracorporeally. That's the lateral dissection. Again, the gauze piece there is seen and one is sure of the plane over there. The upper rectum is mobilized. This is the lateral mobilization. Now we are checking here to see whether the colon will reach, and this is we divide the descending left colic inside intracorporally and leave the marginal. We like to mark this point of division intracorporally, so that earlier we found that we struggle to identify the correct plane of transection. So in the straight line where we divide the mesosigmoid, we place a suture, and that helps us easily identify the correct transection plane. So it was straightforward. The specimen was levered out, dissected, and anastomosed. That's the appearance of the specimen with intracorporeal anastomosis. Drain was placed, and this is the port position. The post-operative course was fairly straightforward. Thank you very much. Please stay back for the valedictory function. Those who come from outside and want to leave, the high tea is being served at the multipurpose hall below the HT Parekh. So thank you, chairperson, and thank you, audience, delegates. You've been great and kind, and I am really grateful. Yeah. Hello. Okay, so it has been a long and tiring day. You want to invite Rakesh? Yeah. Come. So Dr. Rakesh is a very competent, minimally invasive surgeon.
Hello. Thank you, Rashesh bhai, for invitation, and I would like to invite you, all of you, on the upcoming program hosted by our Sabarkantha Aroli Surgeon Association at GMERS Himatnagar. This is a single theme conference on the basis of a video-based discussion. That is a unique way of presenting a scientific program. And we have, this program is named as a hernia nexus. And we have a interesting faculty from all our local faculty also with the state, and 3 of national faculty are also joining us. So we would like to share a brochure here. If it is there, then you can take an opportunity to register. Thank you.
Some brochure on the reception counter also, the registration counter, so that people can carry with them. Okay. So it's been a long and tiring day, and I would like to thank all of you. It was a very fulfilling experience for me, my first experience conducting an event of this magnitude. I was very apprehensive to begin with, especially after the dinner yesterday when we had very few numbers. I repeatedly kept messaging all of you. I might have irked and irritated some of you as well. But nevertheless, that's it. I want to thank the organizing team, Maulik, Ankur, who have been the backbone of this conference. They are the people behind the scenes, along with the organizing team, my team at GastroPlus, Ruksar, Sonam, Astha, and all of you who have been working tirelessly, who have, you know, tolerated my tantrums and bad mood swings throughout this event. And I really want to thank you. Without you, it would not have been possible. And I would like to say this, that without any agency organizing this conference, my team has organized it and given me the least amount of headache possible. So put a big round of applause to the organizing team. My physician colleagues and dear friends, Ravi, Sandeep, Ram, Mayur, and Manas, who have stood beside me. It's a dream team, really. I really enjoy working with them. They are all dear friends. They have stood behind me, and they have really encouraged me to conduct this event. I would like to thank Dr. Saurabh, who has been an amazing host right throughout this event. Thank you, Saurabh. I would like to thank Dr. Parth, Quizmaster. Is he here, Dr. Parth? Quizmaster? Yes, good job, man. Yes. I would like to thank the AV team, Amar Bhai and Merrill people, Manmitra ji and Naimesh Bhai, Ankur, who got them here. I think by and large, apart from a small glitch here and there, the transmission has been flawless. Right from Cairo also, it didn't appear that we are transmitting something from Cairo, Egypt. And I would really thank you from the bottom of my heart. I would wish to express my sincere gratitude to my teachers in MS and super specialty training for making me what I am today. Right from Dr. Nayan Swadhya to my MS teachers, Dr. Choksi, Dr. And my super specialist, Dr. R.A. Shastri and Dr. Birappa and others, with whom I have worked and learned the tricks of the trade. Last but not the least, I want to sincerely thank our sponsors from the industry. I hope everybody is here. Sponsors and supporters who have contributed to making this event possible. Medtronic, J&J, Lotus, and others, without whose support we won't be meeting here today. Finally, I want to apologize to anyone whose names I have missed and have facilitated and helped in this event, and all the deficiencies that you could identify were mine. Thank you very much. So now we have the winners of the quiz, poster and paper. I would like to invite Dr. Ram and Dr. Manas to give away the prizes. Mayur, you can also join. You guys have been behind the scenes. Please come up. So the poster winner to start with, so PGs have participated in a very encouraging and enthusiastic manner. Thank you, all of you. Often you do keep doing the thankless jobs that we leave you with, and you guys don't have an opportunity to complain also, so good job. A poster winner, Dr. Riya Doshi from GCS Medical College. If she's not there, can somebody... Okay. Paper winner, Dr. Harsh Patel. Are you Harsh? I will take you a prize because I permitted you to think it yesterday. Just to encourage encourage you, our light-hearted comments aside, collect data and present their series, because if you go outside Gujarat, nobody will accept your posters. Believe me. We need and even case series are retrospective and they are low quality data. Nevertheless, let's begin here. I would like to congratulate Dr. Karan from Narendra Modi Medical College, who took the pain of presenting a case. Quiz. Winner is BJ Medical College Team 1. Join us for high tea and let's hope to meet again sometime very soon. Thank you.